These classmates and old friends, they never let you get bored and they're always by your side to work. Therefore, that is the importance of your friends. As you grow old, automatically your friends' number will decrease. But always keep in touch with your friends. We have the three friends. Always we are in touch with. You can call us as three wise persons or three idiots. I don't know. That depends on you. But we enjoy our time. We laugh and laugh. Now, if we read one book to keep your wellness right in front, then choose this book. Bhagavad Gita, the only book which has got solutions for every problem of life. Read it daily, you will understand. If you don't understand, please call me, I will make you understand. Karmanevadikaraste mahaphalesu tadasana. This is the only verse that everybody should display it in their drawing room, in their clinics, and in their bedroom. Because if you perform work, the prescribed work, then you can never fall ill. That is the theme of it. In Astabhakra Gita, it is being written that worry gives rise to suffering and nothing else. One who knows into it definiteness becomes free from worry and becomes content and remains well. Then what the books say. Books are the medicine for you, for your soul. They heal the internal part. Reading is healing. Your friends now laugh. It is the fact. More than 30 years ago, Norman Persian, a successful journalist and editor, suffered from such a neuromuscular disease which was incurable. When he knew that I am not going to be cured, then why I should think of it? If negative emotions can make us sick, maybe positive emotions, especially laughter, can help us heal. So the lesson is laughter is not just good for the soul, it can be good medicine to learn to laugh. There is nothing in the world so irresistible and contagious as laughter and good humor. Laughing is and always will be the best form of therapy. Now, regarding psychosexual health, which is least discussed during the menopause, we discuss it. But the important thing is, aging is inevitable, but sex has no expiry date. Nobody can deny. Even at the age of 80, whether he or she is leading a sexual life, free and successful. The only magic pill for women's sexuality is broad spectrum freedom. Now it is given to the woman, the empowerment. Sexual activity must be widened, not that only penetrative. Postmenopausal age is an age of compromise. Therefore, I preach these three rules. 1 hour a day keeps all the illness away. Regular and rhythm, don't miss the routine. Regular is the two different vitamins, vitamin R and vitamin T. R for romance, T for touch. Then only you will see what is the difference, how well you are. Then comes mission. Nobody thinks about mission, only medicines and medicine. So mission if you have, then definitely your age will pass. So what is my mission, you can ask me. My mission is to be ladder of success. For my next generation, my students to climb up. And they are my students climb up with me and they grow and they grow. I'm happy with that. That is my mission. So dear friends, my mission is now it is I have achieved 28%. What does it mean? I have fixed my mission that I will motivate 100 batches of students in different medical colleges pan India. Up till now, I have completed 28 batches. So, I mean, milestone for me. If I keep a mission like that, definitely I will never forget. I will also suggest you, I may not advise you, suggest you fix your, I mean, your mission and vision and enjoy your life. I am not touching therapy because so many people are doing that. Try the best medicine is that if the physician motivates the patient and treats the patient in such a way that the last advice is try not to take medicine is the best medicine and is the best medicine. So we have seen the evolution of medicine, how medicine started. 2000 BC is the thought. 1000 BC, then the root is there. 800, 1850, prayer. In 1940, the potion is snake oil, swallow the pill. 1985, the pill is ineffective, take the antibiotic. In 21st century, now everything is artificial. Now let us come back to the roots and nature. Therefore, I am not talking about medicine in menopause. Definitely, the medicine which is panacea today will be a poison tomorrow. I write it. I am giving you writing. Whatever medicine you are prescribing for menopausal illness, that will turn to be poisonous after few years. You say that medicine is banned. That is, you have seen so many analgesics. You have seen so many antacids, ranitidine, so many common things that are being the history like that. So I'm not going to that. The greatest medicine of all is teaching people how not to need it. Already I have told you. The placebo effect of like me or hate me, either you can love me or you can hate me. In both ways, it is in my favor. As Vivekananda says, if you like me or love me, I am in your heart. If you do not like me, hate me, I am in your mind. Whatever you may be, I am with you, I am with you. Thank you, madam. Last, there simply is no field that can replace human connection. There is no pharmacy that can feel the need for compassionate interaction with others. There is no panacea. The answer to human suffering is both within us and between us. Therefore, let us, we should be responsible for the wellness. We do not blame others. Let us pray, Lord God. सर्वधर्मं परित्यज्य मामेकं शरणं व्रज अहं सर्वपापेभ्यो मुक्तिं नास्ति. Now where there is no answer to any problem, just surrender, surrender and surrender. Jai Jagannath, please stand up and pray, Lord Jagannath. Hey Lord Jagannath, जगन्नाथ हो, किसी मागू नहीं तोते, धन मागू नहीं, जन मागू नहीं, मागुची सरधा पाली रुहात. I don't want anything. I just want a piece of land in front of the temple. Thank you very much for patient hearing. The horn may not be full, but the quality of the listeners, the quality of the audience is awesome. I am very much thankful to you. I do not know whether you like it or not. Thank you. Thank you very much. Thank you. Most of the chapter has gone through several effects. Very tough topic to understand. I think everybody has to enjoy it. That is the night to justify the talk. Thank you very much. Now you will be thought and you get enlightened of many things about that. Now I invite our next speaker, no other than Dr. Sindhu Nandini Tripathi. He will be talking about, I know every knows Madam, so time Japan, India, Madam is a academician. He likes the doctors who are actually real academics and we want to promote academics in all seminars. We were professors in all physical.
My dear delegates, my dear students and grandstudents present here.
So, just to be a subject of control. So, let me one lady asked, tell me class, tell me true. Of all the ladies in the world, who is the most beautiful feminine? And the class answered, thou art the most beautiful lady in the world. Yes, well, you were too busy with this thing and that thing. Then you stand before the mirror and ask the same question. The mirror answers, thou art fair and beautiful be, but now your daughter-in-law is lovelier far than you are stuck and realize that you have arrived at the inevitable menopause. Menopause was classified like this previously, but in 1995, for the first time, Dr. Antarsaria named them as stage 1, stage 2, and stage 3. Later on, he divided stage second into A and B. The first standardized classification closed in July 2001. A follow-up workshop stopped last 2010. After that, it stopped. We are not having any classification that was destroyed then. We are doing it. Life cycle, menopause, perimenopause, menopause, postmenopause. A woman spends one third of her life in postmenopausal period. This time is becoming common economic. This is a beautiful period in a woman's life that is utilizing properly. From the time Homo sapiens invented the earth, the women were having menopause. Nobody has to worry about it. I'm talking about it. The reason is plain and simple. Because you see, when you get independence, our average longevity was 40 years. Child marriage, first pregnancy, adolescent girl, pregnant, first wife died in childbirth, second wife in puberty, she was also adolescent girl, third wife was a Sahara tree, and we are the grandchildren of the fourth. So, what is the time for menopause? Now, longevity has increased. More than one third of the life the woman is spending after menopause. For most women, there is no life. Why? Myself and most of you sitting here, then you get never knew what the menopause women and we are standing. My study, 30% of women suffer from menopausal syndrome, and most of in India, 30 to 40%, but in Western countries, they are giving 70% women are menopausal syndrome. That I got. Most women suffer from heart pressure, excessive sweating, depression, loneliness, emptiness syndrome, and feel neglected. Frequency of misdirection is a heart problem, means which is coming, I think, health themselves. So, don't get to that's how the body problem is life. But now, he is coming midlife crisis. Life has many phases, he has got studied. The other day, still my old student came to invite me for our daughter's marriage. He was pretty good girl with good manners and always dressed decently. But I could not believe my eyes seeing her mimicking the adolescent girl in such a vulgar way. I also see our Babu in a function, the same thing. The hairstyle of adolescent boy with patch, jeans, and an awful color shirt. The Lucknow, the Kharabpur society suffocates them. They just want to defy it, and there we have now man of midlife crisis here. So, this word was coined by 1965, and this is a very good and strong 35 to 55 years old age, and since can
whether should avoid this at any cost. You see, 45 years, how late is what? 50 or something. Depressed, left to herself and 72 years. She's a lonely woman. Like really, the beginning at 40, up until then, we are just doing research. Never 50 and 70, I think really. So how will you manage this menopausal health sector? Now, one thing comes to our knowledge that is salute genetics. Most of you must not have it, but this gentleman has told that stress is the main factor for this menopausal syndrome, and if we can manage stress, then we can promote this. Self-recognition is discovered in 2012, only mentioned a para-impact textbook of community medicine. So this is a new theory which has come and shaped and is very much popular. But everybody thinks that if they take care of the health, then this menopausal health will not be there. So health has got four legs, all of you know, physical, social, mental, and spiritual. And physical health depends on two things, one is nutrition and another is exercise. And nutrition is the best thing, and in brief, balanced diet is best for all of you. Came COVID-19 and each one of us became a immunity specialist from Kada to Jogo to exercise to shifting to oatmeal, etc. The very best way to stick to a balanced diet, low carb. And drink to your health, water 3 liters at least. And tea is not bad for your health if you take 2 cups of tea every day. Exercise, aerobic, energetic, so many things. And you may not be knowing, climbing the staircases is the best exercise for a old woman. And morning walk is the best. In every walk of nature, one visits far more than 50. And if you are in the morning for 30 minutes, you are working with your partner, the day is done. Nothing to worry about. Keep psychological equilibrium, gaining new friends. Suppose you don't have new friends, at first internet, that is a very good thing. How it helps? It prevents osteoporosis, increases the cellular DNA, tones of the whole body, increases eyesight and immunity, prevents weakness. The best treatment for obesity is morning walk. And in the morning, the sun rises, and from Vedic era, you pray for जब कुसुम संता संता सपना महादुति धनधन सदसा सपना बहुत श्री विराट. These are not miracles, but scientifically proven by working circulation increases, endorphin is secreted, cellular increases inside, and definitely the lifespan increases. Social health is the best thing for the health. Menopausal health sector. Human beings are social animals. Having good social health helps people improve their emotional well-being and feel supported in their daily life. Similarly, you cannot tell your colleagues, your relatives, to keep your social health in good condition. When you go to the office, when you are in your family, they include more rates of anxiety, depression, higher self-esteem, better empathy, and more trusting and cooperative relationship. Mental health, that is this is a menopausal health sector. So what we should do? The mind is in so stress, and instead can make a heaven of hell and a hell of heaven. That was told by Milton. And mental health includes our emotional, psychological, and social well-being. Mental health is important at every stage of life, from childhood and adolescence to adulthood to menopausal age. So karma is rich in strength and self-confidence, so that they are very important to do. And then comes our spiritual health. So many things Dr. Saro talked about spiritual health. Spiritual health is a state of being where an individual is able to deal with day-to-day life in a manner which leads to the realization of one's full potential, meaning and purpose of life, and happiness within. Some common criteria that fall within the category of spiritual health include belief in a supreme being. He may be Lord Jagannath, he may be Allah, he may be Jesus. Unity is a great force, a guiding sense of meaning and value, and ultimate religion, balance, introspection, and meaning. To achieve spiritual health, yoga is a medium, all of you know, and yoga is our ancient thing. Yoga and exercise are not one and the same. Exercise only physical value. Yoga is spiritual value is limitless. And this has been included by WHO in 1978, then first pillars of health. So Patanjali's Ashtanga Yoga means Patanjali's Ashtanga Yoga, and Dhamma, Gandhi was practicing very much, Niyam, then comes our asana. We think that yoga means this asana only, but that is not so. It includes dharana, it includes pranayama, pratyahara, and it includes meditation. Meditation means you realize yourself inside and who I really am. That is what in meditation. And samadhi, most of us cannot do because we have not got to that level. So this is the yoga. And the biophysical, mental, and spiritual benefits of yoga are gaining popularity among all age groups and all over the world. And now we are celebrating 21st June as International Yoga Day. In my opinion, if a menopausal woman follows this Dhamma, asana, and meditation, that will be more than sufficient to overcome the roller coaster. The concept of integrated health is now emerging, and many doctors and patients are going for it. It is the concept of Sri Aurobindo and Sima. The measures I have described here for all human beings, both men and women. Women require little more attention from the healthcare providers in the whole life cycle, which encompasses menarche, reproductive years, and menopause. And the key figure is the obstetrician from whom to start. And we are simply means we need some spiritual health. The simplest way it can be advised to show morning, to go to temple whenever possible, to read scripture and read books. No things about by prayer than this world brings us. Whatever religion and observation belongs, it does not matter. So implementation of the fourth dimension menopause is very, very important. And as a medical teacher, we can implement it. As a healthcare provider, we can implement it. As a healthcare planner and administrator, we can do it. As a policy maker and lawmaker, whose vision and will matters most. Meditation knows particular more than 50%. On the other hand, it increases serotonin and dopamine secretion. Alternative reproductive medicine, naturopathy is there, and Ayurveda is there, then comes homeopathy, then comes yoga and meditation already I have told you, and then we have many pathies, allopathy, homeopathy, yogathy, naturopathy, but everywhere one pathy is required, that is sympathy and empathy. And hormone replacement therapy, so many things we will discuss. So I'm not going into detail to this, but just we can know all the estrogen and progesterone can do, we can use conjugated estrogen, mostly used in menopause women. So it can be given by different groups. And less than 60 years, within 10 years of menopause, effective gives the best results. Quality of life and all other parameters improve, more so the emotional problems. Since the discovery of estrogen at that status, the need makes it more challenging. After 16, all the materials available today, I still think for women who are really vulnerable with postmenopausal symptoms, I would recommend it. Whatever you may say. Alternative to HRT are also many that we will be discussing throughout the day. Supportive therapy to hormone therapy is also we will be discussing. Another rule of good health is the modern cooking or in the same consultatively obstetric natural and homeopathy that also does some work. And Ayurveda is almost similar to our whatever we do. Phytoestrogens are very, very useful one that all of you know. And meditation is the only thing which postmenopausal women can do and come out of the health. So, fourth dimension, the question was asked oneself, who am I? Where am I? What can I do? What is my power even in adversity? So, part of the secret of getting out gracefully is vitally linked to the value and belief system. Lifestyle modification, it is no way different from old age. This is a recent concept of making life beautiful in the old age. It was introspected in 1987 by Rare and Pearl. Avoidance of disease and discovery, maintenance of high physical and cognitive function, sustained engagement in social and productive activities, requires one's health high should be prepared. Outcome and outcome. So prepare a will when you enter the old age. As a doctor, keep reading, teaching, and treating. Attend family and social cultural functions. Keep updated in recent advances. Keep yourself connected by the society. That everybody should think that whenever women should come and stand. Don't demand respect and service in respect of your age. Feel into that, try to serve the society and try to what society has given you. You cannot stop aging. You should have a holistic approach towards menopause. It is never too late to be what you might accept menopause. Don't buy the life, hide your culture, loss of sleep, loss of beauty, loss of outcome. Try to manage them naturally. They are the signs of your past knowledge and experience. The husband must accept her menopause and change her mindset. To conclude, the role of postnatal menopause is not difficult to manage. The knowledge, the conduct, change and develop a holistic approach to the lifestyle management and should be tailored to meet the individual needs. A caring husband, loving children, supportive society with an empathetic physician will go a long way to brighten menopausal emotional health respecting women. Life is swift, change lifestyle, be a optimist and enjoy it. It is never too late. Enjoy this, then plenty of time to be sad. If they can, why not us? Let us revive our old custom. Growing old is natural, but feeling old is not. I never feel old. Positive attitude of menopause. There is no more effective force in the world than the menopausal woman with just may the great Lord Jagannath bestow his blessings on the menopausal woman to lead a healthy and youthful and peaceful life. So the minister, we obstetrician, let us incorporate this spiritual practice into our life. We do not have time in our busy clinics. A detailed pamphlet is a means of reaching them. So you cannot, counseling is good, but you cannot have it. And when I was working in the city center, horror was the specialist. We made many pamphlets for everything and distributed because at that time also we were not having time to consult each and every person. Let us utilize all the experience of the menopausal women to build a new society. If Mrs. Gandhi can lead a country, Subharakshmi and Lata Mangeshkar will sing at the 80s. Mother Teresa will serve the country at the fag end of her life. Why not we? Let us not add years to the life, but life to the years to live. That is a quality life. We celebrate World Menopause Day at October 18th. Raise awareness. I am very grateful to my husband, Dr. Vasim Tripathi, for standing before you. And the omnipresent, the omniscient, the omnipotent Lord Jagannath bless the menopausal woman and all of us. Thank you. Thank you. For giving me the opportunity.
Patrick. I think he's a teacher of all of us.
Hello. ঠিক আছে হ্যাঁ হ্যাঁ ঠিক আছে ঠিক আছে
Now request
ହଁ ମୁଁ ଦେଖୁଛି
Dr.
ଇଭେଣ୍ଟ
Sudha
ଅଛି
Sharma
ସକାଳେ ରହୁଛି
to
ସକାଳେ
deliver talk on menopause, what your
ଇଭେଣ୍ଟ
heart
ଯେଉଁ
says.
ସରିଥିଲା ସେ ଇଭେଣ୍ଟ ସବୁ ସେଟଅପ୍ କରିବା ଭିତରେ
Dr. Sudha Sharma.
ଲେକ୍ଚର ସରିଲା ପରେ ତାକୁ ପଠଉଛି ହ୍ୟାଲୋ ଫ୍ରିଜ୍ କର ଆଉ କ'ଣ କାମ ବାକି
A
ରହିଲା
very
ମୋତେ
good morning,
ଏ ଆଉଟଡୋର୍
everyone.
ୟୁନିଟ୍ଟା ଛାଡ଼ିଦେଲା ପରେ
Good morning, Bhuvneshwar.
ହଁ
Dr. Harai, you made my job so difficult. Speaking after
ଆଡ଼ଜଷ୍ଟ
two star watch is not an easy
ଆଡ଼ଜଷ୍ଟ
task.
କାଲି ହେଲା କେଉଁଟା କ'ଣ
Heart, some interesting facts. Human heart goes through childhood, reaching its full size when child stops growing. Our heart beats about 100,000 times in a day and more than 2.5 billion times in lifetime. Is there any connection? कभी कभी मेरे दिल में ख्याल आता है तुम होती तो कैसा होता तुम होती तो वैसा होता तुम ये कहती तुम वो कहती. What is this all has to do with our hearts? Our emotions and feelings, they have diverse effects on autonomic nervous system, which can result in changes in heart rate, variability and contractibility, all because of release of cortisol and adrenal rush. So these emotional feelings are the same for both men and women. Their hearts beat in a similar way, but there is a difference in male and female heart and their cardiovascular system. Premenopausal women are at lower risk of having CVD as compared to men of similar age because there is a protective effect which is attributed to estrogen. And we all know this protective effect of estrogen on heart is because of various mechanisms by improving lipid and carbohydrate metabolism, regulating coagulation fibrinolysis, regulation of gene expressions, positive effect on endothelial cell function, vascular smooth muscles with anti-thrombotic antioxidant effect. It promotes and maintains glycemic body fat distribution, improves glucose and insulin metabolism, and also displays anti-inflammatory effect through cytokine production. Now, this protective effect ceases as she enters into menopause, and risk of developing CVD becomes twofold higher. So, women tend to develop CVD about 10 to 20 years later than men, but this 10-year advantage is lost in case if she has premature menopause, she is diabetic, dyslipidemic, or has history of smoking. So CVD is the leading cause of death in women, especially after menopause, and you know, coronary heart disease develops several years later than men. What are the characteristics of menopause which are relevant to CVD risk? These are age at menopause, type of menopause, menopause staging, endogenous estrogens, menopause-related symptoms, and menstrual irregularities. Women experience menopause at 50 to 54 years of age, have lower risk of having fatal coronary heart disease
than women who experience it before 60 years. Type CBD is substantially high when bilateral sulfonylurea is performed younger age less than 40 to 45 years of age. Menopause staging, you know, there is significantly higher systolic blood pressure and diastolic blood pressure in late menopause transition. Carotid intima media thickness increases, and there is increase in aortic pulse wave velocity in women who are transitioning into menopause rather than who are premenopause. Endogenous estrogens, higher estrone levels, they are related to higher brachial flow mediated dilation and better endothelial function. Vasomotor symptoms. The females who report vasomotor symptoms at midlife, it is linked that they can have adverse lipid profile, insulin resistance, increased risk for incident hypertension. So, that's when a study was showed that all those females who had vasomotor symptoms, they had higher, carotid intima media thickness than those who reported no heart machine. Sleep disturbance, significant association of objective measures of poor sleep quality with increased risk of metabolic syndrome, both carotid plaque and CIMC. So self-reported poor sleep quality has been independently linked to an increased risk of aortic calcification and arterial stiffness in perimenopausal females. Again, it has been shown that the impact of menopause status on association between subjective measures of sleep quality and cardiovascular health, which has been measured by American Heart Association Life Simple 7 scores. So they have seen that shorter sleep duration, poorer sleep quality, great severity of insomnia that was associated with worse AHL Life Simple 7 scores in postmenopausal females. Depression. Depressive symptoms during menopause transition also have been strongly linked to increased CVD risk. Menstrual irregularities. It has been well established that irregular long menstrual cycles are closely related to insulin resistance, metabolic disturbances, hyperandrogenism, chronic inflammation, mortality, obesity, type 2 diabetes. So CVD has been reported to be the most important cause of death in women in India, especially in midlife age, reported by Registrar General India Ministry of Home Affairs. And also a report from US National Mortality Record of six largest patient subgroups from 2011-2023 revealed significant differences in cause, specific death with highest CVD death rate amongst Asian Indian women. There are certain women's, cardiovascular health life simple seven score at midlife current status. And what are those? BMI, physical activity, smoking, diet, cholesterol, blood pressure, and fasting glucose. BMI and adipose. It has been seen that prevalence of obesity is higher amongst middle-aged women, so higher central obesity, higher risk of mortality. Physical activity, more than 150 minutes per week of moderate intensity or 75 minutes per week of vigorous exercising, and the risk of all-cause cardiovascular mortality increases if you have more than 8 hours per day of sedentary lifestyle. Cigarette smoking, we all know, compared with women who never smoke, smokers have increased risk of CHDL stroke and mortality. Diet, night nutrient components have been seen. Fruits, nuts, white red meat, cereal, trans fat ratio, polyunsaturated oat saturated fatty acids, multivitamins, and etc. Cholesterol. Sorry. The prevalence of LDL more than 130. Again, the blood pressure with every 10 degree millimeter mercury increase in systolic blood pressure, there is association of 15% increased risk of CVD for both men and women. Fasting glucose, diabetes is a stronger risk for CVD mortality we all know in women than in men. Menopausal hormone therapy and HR. Because estrogen protects CVD in premenopausal women, with the same idea HRT was being prescribed was taken on counter also from 60s to 80s, thinking that menopause is a hormone deficiency state, it is curable and preventable. So the dictum was take HRT, you will be feminine forever, you will be healthy forever. Till 2002 when Women Health Initiative study and first trial, they came and it was declared, it was documented, it was recommended that no HRT for primary or secondary prevention of cardiovascular disease. But if you start MHT before 60 years, within 10 years of final menstrual period, it has a protective effect on heart. And this protective effect stems from beneficial lipid modulation as well as estrogen's favorable action on endothelium and respiration. Because as compared to older women, women in this age group, they tend to have a better baseline cardiovascular health, lower CVD risk, low coronary artery tension scores. So please give MHT if needed. Don't deprive these females of MHT. So what is the best route of administration and MHT formulations for heart? Most recently, two large case-controlled studies using research clinical practice guideline database in UK, they have evaluated the association between MHT regimens and risk of VT. So oral MHT was associated with increased VT, whereas transdermal was not. CEE was associated with higher risk than estradiol. CEE plus MPA had higher risk. Estradiol and dydrogesterone had the lowest, whereas micronized progesterone was not evaluated. So what are the current guidelines and considerations on cardiovascular disease preventive therapies in women according to American Heart Association published in Circulation 2023? Journal guidelines recommendations. Encourage optimal blood pressure of less than 120 80 millimeter of mercury. Lipids encourage optimal lipid levels, LDL cholesterol less than 100 milligram per deciliter, HDL more than 50, triglycerides less than 150, non-HDL less than 130. Aspirin in individuals with cardiovascular disease unless contraindicated, smoking cessation, diet emphasizing intake of vegetables, fruits, legumes, nuts, whole grains and fish, diet limiting consumption of saturated fat, cholesterol, sodium, processed meats, refined carbohydrates and sweetened beverages, exercise 50 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity aerobic exercises. Additional cardiovascular benefits with 300 minutes per week of moderate or 150 minutes per week of vigorous intensity aerobic exercises. Weight loss or maintenance. So maintain or achieve an appropriate body weight through comprehensive lifestyle interventions. Higher level of physical activity is recommended to maintain weight loss. Environmental exposures, assessment of exposure to environmental hazards, living near a highway, regulated private well for drinking water, house built before 1978, and recommendations which are based on cardiovascular risk. So friends, if we really want to make this phrase, dil to bachcha hai ji, during menopause and old age, a truth, we need to follow certain guidelines and healthy lifestyles. Otherwise, it's a myth. So, what are those heart healthy lifestyle choices according to assessment health? Stop smoking, stay active, eat right, maintain a healthy weight, know your numbers, blood pressure, lipids, everything, and take medication as and when required. So heart is the same, beats in same manner, but feels differently when different emotions different when you have love for family. So different when you have love and passion for Indian menopause society. And this is beloved part. Excuse me. This video, the audio. So you are under cardiac arrest for stealing away my heart. But the loveliest masterpiece of the heart by God is the heart of the mother, which is her child's school room. And this one is a small poem written by my daughter, Dr. Shabi Mahajan, who is a breast cancer surgeon. Mother's heart is the sanctorum of the divine temple. Go to thee and worship it, to experience blessings from the cosmos, creating miracles beyond your imagination. Thank you very much.
Thank you, madam. Thank you for your beautiful presentation.
Thank you, ma'am. Now I could request the chairpersons to felicitate our speakers. Dr. Gangadhar Sahu, sir. Dr. Sindhu Rajani Tripathi, madam. And Dr. Sudha Sharma. I would like to felicitate our chairpersons. For that, I would request Professor Dr. S.T. Mahapatra, sir, to kindly felicitate.
ন্যাশনাল অ্যান্থেমটা বলা বলছি କିନ୍ତୁ ଆଇନ ପାଇଁ ଆମେ ଆସିନାହାନ୍ତି ବଜାଇବା ପାଇଁ ସାଉଣ୍ଡ ଦେବା ଆସୁ ପବନ ପ୍ରୋଗ୍ରାମ ଅର୍ଥ ଆସେ ମିଶନ ସେ ନ୍ୟାସନାଲ ଆନ୍ଥେମ୍ ଦେଇଦେଇଛନ୍ତି ହଁ ଆସିନାହାନ୍ତି ଟେଷ୍ଟ କରିବାକୁ ଟେଷ୍ଟ କରିଦେବେ ଆଉ
Moving on to our next academic session. Yes, sir. Thank you, sir. Moving on to our next academic session, I would invite Dr. Dilip Gargavi, Secretary of IMS Ahmedabad, past President Ahmedabad Society of Obstetrics and Gynecology 2014-15. Sir, kindly come, please welcome to the dais. Dr. Sangamitra Mahapatra ma'am, former professor and head of MKCG Medical College, Barampur, Orissa, and President Barampur
এটা অ্যাপে
ONG
হচ্ছে জুম পে
Society. And Dr. Indira Palu ma'am, Associate Professor, MKCG Medical College and Hospital, and Secretary, Barampur ONG Society to chair the session.
ଆସିଲେଣି ଆସିଲେଣି ରାଗିଣୀ ମ୍ୟାମ୍ ଆସିଲେଣି
I would also request Dr. Sarla Nihalini ma'am, if she has reached. Yes, ma'am. Please welcome to the dais, ma'am. She is the clinical director and co-owner of Convert Hospital with a vast 32 years of experience in emergency obstetrics to come to the dais.
Hello, hello. Backdrop.
Good morning. I'm Dr. Dilip Reddy from Ahmedabad, and I'm thankful to the organizing team of this Odisha Society for giving me chance to be here as a chairperson of this session. I'm extremely thankful to Dr. C.C. Mahapatra sir, Dr. Mahapatra sir, one is sitting in this audience, my near and dear Dr. Harabai, Dharmendra Bhai, Mrityunjay Bhai, because we always Gujarati used to speak Bhai and Bahan. So that's why we always know him as a Harabai. It's a great event organized by the whole team, and I understand the pain which they have taken for organizing this event. One of the most important scientific sessions so far as human life is concerned. See, I'm speaking all this because in my session, one speaker is not there, so I will end up little bit time as a chairperson of this session. So, सर गुलजार साहब की बहुत अच्छी शायरी है कि मैं दास्तां सुनाते गया और वो शायरी समझते गए और वाह वाह करते गए. The same has happened in the life of the woman. When you are telling about your pain, they understand. She is telling, it's all right, it's okay, it's okay. So आप कभी दर्द की भी दास्तां सुनाते हो तो लोग यूं ही देखते always take it lightly. This is what happened in the life of the menopausal and perimenopausal period of the woman. And that is what we are going to discuss here, why it is happening and what we should do, what we can contribute to the society for the betterment of all those women who are suffering from the menopausal symptoms. And for that we are here. And I'm thankful again to Dr. Ravi. Please thank you. Now I'm handing this mic to the speaker. This session, our first speaker is Dr. Omar Rahman, physiology of the ovarian aging. So the ovary is a, not ovary, it is a matter of worry. When a girl is in minority, if she is not getting period, that's a matter of worry. If she is in a midlife and having a PCOS, then also problem. In the menopausal, if the ovary gets enlarged, then it is a matter of worry. So ovary is not ovary, it is matter of a worry. Yes, madam, please come.
Good morning, respected chairperson, the delegates, dignitaries on the dais and off the dais. I thank the organizers for giving me this opportunity to speak in a forum which is not my department from OG. So thank you very much. And my mentors such as Sujata madam, Sasmita madam, Bhagya madam, I have done so many work with them. And Hora sir, thank you sir. Today I'll be speaking on physiology of the ovarian aging. As we understand that aging is a universal process, all of us will go through it. And it drives the progression of multiple organ disorders. And why this topic is important today? Because by 2050, India won't be a very young nation that we claim as on today. We will be having a global population of above age 65 years and older, which would be more than 2 billion, and that would cost the healthcare facilities quite a lot. So we have to investigate the factors underlying aging, age-related diseases, which are crucial for prevention and treatment strategies. Now today, when we think of one nation, we have to also think of prevention is better than curing. So what happens when the ovaries age and they age earlier to the other organs? There is both a decrease in follicular quantity, quality, and there is a fluctuation of various hormones. This would lead to infertility and an early menopause. Now, as we understand, the number of primordial follicles peak during gestation and declines in a non-linear manner, giving more than or even less than 1,000
by the time a lady attains menopause at the age around 51. But as research and various statistics proves, there are many ladies who attain menopause even way earlier. So during menopause, the decline in ovarian follicles lowers inhibin B, promoting the anterior pituitary to secrete FSH to boost the estradiol production, but it doesn't happen as the ovarian function has declined. Though there is a high level of FSH, the estradiol levels do not increase. Now, since estrogen receptors are almost in every organ, their non-availability and non-availability of estrogen leads to various diseases affecting almost 10 systems of our body, including um, cardiac, osteoporosis, respiratory, endocrine, motor. I mean, there's not a system, including decreasing immunity, digestive system, reproductive system, everything gets affected. So, what are the life stages of ovary and the female body? To address ovarian aging and its related diseases, it is crucial to identify the etiology and the risk factors contributing to this process. Genetic variations of certain genes um, and lifestyle, which includes increased physical activity, significant weight loss or weight gain in a very short span of time, smoking, vegetarian and high carbohydrate diets, excessive intake of lipids, all these contribute to endocrine disease, including using of too much of cosmetics. So as we understand that humans have a very limited reproductive lifespan, so with progression of career and the biological clock ticking, it is difficult for women to manage. Now here we see the oocyte dynamics that at birth there is quite a large number of germ cells, and as we reach menopause the decline is remarked. So what is the current model of follicular depletion? As you understand, there is genetic abnormality, there is altered lifestyles, all these affect the mitochondria, which gets impaired, release of lot of reactive oxygen species, lipid peroxidation, and oxidative stress, which also enhances or the present lifestyle increases this decrease. So age, loss of reproduction and loss of reproductive success as we go towards IVF and other assisted methodologies of reproduction. So along with age, there are other determinants which cause menopause, such as the age of the first childbirth, age of the last childbirth, age of menarche, alcohol use, body mass index, coffee consumption, ethnicity, OCPs, parity, physical activity, family history, and NCD diseases such as diabetes and hypertension. So this can cause a premature failure of ovaries. Almost 90% of the etiology is unknown. So we are beating around the bush thinking that one of these causes could be contributing. Here again, these factors and the genetic characteristics that are there, which need to be explored, they cause a premature ovarian insufficiency, which is a woman attending menopause in less than 40 years, or an early menopause, that is 40 to 45 years, and the proper menopause, which is around 51 years of age. So here we have certain genes which can be explored in case of a premature failure. So what are the characteristics? Here we have decreased fecundity, decreased oocyte and embryonic yield during an IVF, increased embryo aneuploidy, decreased embryo quality, decreased IVF failures. Age is one of the greatest enemies of the IVF experts. So how do we assess the ovarian age? Um, that can be assessed with certain biochemical markers. We can assess by ultrasonography. We can do a dynamic assessment. And here, while doing the biochemical assess, one of the favorite biochemical investigations that most physicians order is the serum AMH. Now, AMH gives you um, the amount of ovarian reserve that is present, and since it is an age, it is the favorite test, along with some specialists also order an FSH. But if we compare FSH and AMH, I would rather say that AMH is a better marker, because FSH levels may be high even when the ovary is unable to respond, uh, and the estrogen is less. So what we can do, we can do a direct measure of ovarian function, less inter and intercycle variability, not much affected by the hormonal medications that is being given to the lady, and it slowly declines along with the egg numbers or the population of the eggs in the ovary. What is the clinical utility? Here, the diagnosis of patients with low ovarian reserve, screening of PCOS, triaging patients in and out of assisted conception treatments, and individualization of controlled ovarian stimulus protocols. So with this, we can go ahead with the future research where we can think of, can gene therapies, medication, and lifestyle modifications along with environmental improvements may affect and slow the ovarian aging. We need to work on that. What is the interrelationship between ovarian aging and age-related other diseases, where we understand that estrogen receptors are there in almost all organs of the body, and when they are not there, there is a mild inflammation sets in, and there happens this NF-kappa B gene activation is there, which further leads to release of cytokines, which can increase inflammation. And in the morning, most often, menopausal ladies would feel there is a crack, there is a pop, there is a pop sound in the joints, and they may not feel like more ladylike, they would rather feel like a packet of Lay's chips. So here we can work on it. And then, can there be therapeutic interventions targeting both the ovarian aging and age-related diseases, which aim to facilitate clinical translations and anti-aging processes, which is the biggest industry at present. Thank you. Thank you for listening to me.
Thank you, Rama Madam, for giving a deep insight into the journey of oocyte from womb to term and healing the ovarian aging. Thank you, Rama Madam, again. We have a lot of connection during HPV testing. I met you and you told me a lot of things for Parampu, and this is medical field for the HPV testing. You helped me out. Thank you, Rama Madam. Now, I would like to invite Dr. Jyoti Jaiswal Madam, and she is from my Raipur, and she is a good academician and all-rounder, and we invite you, madam. And madam's topic is body's thermostat at menopause.
Thank you, Sarla ma'am. Good morning, everyone present here.
टाइमर
Uh,
स्टार्ट कर दो
as Dr. Sarla said that I am from Raipur, the city where Vivekananda has spent her 2 years of life, and I bring greetings from the Raipur Menopause
नहीं
Society,
10 से रखो
each and every member from
नहीं
that
नहीं
society.
10 करो
Yesterday, Rangadhar Sahu sir said when
कहने से
you
खबर पूरी
reach
ले
to
लीजिए
be pray for all, and he blessed me for his blessing to have a good journey, and with his blessing I got the blessings of Lord Jagannath. So Jagannath और भोलेनाथ दोनों की कृपा के साथ I will like to start my this lecture for with praying for good health and happiness and meaningful life for everybody. The topic allotted to me is body's thermostat at menopause. Let's discuss why we need to talk about this at menopause. Menopause, a relatively long period of a woman's life with changes started from ovaries and accompanied with biological, So, what are the most common psychosomatic problems associated with menopause? They are vasomotor disorders, mainly hot flashes, insomnia, mood swings, urogenital symptoms, sexual related problems, decreased libido, obesity, aches and pains, depression, and emotional psychosis. And I have bold them in red that the vasomotor disorders or hot flashes very cumbersome and they start even when the menopause not yet started during the transition period. So we'll discuss this only today. The women can, on a lighter note, can say that I am still a hot babe. Only now it comes in flashes. The only thing hotter than me, she says, that hot flashes in this and this coffee. So actually the hot flashes can have the negative impact on quality of life. So let us understand what is these hot flashes, why hot flashes started at menopause. Is altered or narrower thermostat responsible for this? Why thermostat get disrupted during menopause? Which hormone or substance is associated with this thermostatic regulation and what we can do for correction of it? So let us see what is hot flush. This is subjective sensation of heat and sweating, most notably on the upper body associated with objective signs of cutaneous vasodilatation, followed by a subsequent drop in the core temperature. It can occur any time, day or night. It can have a very short episode or episode longer for 10-12 minutes. It can recur with varying frequency. May be associated with sweating, flushing, palpitation, anxiety, irritability, and even sometimes panic. At the onset of hot flash, there is sudden increase in sweating. Some may experience even the fainting and dizziness. So think that hot flashes can be so cumbersome. The heart rate also gets increased. One can have tachycardia. It can increase by 5 to 25 beats. Initially, there is increase in the temperature in the fingers, and then neck, and then on face. Then sudden and rapid heat loss and a decrease in the core body temperature. So this is a coping mechanism when the heat developed inside, then how to cool the body. Intensity can be of mild, moderate, or severe type. Mild when only the passing of sensation of heat, but there is no sweating. Moderate when sensation of heat is there with sweating, but allows continuation of the current work, current activity. But it is severe when this, along with the sensation of heat, with sweating, that interferes with the continuation of the activity and lady says, अब मैं अभी कुछ नहीं कर सकती, I have to sit, and she gets restless. The incidence increases during late perimenopause. Sometimes they remain for the first 2 years on their highest peaks and then gradually declines. For some, it is only for few months, and for some, it can remain for years together, even after 10 years of menopause. The prevalence also ranges in a very wide manner. At some studies, the prevalence is only 19-20%, while in some studies it is up to 75%. Indian Menopause Society also has conducted so many studies, the pan-India study, where also the incidences are ranges differently at the different places. Worldwide study by the SWAN also they have given that African Americans are having the very high number of hot flashes, vasomotor symptoms, followed by the whites and Chinese, and the Japanese has the smallest number, nearly 18%. And maybe the diet, the more soy protein, etc., can be responsible for this. Still, the cause for this much variation, whether it is genetic related or it is diet related, has to further work upon. There are a few risk factors which causes these thermoregulatory disruption more common. The BMI is one of them. It was earlier thought that lean thin patients and especially who are smokers, they are most likely to experience hot flashes, and yes, it is very right that they have severe kind of hot flashes. But contrary to the belief, the new study found that hot flashes are associated associated with a higher BMI also. The thermoregulatory theory of body fat tissue act as a strong heat insulator, which makes distribution of heat more difficult. So whatever heat generation is there, so to cope up with that becomes difficult with the higher BMI as well. The adipose tissue acts upon the hormones leptin, promolactin factor 8. It suppresses the ovarian steroid production and it also may influence the thermoregulation. Race and ethnicity, as I said, the research in Japan shows that there are less incidence of the hot flashes and fewer hot flashes than the United States of America, Canada, and UK. Smoking, cardiovascular risk, and genetics can be very well associated with the hot flashes. And as Subha Madam said, that the patients are having a high risk, which are having hot flashes, they are having the high risk for the cardiovascular risk as well. The pathophysiology behind these thermoregulatory disruption and hot flashes are having unknown etiology for the many things. It is not very much studied till now. Very little research has been done on the subject, but it is uh, in the thought that thermoregulatory and neurochemical, both kind of disruptions are responsible for that, and this cause the changes in the hormone and their effect on the brain, which is associated with the autonomic nervous system and the vasculature. A simple thermoregulation is associated, like it is connected with the hypothalamus. Whenever there is the cold conditions, one can have the skeletal muscles to twitch off, then the goosebumps will happen and the blood vessels will get contracted. When there is heat perceptions, then the thermoreceptors will give the trigger to the sweat glands. There will be sweating, there will be the cold feeling, hair follicle muscles will get relaxed and vasodilatation will be there and they will be able to cope up with the increased heat. So this is normal thermoregulation. Thermoregulatory nucleus is located in the preoptic area of the hypothalamus and it is for maintaining homeostasis temperature in the body. So basically, these nucleus regulates core body temperature, which maintains it within a homeostatic range. So always there is a strip between the higher temperature and lower temperature where the feel of heat or cold can happen. So this thermoregulatory null zone has its own threshold, and this threshold gets decreased. It becomes very narrow at the time of the menopause, and whenever there is the threshold will cross, on the upside the patient will feel the heat and below it they will feel the cold or the shivering. Excessive sweating occurs at higher than the threshold point, shivering occurs below the threshold point. Now comes that why it happens at the time of menopause or transition. Is there any role of estrogen in thermoregulation? Yes. Estrogen stabilizes hypothalamic control of the body temperature, maintains normal set point of thermostats and serotonergic activity, and it inhibits norepinephrine mediated vasodilatation. So this complex pathology which we have discussed occurs. There is neurochemical disruption also, and estrogen appears to stabilize thermoregulatory dysfunction. Estrogen withdrawal, decreased level of serotonin receptors in hypothalamus, decrease in endorphin, norepinephrine, serotonin, and it lowers the thermoregulatory threshold and causing hot flashes. The latest theories are lot of research on KNDY neurons and these kisspeptin neuropilin B and dynorphin neurons. They are specific group of the brain cells. They are present in a very small population of the cell and have a role in the vasodilatation. These neurons are activated, they trigger for the heat loss mechanism, and these studies are suggesting us for the newer strategies to make out for the control of the vasodilatation. The CGRP, calcitonin gene related peptide, and the candy neuron, these are the two mechanisms. One acts at the central, second acts at the periphery. And the CGRP has been found higher in the women with vasomotor symptom. It causes vasodilatation and peak sensation. So CGRP may be the mediator of the vasodilator signals originating from the thermoregulatory centers. Blocking these CGRP action can potentially reduce VMS. So there is linkage, as I said, that KND9 neurons are the central drivers and they leads to the peripheral release and action of the CGRP. Uh, Investigations are not very much required for confirming the treatment for the vasomotor symptoms, but if one has the confusion, then one can go for the investigation and confirm that it is only menopause related and not because of any other reason of the vasomotor symptom. And the management remedies are including hormonal and non-hormonal. The lifestyle modification is the one of the very important and go ahead kind of management which should be given along with the others. The strategy to maintain the body cool is one of the important aspect to manage stress reduction, and exercises should be an integral part for the pharmacotherapy. MHT remains the most effective first-line therapy for vasomotor symptoms during menopause transition. It is also important, and Tibolone can be the second option if
Dr.
MHT
Jyoti,
cannot be there. Yeah.
Dr. Jyoti, please.
Sir, just the last. The fazolinitant can be the one of the new therapy which is under the research. These are the menopausal guidelines. We are aware of the non-hormonal things. For the summary, lifestyle modification, MHT, desloxetine, CE, paroxetine, that is SSRI, and fazolinitant on the way. So correct the body's thermostat, flush the hot flushes, bring the happiness in menopausal women's life. Thank you very much.
Thank you, Dr. Jyoti. I, I know her since last 15 years, and I wish her to be the first person from the Chhattisgarh to lead the IMS. Our next speaker is Dr. Ragini Agrawal. She is from Gurgaon. Because of some reason, she is not able to come here physically, and she will deliver her lecture online.
Switch करो मोरो 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 ना yes sound दे mic what is it
Somebody has to tell me, am I connected?
mic रे कौन mic रे
Should I start?
mic रे कौन
Yes, sir.
Screen sharing
Yes,
thing.
Dr. Ragini, we can listen you.
Yeah, I need a screen sharing rights. IT वाले देंगे. Host disabled participant screen sharing. I need a screen sharing. Very good morning to one and all. And it's a privilege to be with you all here today. Thank you so much, Dr. Hara Patnaik and Odisha team for giving me this opportunity to speak on a topic. इसको देख के लगता है क्या बोलना है, but I think it is the one of the most important topic when we go in detail because it gives us a insight to save the uterus of the woman. You consider that uterus has to be
कोई भी
removed
शेयर
by
कर पारे बोली कोई पीटी से कोई को
so I just starting my presentation that
कुछ
I got the
कुछ कर दो देखो जी
so with blessing of God and gratitude to one and all. The topic given is to me is the spectrum of disorder cycles in the perimenopause. Friends, we all know that menopause is an eternal truth of the life. And menstrual irregularities are often misinterpreted as pathology in menopause transition and can cause anxiety in women and confusion in clinicians. It is very important when a patient comes to us during menopause transition, we should evaluate properly
a normal physiology, or we are dealing with really some pathology. So consider perimenopausal irregularity as a physiology, not disease. It should be a dictum. As we all know that perimenopause span is maybe 4 years to 10 years, and menstrual irregularity is one of the earliest and the most visible signs. And it is often misunderstood as disorder, leading to diagnosis and the overtreatment. What is our responsibility is correct recognition, and we should give a proper counseling to the patient, and her expectations and outcomes should be in line also. Here we are dealing with a continuum, not discrete categories. So there is a word spectrum concept is there. Not one pattern, but multiple evolving menstrual phenotypes are there, because every woman has its own problem during the menstrual uh, transition period, and driven by the ovarian follicular depletion and the neuroendocrine changes. Variation across months, seasons, and stress level also play a big role. And whenever a patient comes to us, we have to classify at what stage she is. We have two classification. One is structural and another is our beloved past president Dr. Behram's Consalseria classification, which is more simpler than this. And we all know that during the early transition there is a shorter cycle. In the late transition there is a longer intervals and the skip cycles, and final menstrual period identified only prospectively. So what happens? In the reproductive period, there is an estradiol and the progesterone are castrated via the HPO axis. There is a regular ovulation, predictable cycle length. But when the perimenopause starts, first comes the luteal insufficiency because of the erratic progesterone secretion, leading to shortened luteal phase, short cycles, and here PMS may appear again, and then it leads to the involutory cycle phase, where follicular recruitment unstable, estrogen fluctuates, high to low to high, and cycles become variable. Then we lead to the late perimenopausal cycle, where there's a long cycle, maybe skip periods, heavy withdrawal readings, and here estradiol fluctuates unpredictably. Progesterone progressively decline. If you see, in this phase, progesterone is almost one third of the estrogen level, and FSS rises but versatile. So basically, it is not excess estrogen, but it is an unopposed estrogen due to low progesterone, leading to the estrogen dominance and causing this problem of the short cycle, heavy bleeding, sometimes scant bleeding, and in the end there is no bleeding. So if we see all these things in as a scenario, shortened cycle, which is predictable but closer together, PMS may be worsened, we have to reassure that patient and maybe we can give the progesterone support. When the patient comes with a polymenorrhagia, here our main issue is to stable the iron also. We have frequent cycle with heavy flow. We have to do an ultrasound and find out, yes, it is no other structural changes or the reason according to the palm point classification. And here, women may have a fatigue and the iron deficiency also. According to report, we have to manage and the anemia management can be done. Maybe it is a period of the subclinical hypothyroidism which is precipitated in the early phase. Now coming to the radical cycle length, no fixed time, sometime early, sometime late. And there's anxiety due to unpredictability. But what you have to do, you have to reassure again, counsel the patient, reassure normal transition, and can give them follow with the app. But the situation worsens. The patient has a lots of clots. She wants, oh doctor, just remove my uterus. But again, you have to see that maybe it is just due to the unstable endometrium, with all type of a support, and if ESG is normal, with transuricase, progesterone, and no doubt LNG-IUS is the wonderful thing in these patients, as it really gives them a amenorrhea or a splenic physiological. When it is not normal, postmenopausal breathing, yes. Tell every patient if she has a menopause. When she attained the menopause and after that if she has a bleeding, she has to come back and tell. At that time she does not think that it is a normal thing. Intermenstrual bleeding, bleeding of the intercourse, persistent heavy bleeding, unresponsive to treatment. So what you have to do? History, physical examination is must. Put a speculum. Please don't send for an ultrasound only. Pelvic ultrasound, thyroid and metabolic profile, and endometrial biopsy if indicated. Usually, if the patient is more than 45 years, you have to go for endometrial biopsy. Don't say no, no, no for the hysteroscopy. Many of them they need hysteroscopic guided biopsy also, and ultrasound will tell you about the endometrial thickness and all the structural abnormality in the palm point classification. Endometrial sampling is more than 45 years with abnormal bleeding. We have to rule out the risk factor of the endometrial cancer like diabetes, obesity, and LNG-IUS failure cases also need an endometrial sampling. So friends, whenever the patient comes to you, consider this therapeutic remember. Management is heavy. First, we have to take the non-hormonal measures. Stress, sleep, metabolic optimization is really, really necessary. Every speaker is talking about it at this time. These problems also play a big role. Exercise for insulin and the estrogen modulation, iron supplementation is everything. And what we have as a hormonal therapy option, cyclic progesterone, combined OCs in specifically in the younger population, LND-IUS, but in the later population, the low dose transdermal estradiol with the micronitrodextron plays a very nice role. So progesterone is a mainstay. It stabilizes HCL, it reduces the bleeding, it improves sleep and anxiety. As we know that the progesterone metabolites act like a natural tranquilizers also. LNG-IUS is my favorite. Best for heavy for unpredictable cycles, endometrial protection plus consistency. COC, good for early perimenopause, not ideal for late perimenopause cycle. Here you have to go with the estradiol patch and the progesterone using to smooth the hormonal fluctuation, improves vasomotor and the mood symptoms. You can go with the traditional NSP also if the patient has no comorbidity. Surgical option. We use leave the uterus alone. It is not only to give a baby. So it's really needed if you really go and does your Ricky properly and only after complete evolution and you can go with the hysteroscopic polypectomy or the submucous removal, the conservative surgery whenever required. Yes, this problem actually affect the quality of life, mood, sexuality, work, and relationship. So quality of life is the most important thing to handle. So you have to take care of these things also. Patient education and counseling is the key to the right treatment. We should not forget menopause is not a disease. It is a determinant, it is a phase of life. So education and counseling give our assurance and we can uh, smoothly navigate with this stormy period and we have to understand that we have to reduce the unnecessary risk factor. So friends, take home message from my side is recognize the pattern, be reassured and support, confirm normal physiology, intervene only when needed. Symptoms are coming in future like neuroendocrine modulation therapy and individualized hormone profiling. So we can diagnose the uncertainty with clarity and compassion. Perimenopausal cycle changes are physiological. That is the wisdom, that is the main line we should remember every time when a patient comes in our OPD. Spectrum approach prevents over medicalization. Tailored, gentle, evidence-based care works best. Save uterus is my last line. Thank you so much for your patient hearing and thank you for giving me this topic. Although I was not very happy, but I'm really, really, very happy after making this whole presentation. Thank you so much.
Thank you, Dr. Ramani and Dr. Gandhi. All the past presidents are sitting in the audience. Yes, Dr. Munshi sir.
Just show me once the audience.
ऑडियंस बोले
Possible. Thank you so much. I want to see the and Mahapatra sir.
Thank you, ma'am.
Thank you so much.
Thank you, ma'am, for a wonderful talk. Now, I would request our chairpersons to felicitate our speakers, Dr. Roma Ratan, ma'am, Dr. Jyoti Jaiswal, ma'am, and Dr. Ragini, ma'am. She is online, so we are going to felicitate you, ma'am, through online only.
वाइड करो
Yeah, we'll send it by post, ma'am. Just here, please.
ऑडियंस बोला
So I would like to felicitate our chairpersons. So for that, I would like to request Dr. Jamuna from Hyderabad and Dr. Sandhya Dikshit from Hyderabad to felicitate our chairpersons. Ma'am.
कॉल चढ़ा होने से
Yeah, she had a call, so she has just gone
नहीं
outside. Jyoti ma'am.
सबको बुलाए पे बुला कहूँ बुलाए पे
Dr. Jamuna and Dr. Sandhya Dikshit ma'am from Hyderabad to felicitate our chairpersons. Please.
अच्छे अच्छे कॉपी कॉपी हाँ मेल मेल करते नहीं नहीं एबे मेल आसला बुला बुला एपड़ एपड़ को एपड़ को
Before I leave the stage, I would like to quote the one Kavita Atalji. क्या हार में क्या जीत में कंचित कभी भयभीत में कर्तव्य पथ पर जो भी मिला ये भी मिला सही है वो भी मिला सही है हार नहीं मानूंगा मैं हार नहीं मानूंगा this should be the attitude of every person in the life and the same thing Harabai you have not covered the anthropos also but that is also part of a life
चेंज करो
Thank you, sir. Moving on to the next session. The next session will be on the oration, that is saying safe in tough types of menopause. For this, the chairperson for these sessions are Professor Dr. Sarat Kumar Mahapatra, sir, Professor Dr. Sushil Kumar Giri, sir, Dr. Haravashar Patnaik, sir, and Dr. Janmeja Mahapatra, sir. I request chairpersons to join us on the stage. I request the chairperson to introduce our speaker for the oration.
Good morning, everybody. This is a very prestigious session. Before we have the ceremony by the Honorable Governor, we present before you Dr. Anita Shah, the President of Indian Menopause Society 25-26. Madam Shah comes from land of Gujarat and the diamond city of Surat. She is a very affectionate personality, very warm hospitality, and Madam, we welcome you to this Eastern IOS conference, and she is also associated with Indian Medical Association. She is the founder secretary of Surat IMS at Club 35 Plus, and because of paucity of time, we start the oration now, Madam.
very good evening to all of you. Respected chairperson dear हरा भैया, हम लोग डॉक्टर हरा पटनायक को हरा भैया सालों से कहते हैं. All the organizing team of Odisha and my respected seniors and dear friends. It gives me great pride and privilege to be over here to address this august audience on this Eastern conference. Thanks a lot for lovely hospitality, Haravaya, and all the team of Odisha Menopause Society. As I was installed as the president of Indian Menopause Society in the month of February 2025, I had just had a reason that I will keep the theme of the year sailing in tough times of menopause. So I thought that let me highlight that only because the theme of the slogan of our Indian Menopause Society is only fit at 40, strong at 60, and independent at 80. And we want that each and every woman should save the difficult task of menopause and postmenopause with a very lively, healthy, and happy life. The human life is itself is a journey of tides and ebbs. By the time we approach menopause, we all have been trained to safeguard ourselves through the various types of life familial, social, financial, medical, professional, etc. etc. But the time of menopause is just like a time of Poonam, which is not going to last long. It is not like tsunami, not tough times for all the women. But majority of women are facing a lot many issues during this transitional phase of life. We are listening a lot about all this since morning. So smooth sailing in menopause, I can say it is a need of an hour. For a layperson, menopause makes the end of women's menstrual cycles essentially a natural biological process. But we know it is the gradual cessation of the function of the number one organ of the body and that is the ovaries. Such a catastrophic event cannot pass away without leaving behind some afterthoughts or after side effects. It happens so much inevitably and with such regularity that I have wondered why women has taken such a long time to realize that though it is inevitable with many of its consequences, occurring in nearly 35 to 40% of our women pass through those turbulent times, we can at least prepare to face it with impunity and reduce the unwanted consequences. That reminds me an incidental story which I think actually applies to menopause. The year was 1971, sometimes in March. Two topmost persons of the country were engrossed in serious discussion. One was the Iron Lady, Mrs. Indira Gandhi, then the Prime Minister of India, and the gallant yet shrewd army man Sam Manekshaw, the chief of the army then. The question Prime Minister asked, when can you intervene in free Bangladesh? Then is Pakistan. Mr. Manekshaw replied, December this year. Mrs. Gandhi was taken aback. Aren't you prepared, sir? Malik Shah, in his usual humorous tone but with a straight face, replied, Madam, do you want to win in free Bangladesh or just play around? Without further query, Mrs. Gandhi fixed a date in December, and the rest is the history, all you know. Ladies and gentlemen, for a war expected to last for around 3 weeks, the army, Indian Army, which is known for its battle readiness, needs nearly 9 months. What to talk about an undernourished and since birth overgrown human organism with all her under and misinformation can cope with the onslaught of hormone deprivation without any previous preparation? So, navigating life changes with confidence, we have to accept. Navigating menopause, often referred to as the second spring of life, can be challenging due to its physical and emotional changes. However, adapting effective strategies can help manage symptoms and ensure a smoother transition. So, as a healthcare provider, we should play the role of sailors to safeguard this transition journey. The foundation begins from adolescent age only. Good skeleton and healthy muscle mass has to develop and preserve from teenage. Once this formative period passes away, one has missed the bus. Again, there is no rocket science, nor is space travel costly. Diet and physical activity. Do you think the August audience needs any further highlights on this talk? But the million dollar question is, how many of us, yes, us, the medicos, ever have counseled the mothers of an adolescent girl for proper diet and simple, inexpensive food and simple physical activities for her daughters to follow? It costs nothing. Perhaps that's right. It is not trendy. Let us resolve. We all will possibly spare 10 minutes for this counseling for one mother daily, 5 days a week during our regular counseling hours, and tick mark that day on our calendar and watch how many tick marks are there in a month. Let us supplement them, not just prescribing, but counseling about simple 500 milligram calcium and low dose iron supplements to be taken on school days or work days. Easy to remember. Newborn and infant vaccination have been now firmly rooted in the psyche of the society. Let us propagate teenage and adult vaccination proactively. Counsel the parents. You all know about various vaccinations in the adolescent age group. HPV vaccine, TDAP and TD vaccine, MMR vaccine, rubella vaccine, hepatitis B, hepatitis A, typhoid vaccine, varicella vaccine. So we have equipped the adolescent with all the physical credits to face the reproductive life. चल पड़े हैं अपनी धुन में. Sound?
साउंड से टिकी रोकी दो
So, now comes the reproductive age. Now the time has come to grow the assets which one's body and mind have invested and developed. I believe that this activity of reproduction is the most demanding activity of any organism. The extent is that most of the species, during evolution, the procreation ends the life of the organism. Semiviparous like octopus and jellyfish and honeybee. Very minority of species in India animal kingdom survive beyond the reproductive competence. Homo sapiens, and one of them is one of them. So therefore, the reproductive career and activity has to be properly supervised, supplemented, and managed. This should pass without any scars on the health and long-term consequences. The net result of adolescent deposits and reproductive withdrawals will decide one's menopausal and postmenopausal lifespan and quality of life. So let us make sure that every woman enters menopause with robust positive balance. You all know about the tough types of menopause. It is already described in previous talks. Menopause is associated with an increased risk of various comorbidities also. Cardiovascular disease, hypertension, obesity, diabetes mellitus, mental health disorders, urinary tract infection, osteoporosis, sarcopenia, thyroid dysfunction, cognitive impairment, and Alzheimer. So, studies indicate high prevalence rates of non-communicable diseases among peri and postmenopausal women. There is prevalence of dyslipidemia, osteopenia, osteoporosis around 50%, diabetes mellitus 25%, obesity 25%, hypertension also 20%. So, what about public health implications? Menopause related NCDs remain under addressed in public health programs globally. In India, Where early menopause is common among poor populations, there is an urgent need for interventions targeting awareness, screening, and management of these diseases. What we are doing under the banner of Indian Menopause Society. Integrating menopausal care into existing health programs for NCDs could improve outcomes for women during this transitional phase. So you all know very well about the routine health screening in menopause. Routine health screening during menopause are crucial for maintaining the overall health and detecting the potential health issues in an early stage. Routine examination, lipid profile, diabetes screening, thyroid profile, ultrasound, DEXA scanning, cancer screening, all are of utmost importance. In postmenopausal women, the most common cancers, typically you all know very well, they are the breast cancer, cervical cancer, ovarian cancer, and endometrial cancer. So breast cancer screening is very, very important. Regular mammograms are recommended every 2 years for women ages 40 to 74, though some guidelines suggest annual screening for those at high risk. Cervical cancer screening should continue until the age of 65, typically with a pap test every 3 years, and HPV testing you can do at 5 yearly. I am happy to share that this year I have made the collaboration with Metropolis Lab, and we are doing HPV DNA testing with liquid-based cytology with only 1000 rupees all over India. So many of our patients are getting benefit of that. Ovarian cancer screening, there is no reliable screening test for ovarian cancer, but high-risk women may undergo routine pelvic examination, transvaginal sonography, and serum CA-125 test. Endometrial cancer, most common gynecological cancer in postmenopausal women, often linked to obesity and excess estrogen without progesterone. Colorectal cancer screening is also recommended between the 40 to 75 years of female. So, what are the benefits and risks of routine health screenings during menopause? Routine health screenings during menopause offer several benefits and involve some risks. Early detection, if we look at the benefit, screenings help identify health issues like osteoporosis, heart disease, and cancers, and timely interventions we can do. Personalized care. They enable healthcare providers to tailor treatment plans for menopause symptoms and monitor overall health. Preventive measure, regular checkup encourage healthy lifestyle choices and update vaccination. If we consider the risk, false positives, some screenings may yield false positive results, leading to unnecessarily stress and additional testing. Overdiagnosis, there is a risk of overdiagnosis for conditions that might not have caused symptoms or affected quality of life. Frequent screening can cause anxiety, especially if results indicate potential health issues. So it is crucial to discuss these aspects with a healthcare provider to determine the best screening schedule based on individual risk factors and healthy history. Menopause vaccination, we also have to explain our patients regarding the importance of vaccination. Recommended vaccination include those of hepatitis A, B, tetanus, human papillomavirus, pneumococcus, flu, shigella, and meningococcal, and of course, we have all have taken the COVID vaccine also. So, what are the common barriers for vaccination among postmenopausal women? Economic status, age, education, and household competition can influence the vaccine uptake. Presence of comorbidities can increase the vaccine uptake, but lack of healthcare access to insurance can be a barrier. Concerns about vaccine safety, lack of provider recommendations, and limited awareness of vaccine benefits can defeat the vaccination. Cost of vaccination and lack of insurance coverage can also hinder the vaccine access. So, education and awareness campaigns can help address these barriers by promoting vaccine uptakes among the older adults. So, what are the key strategies for staying safe through menopause? We all know that this year the theme of our International Menopause Society was also lifestyle medicine in menopausal health. Lifestyle adjustment, you all know very well. Healthy diet, proper macronutrients as well as micronutrients, we have to always explain our patients. Calcium in dairy products, protein, fruits and vegetables, whole grains, and healthy fats. There are the need of an hour. Phytoestrogens found in foods like soya. This may help with bone health and cardiovascular risk. Avoid trigger like spicy food, caffeine and alcohol that can worsen hot flushes. Limit consumption of added sugar, processed food, alcohol and caffeine to manage symptoms better. So Mediterranean diet is usually we like to recommend. Regular exercise. We know everything about exercise. Uh, Heart health, bone strength, that is improved. Of course, mental health also will be improved. Exercise boosts mood, reduce anxiety and improve sleep quality. Weight management. You all know very well that regular exercise will maintain your weight, balance your weight. So recommended exercise include aerobic conditioning, strength training, balance exercise, and pelvic floor exercise, of course. Sleep hygiene is also very, very important. Stress management, relaxation techniques like yoga, deep breathing, and meditation can help to each and every patient. Social connections, joining groups or staying socially active can improve mood and mental health. And that is why, under banner of Club 35 Plus, we just want to reach to the grassroots level and just we spread awareness in general public. Workplace support, this is very, very important. Menopause one can help. Menopause and sickness, absence, and cost, if we consider the relationship between menopause, absenteeism, and productivity, loss and cost to the individual, society, and to the economy has never been computed. We have never thought in that way. Dukes et al. State that three-quarters of symptomatic menopausal Dutch women looking for professional help because of health complaints has an increased risk for sickness absence and possibly even for early withdrawal from the labor market. Other studies report that menopause is associated with lower work productivity and short-term sick leave and hence with increased cost for employers and for the healthcare also. So intervention is really needed at workplaces. Our government is doing lot of work for antenatal women as well as neonatal infants, and that's why we have come to a very lower rate of maternal mortality and infant mortality. But in this direction, we also need that we have to do something. You all know about the symptom management, heart flushes, vaginal dryness, mood swings and anxieties. Hormonal and medical support is the need of an hour. Similarly, where there is contraindication for hormonal therapy, bioidentical hormones are also coming in market. Alternative therapies are also there, and emerging research suggests that may reduce the stress and improve the mood during menopause. Acupuncture is also very, very helpful. Building emotional resilience. Connect with support groups or communities like Menopause Cafe or Women's Health Concern to share experiences and gain insights. Engage in self-nurturing activities such as massage or hobbies that bring joy and relaxation. Preventing long-term health risk. Get sunlight exposure for natural vitamin D production that strengthens the bone. Avoid smoking and limit alcohol intake to reduce the risk of heart disease and osteoporosis. Seeking professional help. If symptoms are overwhelming, consult a menopause specialist for tailored advice. Talking therapies like CBT are also very, very helpful. Online resources such as Menopause Matters provide additional support. By embracing these strategies, balancing lifestyle changes, symptom management techniques, emotional care, and professional guidance, women can navigate menopause with greater ease and confidence. Menopause and finance, very important. There is reduced income, severe symptoms may lead to missed workplace or even lost income and reduced saving contributions. Career impact. Symptoms can affect career progression, leading to lower future earning. Reduced working years can negatively impact the retirement savings also. Additional costs for treatments and medication related to menopause symptoms affect the healthcare. And early awareness and planning, such as building emergency funds and maximizing savings, can help to mitigate these financial impacts is for each and every woman. Here, I just remember a story of Lady Iris. She was a freelance journalist, senior commissioner editor Telegraph, former editor-in-chief CEO. She participated in rowing in 2019 after Oxford University's Women's Victory in 1990s. In 2021, she took the Talisker Whiskey Atlantic Challenge. She did rowing competition in 2024. And Levy Island experience rowing in Atlantic had a transformative impact on her menopause symptoms. At the time, she was struggling with perimenopausal changes, including heavy periods, night sweats, disturbed perimenopause, disturbed sleep, joint pain, and feeling of irrelevance. Taking on the physical challenge of rowing 3,000 miles helped her regain control over her body and mind. The intense physical activity improved her fitness, alleviated joint pain, and led to significant weight loss. The demanding routine of rowing in ships also provided mental clarity and mindfulness, leaving no room for negative thoughts. During the race, her periods temporarily ceased due to the stress and weight loss, offering some relief from symptoms. Post stress, she reported feeling resilient and energized with a newfound Carpathian approach to the life. The experience reinforced the importance of physical fitness in managing menopause and inspired her to embrace challenges as a source of empowerment. So, how we can empower the embarrassing menopause? Menopause is often misunderstood and stigmatized, yet it can be transformative and empowering stage in a woman's life. By reframing menopause as an opportunity for growth, self-discovery, and renewed vitality, women can embrace this transition with confidence and purpose. We have to redefine menopause. It is a time for growth. We always say that life begins after 40. Menopause marks the end of reproductive years but opens doors to new possibilities. Many women find this phase to be a time of reflection, self-awareness, and personal transformation. It can be viewed as a natural part of life's journey rather than a limitation. Strategies for empowerment. Navigating menopause with a proactive approach can enhance physical, emotional, and mental well-being. Prioritize priorities for self-care. To take care of always and thinking of always for yourself is not selfishness, but you have to prioritize your self-care. Engage in regular physical activity to strengthen bones, muscles, and cardiovascular health. Adopt a nutrient-rich diet to support hormonal balance and overall vitality. Practice relaxation techniques such as mindfulness or yoga to reduce stress and improve sleep quality. And have me time, very, very important. Cultivate emotional resilience. Address hormonal fluctuations by connecting with supportive communities or engaging in therapy. Challenge limiting beliefs about aging by embracing positive thoughts and attitude towards menopause. Celebrate small victories and milestones to foster the confidence. Seek knowledge, very important. Education is critical in understanding menopause symptoms and treatments. Women who actively learn about this phase often feel more empowered to make informed decisions about their health. Build supportive networks. Connecting with friends, family, or peers experiencing menopause can provide emotional comfort and shared wisdom. Social support has been shown to improve health outcomes and reduce the feeling of isolation. Focus on physical health. Maintaining physical health through exercise, proper nutrition, and regular medical checkup ensures longevity and energy during this stage of life. So we have to take menopause as a new beginning. Menopause is not end, it is the beginning. By embracing this phase with positivity, self-compassion, and proactive strategies, women can redefine what health, happiness, and fulfillment mean to them. This transformative period offers an opportunity for renewed confidence, deeper self-care practice, and the pursuit of personal ambitions. Really, women are rays of hope, pillars of strength, and the epitome of love. You can see all these celebrities, everyone are in the phase of postmenopausal age group, but they have achieved a lot and they have fulfilled whatever they have dreamed. Sound?
Thank you, madam.
We want that each and every woman should think
Thank you,
that,
madam. Please give her a big round of applause. Madam President Dr. Anita Shah for a wonderful oration. We are getting ready for the Honorable Governor. Madam will be felicitated in the inaugural ceremony. Thank you. Let's get ready for this. Thank you so much. Please give her a big round of applause. Ladies and gentlemen, photograph please. Thank you very much. See, there is a few announcements I have to make. We are taking for you. Nobody will be on the corridor and everybody will be sitting inside while the Honorable Governor comes. The band will be playing in the back and all the phones should be, these are the instructions from the Raj Bhavan, should be on the switched off or silent mode. Please bear with us. The first two rows has to be, first row should be emptied for the governor's family and their team. Sorry for this inconvenience and there will be, nobody will be passing in the front of the governor. All these things are there. I think we are all educated and enlightened enough to cope with the request from the Raj Bhavan. Thank you very much.
କାଟା ବଲଟା ମାଷ୍ଟର କରୁନାହାନ୍ତି ମାଷ୍ଟର କରୁନାହାନ୍ତି ଫ୍ରେମ୍ଟା ଯିବା ସେ ଷ୍ଟେଜ୍ରୁ ଯିବାକୁ ପଡ଼ିବ ଚେୟାର ଚେୟାର ଇଏ କରିବା ପାଇଁ ଗଣେଶ ଭାଇ ଗଣେଶ ଭାଇ ମାଷ୍ଟର କରୁନାହାନ୍ତି କ୍ୟାମେରା ବନ୍ଦ କରୁଛନ୍ତି ନା କ'ଣ ଏଇଟା କଟିଗଲା ଯେ ଏଇଟା
be having the traditional lamp lighting ceremony. The simple yet profound act carries with it a multitude of implications, the triumph of knowledge over ignorance. For this, I would like to invite our chief guest, Honorable Governor of Odisha, Dr. Haribabu Kambapati sir, and guest of honor, Dr. Anita Saha madam, to step forward and light the lamp. And I also request other esteemed dignitaries on the dais to join us for lighting the lamp.
ବାଜିବ 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 ବାଜିବା ତ ବଜେଇ ଦେବି ବଜେଇ ବଜେଇ ବଜ 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 ସରିଲା ତ ଥାଉ 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 ଟିକେ ବଡ଼ ଲାଇଟ୍ ଟିକେ ଦିଅ ଲାଇଟ୍ ଟିକେ ଦେଇଦେବ ଲାଇଟ୍ ଟିକେ ବଢ଼େଇ ଦେଉ କହିଲେ କମେଇବା ବାସ୍
Now I request sir to please accept our sincere token of thanks.
ଲାଇଟିଂ ଖତରା ହେଇଯାଇଛି
I request other members. I request other members to also please accept this token of appreciation. Now I request our chief patron, Professor Dr. Sarath Kumar Mahapatra sir, to felicitate our chief guest, Honorable Governor of Odisha, Sri Dr. Haribabu Kambapati sir. Now I request our patron, Professor Dr. Sushil Kumar Giri sir, to felicitate our guest of honor, President Indian Menopause Society, Dr. Anita Saha ma'am. Thank you, sir. Now I would like to invite our organizing chairperson, Dr. Haraprasad Patnaik sir, to welcome the hall.
Namaskar. Good afternoon, everybody. I welcome you all to this EZIMSCON conference of Indian Menopause Society we call EZIMSCON 2025 for the inaugural ceremony and Honorable Chief Guest, His Excellency the Governor of Odisha, respected guests of honor, Madam Anita Shah, President of Indian Menopause Society, dignitaries on the dais, national faculties, and international faculty joining online, past presidents of IMS, office bearers, member of organizing committee, delegates, postgraduates, senior teachers, friends, ladies and gentlemen, I welcome you all to this conference. As you know, Indian Menopause Society is an academic body of specialists of all branches of medical science, not only gynecologists, but also orthopedician, cardiologists, dermatologists, radiologists, dentists, and other healthcare professionals. The membership at present is more than 5,000, and this is mainly dedicated to cater the health needs of elderly women in their post-menopausal period, not only physical, but also social, psychological, and spiritual well-being and upliftment. We are indeed privileged to have amongst us the Honorable Governor of Odisha, Sri Haribabu Kanmanpati, as the chief guest of this function. A soft-speaking and mild-mannered personality. He is an electronics and communication engineer. He has got B.Tech and M.Tech and PhD scholar, and he was also a professor in engineering college before joining public life. Sir, we are indeed privileged to have such a great academician among us, and I really feel happy as the first citizen of this state that we are lucky to have a great academician and a public health personality. I welcome our guest of honor, Madam Adita Sir. Madam is from the diamond city of Surat in Gujarat. But sir, she has a golden heart and has a silvery mannerism. And she is a great academician and who has done numerous academic programs and social activities throughout the year. We have 45 national faculty who have joined today. 20 more will be joining tomorrow, and 10 international faculty from Australia, from neighboring countries of Bangladesh, Sri Lanka, and Nepal, Bhutan, and Pakistan will be joining online. So this is online, and everybody is watching this program in Zoom platform. And I hope this two-day academic deliberation and with the knowledge of the participating faculties will enrich the knowledge of all the gathering personalities, delegates and postgraduates. The delegates are the cream of this. I welcome all the delegates who have joined in large number to make the Science Congress a success. I hope your participation will bring many developments in the field of menopause management. I welcome friends from electronic and print media or friends from the pharma industry for your active participation and support. Finally, I thank all those who are present here physically and all those who are available and seeing us in the online platform, virtual platform. Thank you very much. Welcome everybody again.
Thank you, sir, for the warm welcome address. Now, I would like to invite upon the podium President Association of Obstetrician and Gynecology of Odisha, Professor Dr. Sujata Mishra Madam, to address the hall. She is also Director of PGIMR and Capital Hospital, Bhubaneswar.
Namaskar, Jai Jagannath, Honorable Governor, Sir, the dignitaries on the dais from both IMS and AOGO and from the Odisha chapter, the organizing presidents and secretary. Now, as I stand here, I feel very proud and I stand tall when I talk about AOGO, sir, which is the Association of Obstetricians and Gynecologists of Odisha. Sir, it's an association which is which consists of members who are dedicated, who are committed, who prioritize and work towards the commitment of providing better health care to the ladies in general and for neonatal care. Our association is over 50 years old and we are a subset of the national organization which is the Federation of Obstetricians and Gynecological Societies of India, which has over 34,000 members. That is known as FOXY, and under that each state, they have their various organizations. We have about 7 in our state, of which AOGO
and we have over 438 members. We are very, 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 very proud that IMS Odisha chapter and the national chapter did think of letting us associate with them. So this entire program is a culmination of the effort taken by both AOGO and the IMS members to bring forth this conference. So the AOGO per se, while we look after every subset of a woman's health, it could be contraception, it could be menopausal problems, it could be infertility related, it could be delivery related. IMS basically concentrates on menopausal related problems. So I'm very happy here and I place on record that we are all very happy, all the AOGO members stand in full support of the IMS outcome. Together we shall make it succeed. Thank you so much.
Thank you, ma'am. Now I would like to invite President of Odisha Menopause Society, Dr. Abhay Kumar Patnaik sir, to speak a few words and introduce our guest of honor, Dr. Anita Saha madam.
Good afternoon, all. His Excellency Honorable Governor of Odisha, Dr. Haribabu Kambhampati, respected dignitaries on the dais, distinguished speakers, esteemed colleagues, and visitors. On behalf of the Odisha Menopause Society, it gives me immense pleasure to welcome you all to this regional IMS conference at Bhubaneswar, which is a branch of Indian Menopause Society. It is truly heartening to see such inspiring gathering of medical professionals, researchers, and healthcare advocates who share a common goal to enhance the quality of life of the woman in their midlife and beyond. So we are deeply honored to have among us the distinguished personality of the Indian Menopause Society, Dr. Anita Saha. She is well known as Anita Ben. She is from Surat and she is now the president of Indian Menopause Society for 25 to 26. She is practicing gynecologist in Surat since 1988 and president of Surat Obstetrician Society in 2000 to 2001 and organizing chairperson of World Congress of Population Stabilization in February 2003 and organizing secretary of National Conference of Indian Menopause Society (MSCon) 2009 at Surat. She was also the president of Udna Medical Association 2002-2003, organizing secretary of the State Conference of Gujarat 1998-2016, and founder chapter secretary of Indian Menopause Society, Surat chapter, national chairperson of Block 35 Plus Committee of Indian Menopause Society. She is the ex-general secretary, the Secretary General of Indian Menopause Society in 2021. She is also the Vice President of Indian Menopause Society in 23-24. So before I conclude, I should say that once again I welcome to the regional conference of IMS 2025 at Bhubaneswar. May this event be enriching, collaborative and truly memorable for all of us present here. Thank you all.
Thank you, sir. Now I invite to the podium our guest of honor, President Indian Menopause Society, Dr. Anita Saha madam, to address the gathering.
Respected Governor Sir, dignitaries on the dais, senior members and dignitaries of the dais. First of all, thank you very much for giving me this opportunity, Hara Sir, to be as a guest of honor on this very, very unique conference of Indian Menopause Society. Sir, as Hara Sir has told that Indian Menopause Society is a multidisciplinary system. When it was started in 1995, there was a few societies and few members. But today it has become just like a big banyan tree. Today we are having more than 53 societies and we are having 6,300 members. And under banner of that, we are running one Club 35 Plus, by which we want to reach to the grassroots level. know that as lifespan has, women's lifespan is increased, the more than one third of the life every woman passes in the postmenopausal age group. And our main goal of we are having our own clinical practice guideline. We are arranging various webinars and we want to spread the same message as a healthcare provider to all the population. We are also taking CIMP exam and we just make our members credential Indian Menopause Society practitioner so that we can have a latest knowledge and we can give better management of our menopausal patients. Similarly, we all know that these days cancer is also very common and female cancers, in case cervical cancer, which can be prevented, we are doing screening of cervical cancer by HPV DNA testing and IGC factors. These also we have made all over India with a very minimum rate by collaboration with one laboratory. So in short, we unite together and we make each and every midlife woman healthy and happy in the later age of her life. That is the main goal and intention of our Indian Menopause Society. Thank you so much.
Thank you, madam, for the encouraging and motivating words. Now, I would like to invite to the podium Secretary Odisha Menopause Society, Professor Dr. Sasmita Swami, madam, to address our chief guest.
Namaskar. Respected Honorable Governor Sir and all the dignitaries on the dais and off the dais. A very warm welcome to all of you. It is our privilege to have amongst us the Honorable Governor of Odisha, Sri Haribabu Kambhampati, as the chief guest of today's conference. On behalf of everyone present here, I wish to thank our Governor Sir for gracing today's occasion with his presence in spite of his busy schedule. I have given the responsibility to give a brief review of Sir. Sir has served as a Member of Parliament in the 16th Lok Sabha, representing the Visakhapatnam Lok Sabha constituency in Andhra Pradesh. Sir won the 2014 Indian general election as a candidate of the Bharatiya Janata Party and served as the President of BJP for Andhra Pradesh from 2014 to 2018. Our Honorable Governor Sir has a very strong academic background, having pursued his engineering at Andhra University, Visakhapatnam, and completing his BTech, MTech, and PhD in Electronics and Communication and Control Systems. Sir has served as Associate Professor at the university's Engineering College for a long time, later devoting his full time into the journey of politics and administration. In his current role as the Governor of Odisha, he actively participates in the events that promote environmental conservation and education, and Sir has a deep interest for health. He has always emphasized on sustainable development. Once again, we extend our heartfelt thanks to Governor Sir for his presence in today's occasion and at the same time extend a very warm welcome to him. Thank you, sir. Now I request Sir to release our two books, Souvenir and Poise, the unique magazine of Menopausal Society.
टाइप से लोगे तो
Dr. Anita Shahji, President Indian Menopause Society, Dr. Hariprasad Patnaik ji, Organizing Chairperson, East Zone Conference of Indian Menopause Society 2025, Dr. Sujata Mishra ji, President Association of Obstetricians and Gynecologists of Odisha, Dr. Mrityunjay Mahapatra ji, Organizing Secretary, East Zone Conference, Dr. Sashmita Spain, Secretary, Dr. Abhay Kumar Patnaik ji, President, Odisha Menopause Society, distinguished participants in the seminar, and distinguished guests, ladies and gentlemen. It gives me immense pleasure to join you today at inauguration ceremony of East Zone Menopause Conference 2025, hosted by the Odisha Menopause Society in collaboration with the Association of Obstetricians and Gynecologists of Odisha. I extend my warm congratulations to the Indian Menopause Society, the organizers and all collaborating institutions for bringing together such a distinguished gathering in Odisha. The theme of this conference, Advancing Knowledge and Care in Menopause, is both timely and relevant, reflecting the importance of enhancing awareness, scientific understanding, and compassionate care in women's health. Ladies and gentlemen, menopause is a universal biological transition experienced by every woman. Yet, for far too long, it has remained surrounded by silence, stigma, and misunderstanding. Today, as I stand before the distinguished gathering of clinicians, researchers, academicians, and public health leaders, I am heartened to witness a collective resolve to bring menopause out of the shadows and place it where it truly belongs, at the center of informed discussion, scientific progress, and compassionate care. India today has over 130 million women above the age of 45. With rising life expectancy, women are spending nearly one-third of their lives in the post-menopausal phase. This demographic shift brings both challenges and opportunities. Challenges to ensure healthy aging and opportunities to broaden our understanding of women's health beyond reproductive years. Menopause is not merely the end of fertility. It influences physical, emotional, and social dimensions of a woman's life. While medical challenges such as osteoporosis, cardiovascular disease, metabolic syndrome, and mental health concerns deserve serious attention, we must also recognize the equally important social factors that shape a woman's experience during this transition. Family support, understanding at the workplace, and a compassionate community can make all the difference. A woman navigating menopause should feel supported, not judged, ignored, or misunderstood. In many cases, a simple act of patience or awareness within the family can ease anxiety, while community level support can prevent isolation. I urge this conference to devote meaningful discussion to these social aspects as well. The science of menopause must walk hand in hand with the sociology of menopause. In this context, I urge the Indian Menopause Society and all stakeholders to design a comprehensive awareness program that reaches every segment of the society. Such an initiative could set a benchmark nationwide. Awareness is the first step towards empowerment, and empowerment is the true pathway to dignity for every woman. A unique opportunity lies before us to reframe menopause not as an ending but as a new phase of strength, wisdom, and vitality. In many cultures, women entering their 50s become custodians of family traditions, guide younger generations, and pillars of community life. If we combine medical care with social respect, menopause can transform from a period of vulnerability into a period of renewed contribution. What makes this conference especially relevant is its forward-looking approach. I am pleased to note that discussions will focus on recent advances in hormone and non-hormonal therapies, mental health, lifestyle modification, digital health, artificial intelligence, and telemedicine. These innovations can greatly improve access to timely care, especially in rural and remote areas. Odisha continues to strengthen its public health initiatives, particularly in women's nutrition, cancer screening, and community-based interventions. Conferences such as these help integrate new scientific insights into existing programs, ensuring that policy and practice advance together. I also wish to acknowledge the tireless efforts of gynecologists, nurses, psychologists, researchers, and public health professionals whose work ensures that compassion and science remain inseparable. As we reflect on healthy aging, let us emphasize the importance of nutrition, physical activity, mental wellness, and regular screening. These pillars, combined with awareness and social support, truly define holistic care. I am confident that the deliberations over the next 2 days will inspire new ideas, strengthen public health strategies, and foster a more compassionate ecosystem for women in their midlife years. I congratulate the Indian Menopause Society for its vision and commitment. Odisha is proud to host this significant scientific gathering. I wish all participants meaningful discussions and a memorable stay in our beautiful state. Thank you. Vande Utkala Janani. Jai Hind.
Thank you, sir, for the insightful words, and again I extend a heartfelt thanks for gracing today's conference with your presence. Now I request our organizing secretary, Dr. Mrityunjay Mahapatra, sir, to deliver the vote of thanks.
Very good afternoon to you all. It is my privilege and honor to propose the vote of thanks on this special occasion of IMS East Zone Conference. On behalf of the organizing committee, I express my heartfelt gratitude to our chief guest of the day, His Excellency Honorable Governor of Odisha, Dr. Haribabu Kambampati, for gracing the event with his presence and inspiring us with his valuable words. My sincere thanks to our guest of honor, respected Dr. Anita Saha, who has come from Surat with the President Indian Menopause Society, for taking time out of her busy schedule and joining us today. I also extend my deep appreciation to AOGO for providing us with all supports needed to make this conference possible. A special words of thanks to all our speakers, resource persons, and panelists for sharing their knowledge and enriching us with their insights. I would also like to thank the organizing team, volunteers, and staff members who worked tirelessly behind the scenes to make this event a success. I must thank the chairperson of scientific committee, no other than Professor Dr. Bhagyalakshmi Nayak, who is with her team has made the scientific program very successful. Last but not the least, a warm thanks to all the participants, audience members, and media persons, both print and electronics, for their presence and active involvement and enthusiastic response. Sir, your presence has made this event truly meaningful. Once again, thank you everyone. Namaste.
Thank you, sir. Now I request esteemed dignitaries, the faculties of the hall, delegates, and dignitaries on the dais to rise for national anthem. Now it's time for our inquisitive panel session, that is reverse panel, and the topic is revisiting hormone therapy, safer, smarter and personalized. For this, our facilitators are Professor Dr. Sujata Swami Madam and Associate Professor Dr. Jasmina Begum Madam. Ma'am, please welcome on the podium, and I request our facilitators to introduce our dynamic panelists.
So I welcome all the delegates for this reverse panel on MST therapy, the smarter, the safer and the effective way. So I ask my co-host, Dr. Jasmina, to introduce our esteemed panelists.
Okay, good afternoon all. A warm welcome to all the distinguished faculty members, delegates, enthusiastic learners. This panel is not a normal panel. It's not a usual panel. It's a reverse panel. It will be a two-way conversation between the audience and the expert panelist. So as you all know, this is the chance to challenge what we think we know about MHT and update it with what we should know, guided by the evidence, experience, and wisdom. Hormone therapy has traveled a long journey. Today, we are not here not to discuss whether hormone therapy is right or wrong, but we are here to understand how safely it can be used, whom to use, and when to use. So I would like to invite our panelists, esteemed panelists. These panelists are distinguished clinicians. They are the leader with extensive experiences in menopause management and women's health. Our first panelist, Professor C. Ambuja. I would like to invite Professor C. Ambuja. Madam is past president of IMS Society. She is a retired professor and head of the Department of Institute of Obs and Gynec, Osmania Medical College, Hyderabad, and visiting professor to Savita University, Chennai. She is the faculty of National Board of Examination. Next, I would like to invite Dr. Meeta Singh. Madam is senior consultant, head of the Obs and Gynec Department, specialist menopause and osteoporosis. She is the co-director of Tanvir Hospital and the founder chair of Indian Menopausal Society Registry. She was honored with several prestigious awards for her remarkable achievement. Next, I would like to invite Dr. Shruti Saha. Dr. Shruti Saha, madam? Okay. So I would like to invite Dr. Rajni Hejila. Madam is there here? Okay. 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 Okay, Dr. Rajni, madam is senior consultant in the Department of Obs and Gynec, practicing in Hajila Hospital, Bhopal. She is the ex-treasurer for Bhopal Menopausal Society. Next, I would like to invite Dr. Jamuna Devi. Madam is there? Yes. Madam. Yeah, madam. Dr. Jamuna Devi. Okay, okay, okay. Okay. Next, I would like to invite Dr. Sandhya Rani Panigrai. Madam is there in on the dais. She is the senior consultant and she is the life member of Barampur Obs and Gynec Society. And Madam is the former vice president of Barampur Obs and Gynec Society and president of IMI AMS Barampur, editor of IC Surjana e-magazine. And I invite, good afternoon, ma'am. Dr. Jamuna Devi is social activist and she is the master trainer for program on respectful abortion care, women's safety, adolescent health. She has conducted extensive outreach program awareness session in school and college, and currently she is the chairperson of State Medical Legal Committee, Aesthetic Gynecology under IMS Society, and branch steering committee member. She also holds a leadership position in various national and state committee. Next, I would like to invite Dr. Bipasa Sen. Okay. Madam has served as a Secretary General of IMS and Treasurer of IMS, as well as South Asian Federation of Menopausal Society. She has contributed chapter to clinical practice guideline in menopause, clinical update on osteoporosis, clinical update on MST 2023, and she has several publications in Indian Menopausal Journal. I would like to invite Dr. Dilip Gadvi. Sir is there? No? So, so, okay, Dr. Dilip is not here. I would like to inform our audience, this session is a reverse panel. The audience has to ask question or queries related to menopausal hormone therapy to our expert panelists. And the panelists here are the experienced practitioners, and they have contributed to the clinical guidelines of Menopausal Society, menopause guidelines. So they will be responding to those queries. So I just start with this introduction, and now I hand over to Sujata madam. She will be giving a brief introduction to the topic.
So once again, I welcome all the esteemed panelists for this reverse panel discussion on MHT. So as we know, since morning we are discussing about menopause and how this menopause is affecting the quality of life. We must know a little bit about the endocrinology of aging. As we know, the menopause where there is a ovarian follicles are repleting, and the average age of menopause is roughly around 50 to 51 years. And we have various scenarios where we have a removal of ovaries or uterus, we call it as a surgical menopause. And sometimes if it is occurring before 45 years, we may call it as an early menopause. And also there is a scenario where there is a cessation of menstruation below 40, we may say it's a premature ovarian insufficiency. So we are going to highlight how to manage the menopause in the transition phase as well as in various scenarios. As we know, the life expectancy is increasing, and 1/3 of our life is spending in postmenopause. Now it is very important that how to address various symptoms and signs which are occurring in the menopause. So we know it is impacting our quality of life. Since morning we are discussing all about this quality of life, and this impact of symptoms in quality of life, if we see, half of the menopause have a negative impact, half of the menopause have a negative impact on the sex life, and many also complain of various impact on the work life as well as in the social life. And many of these women may present with various scenarios. They may complain of there may be bleeding problems at around menopause. There may be the very important symptoms which they complain is the vasomotor symptoms, that is VMS, where she experiences the hot flushes, night sweats, poor sleep, joint pain, and there may be genitourinary symptoms in terms of urinary problems, and many of, as a clinician, has encountered many of these genitourinary symptoms. And along with that, there is a vulvovaginal atrophy, and there is a loss of libido, central weight gain, and cognitive dysfunction. Along with that, we have a concern regarding the future osteoporosis and whether there is any cardiovascular risk, dementia, and diabetes and obesity. And we know there are certain healthy way of managing the menopause, but today we are going to discuss about the MHT, that is menopausal hormone therapy, in the smarter and safer way. So let us debate, and we also have a reverse panel, so we have an audience. Our delegates will be asking our questions to the esteemed panelists. So as we know, in MHT therapy, there is a popularity before WHO study, but after WHO study, there is a sharp decline in menopausal hormone therapy. The clinicians afraid of prescribing this estrogen because there is a certain study has given the negative concern regarding estrogen or any hormonal therapy. And in India, there is a sharp decline. So today we'll know how this controversial history is, we are going to turn it, and we can know how it is going to change our scenario. So now I'm focusing on one case. She is 49 years old, para 2 professional. She is experiencing hot flushes, night sweats, sleep disturbances, mood swings since her last period 4 months ago. The cycles were irregular. Last menstruation period was 4 months back. She has been busy, not gone for any checkups, and we know this is a classic case of perimenopause. So I invite any of the audience to put the first question. Dr. Pramod will help regarding audience questions.
Yes. Good afternoon, everyone. Myself, Dr. Pramod Kumar Sahu. I'm the coordinator for this reverse panel discussion. Now this first question will be asked from the audience.
So, I see Dr. Ojaswini is coming up with the first questions. Okay, Ojaswini.
So good afternoon to everyone. So my first question is, as all of us know that menopause is inevitable and all women has to go through this, so how will you confirm that the woman is selling through the perimenopause? And is it necessary to do the hormone test to diagnose the condition, or only a clinical diagnosis is sufficient?
My esteemed panelist, Dr. Jamuna Madam.
Good afternoon, everyone, and thank you, Bhagyalakshmi, for inviting us to this panel. I think we are also going to learn from the audience and as well as the facilitators. So anyway, she's 49-year-old, so she's close to the menopause according to the Indian standards, which is 46, 47 years. So I think we should do FSH only to know at what level it is. And then we have some sufficient clinical diagnosis, and depending upon that, hot flushes can be treated and it should be treated.
See, irregular and scanty periods in the perimenopausal period is the biological marker for menopause. So after 45 years, this situation, if it comes because she is 49 years, there is no need to do FSH and LH. This itself is a thing. Only thing that is necessary is examine the patient completely, and this is an opportunity for screening completely and do the speculum examination specially and see that are we missing anything like diabetes, hypertension, and any breast examination, speculum examination. These are the things.
So for diagnosis, we are not at all dependent
on the. For diagnosis, there is no need to go for the FSH or estradiol combination.
Good afternoon, everyone. My respected all my teachers and my moderator and facilitator, the expert. I will recite one thing. पॉज नहीं है मेनोपॉज, उड़ने की बारी है जिंदगी की यही धोच. सब कहते हैं उम्र हो गई, उम्र की ऐसी की तैसी मैं रट गई. हो गई मेनोपॉज, अब खुद को तू सज धज, ना कोई पाबंदी ना कोई रुकावट. ये है मेनोपॉज, ये है मेनोपॉज, नो फिकर है, नहीं फिकर है प्रेगनेंसी की, ना चिंता है प्रेगनेंसी की.
So we have a poet in our
now I will start that.
Okay.
Is it necessary for the biomarker of the FSH estradiol necessary? It depends, madam. If the patient is very highly educated, wants to do, and the professional, and they are from the corporate sector, very intelligent, Google search, I will advise really, but it is clinically obvious that perimenopausal age is going to be menopause, but it depends in which case we are dealing. It is individualized and customized,
okay,
not for generalized.
Okay,
thank you.
But generalized, we have to, whenever she is complaining of symptomatic, we not required to do any hormone assays to confirm the diagnosis. That is.
I think this is a very important part of your discussion. So I put the final word on it. FSH and LH to diagnose menopause beyond 45 is not necessary.
Yes.
So don't unnecessarily do it.
Yes.
That is the final word.
Madam was talking about the assessment of this woman.
Yes.
So what exactly we are going to assess this woman? This side, madam.
How do you assess
a woman?
Because now this patient requires treatment. So any assessment evaluation you want to do?
Hello. Is it okay? They have attained menopause. So if they have attained menopause, there is no need to give Ujjal. In that case, I usually go for FSH. If FSH is high, you just don't take, because there always been dilemma.
For diagnosis of POI, we may go for a FSH testing because that is need, yes.
Age 45, no?
40,
they usually come with amenorrhea.
Yes.
Whether they have attained menopause
sometimes irregular scanty menstruation is there.
Yes. Hello.
So what are the assessment, madam, you are going to do exactly for this woman?
So now it is confirmed that she is heading for the menopause, and we have to treat her symptoms. And before start of the treatment, we should assess the patient fully. That is full medical examination, any history. We can start from the history. Age and BMI and everything is already there. Family history of cancer or breast cancer, And we should also go for medical history like diabetes, cardiovascular disease, any thrombosis in family and personal, and any family history of cancer also, right? So, yeah.
And what other examination you are going to do?
We can even do a breast examination.
So
and
Dr. Ragni was enumerating what are the investigations. Anything you want to highlight? Madam, want to highlight?
Although she has presented with
hello?
hot flush and
Hello,
irritability,
just-
everything. आवाज नहीं आते I think it is okay.
Please flip the mic close.
Okay. Actually, although she has presented with hot flush, irritability, everything, but I will not skip urine for pregnancy test. She has got her last menstruation 4 months back. So I will do a examination for pregnancy also, and thyroid. These are very common diseases, comorbidities, which present with similar, more or less similar complaints. So I will assess those points, thyroid, and as she told, diabetes, heart disease, everything.
You have to go for a full metabolic
Yes,
profile,
full metabolic.
Yes, TBS ultrasound to look for any organic pathology.
Yes.
Hello. One small message to the audience. For your question, what you asked, should never do FSH and estradiol to confirm the menopause after the age of 45 years. And no, that's what, again, to stress for them. And then 4 months amenorrhea, you can just give the progesterones for withdrawal bleeding and see, or you do the vaginal ultrasound, which is very, very important. Otherwise, nowadays we see in the clinical picture how it comes in the when our OPs, they come with all the investigations. They'll spend about 10,000 rupees for hormonal investigations, and then they will come to us. So please don't do any of such things.
So any audience question at this point?
Now second question from the audience.
Yes, of course.
HPV 65, also pap smear 65.
Yeah.
What?
Yeah, so that's an excellent question. If somebody has never had an HPV, even if you are seeing at 65, I think it's a good idea to do once. That's what the guidelines say.
If they have not done.
Not done ever. And once in 5 years is the routine that we do, but we have to be,
So pap smear is not a substitute for HPV.
Yeah.
But there is a guideline that if HPV negative and you do a pap smear, you can repeat it.
Yes.
And if HPV done once, not done once, you want to do once.
Yes.
Okay.
So any other audience question?
If 2 tests come negative before the age of 65, there is no need to repeat. But for the first time, if she has come what you asked, you need to do the pap smear. Even if you don't do HPV, do pap smear at that age. Otherwise, our thing is we'll stop at 65 years. No need to stop and do. For the first time, she's coming, do. Because we get everybody.
Here I think HPV is a better option at 65 rather than pap smear, because atrophic changes will, unnecessarily lead to more confusion. So an HPV is affordable. Like we said, we are doing it for 1,000 rupees. The Metropolis is along with the IMS.
So take home message is that we should always conduct pap smear with HPV testing. That will be very ideal in case. That is a take home message. Okay, that is another point.
Madam.
Madam, for a patient with a, a woman coming with amenorrhea and clinically diagnosing as perimenopausal or premenopausal, should we give withdrawal progesterone to ensue one withdrawal bleed, or clinically can we treat her by doing just an ultrasound examination which proves to be more consistent?
An excellent practical question, Sandhya.
For the audience, madam.
Yeah, excellent practical question, because it is between you and the woman. If you are able to counsel her that, just maintain your menstrual calendar. If you report any symptoms, if you have any problem, do the screening and then come back. But if she is, the hyper anxious kind, and she wants to know whether she is heading for menopause or not. So then I think the withdrawal is a simpler, cheaper method of doing. But if she still insists, that is when, the clinician is forced to do the FSH for the satisfaction of the woman. Otherwise, not necessary.
So any other questions?
Ma'am, I have a question.
So we have Dr. Leena. No. You can start
for audience
yeah.
perspective. You just anyone?
This side, madam. This side.
Ideal candidate for MSD.
Ideal candidate for MST is the one who is having menopausal symptoms, and we have ruled out all contraindications to MST. That is the first point. We should do a proper investigations to see that she is fit for, to take hormones, and she should be less than 60 years or less than 10 years post-menopausal. And all premature menopausal candidates are the ideal candidates for the hormonal therapy.
Shall I answer one thing?
Actually,
MHT is only for symptomatic people. Yes. If there are no symptoms for natural menopause, don't start MST. And if it is a premature ovarian insufficiency or surgical menopause, yes, you start and give until the age of the natural menopause. I think I made it clear. Don't start unnecessarily. Only for symptomatic patients it should be given.
International Menopause Society has produced a white paper last October 2024, where they mentioned that local application of estrogen can be done beyond the age of 60. Now, that can be done, which was not given prior in prior consensus.
But
Madam, we are coming.
I think when women have irregular
Madam,
periods.
Ambuja, madam, I have one question. Just now you told, like surgical menopause, we have to start MHT, hormone therapy. Suppose patient is less than 45 years, we did hysterectomy for some gynecological cause, and she doesn't have symptoms. Do we need to write on the discharge ticket itself, or let her we'll wait for the symptoms to arise and we will start?
In olden days, when we were postgraduates, we used to write like that. The minute you do hysterectomy, going home means it used to carry the prescription for hormones. But now it has changed. We'll wait until they get. But why I am telling surgical menopause is, many of the times hysterectomies are done very early for 35 years, 40 years, and so on. And these symptoms are more common, and with a vengeance it comes. So those people, we need to give a higher dose, and you should explain them and counsel them so that they will come back to us. Otherwise, they will think we are not responsible for that, because once uterus is out, the gynecologist is no more necessary for them. That's what is the impression. Instead of that, they should come back.
Whether it is anti-aging, somebody may take for anti-aging purpose.
Never. Take message is, you have done the oophorectomy for any gynecological cause, should not forget the patient.
It is not an elixir.
Should not give away. It should be properly counseled at the time of discharge.
whenever any symptoms can be
So counseling is
counsel
must.
and follow-up is the main guideline for
follow-up.
this.
Actually, the ideal indication, absolute indication for MST are only two in as per International Menopause Society: bothersome vasomotor symptom and genitourinary syndrome. And in USA and Australia, the third absolute indication is osteoporosis prevention, which is done, but it is not absolute indication in our scenario. These are the absolute indications.
So I would like to, excuse me, that's a very important point because we are talking about MHT at menopause transition. There are two areas of debate, what has come up. So the latest guidelines from osteoporosis guidelines from UK and International Menopause Society guidelines, the white paper. So what we say is, earlier we used to say only symptomatic women. Now there's a little change. In the sense, it is bone protection as well. So women who are at a high risk for fracture, even if they don't have symptoms, but are eligible. So that means the risk assessment of the woman for chronic diseases where your MHT is contraindicated, then it is safe to give even without symptoms. So that statement is that.
The bone health and
Yeah.
MHT.
And second is that early menopause, POI, unless contraindicated, it is a treatment. It is not supplement like we are doing at So similarly, between 40 to 45, you still consider them as an extension of POI. So you have to offer the treatment after a hysterectomy, especially if they are at a high risk of osteoporosis, high risk for cardiovascular disease, high risk for diabetes. Perhaps your hormones may be helping them better because you heard, if you have heard the oration by Dr. Anita, and she said that everything doubles. Yes. All the long-term problems double. So
nice point, ma'am. Oh, that should be in the discharge ticket, yes. Reserved or not. Yes.
Can I add one point? Yes. The latest which is coming up is now the endothelial dysfunction. The estrogens, they enhance endothelial dysfunction if it's there because it's a hypoestrogenism is a pro-inflammatory stage now. So that is why when we are starting with menopause hormone therapy, please be careful about the past history, about the genetic history. Even transient ischemia, it was there in that patient. These are the patients, when given MHT, they have precipitated with the CVD. Yes. I am one example here.
Okay. So
that's why I never forget. Mata, you people have asked me once. Yes. I did not realize at that time I had a history of transient ischemia, cerebral ischemia. It was diagnosed, thoroughly investigated, admitted, everything. Nothing came out. But later on, I had that CVI. And now I can correlate. Yeah. The inflammation is there in my body because I can feel it when I am having myalgia, pains and joint aches and everything. So that inflammation is there when, how do you diagnose it? That is where our science is silent now. That is why the adverse pregnancy outcomes are related to midlife health now. So we have to take those red flags. I think I'll be taking those red flags in my webinar when I'm taking that. Okay?
Any other audience question? Audience question?
And autoimmune diseases, of course, we are neglecting them, but they are also increasing the risk of CVD.
I think one more point, when we give oral contraceptives to regulate the cycles in younger age group, say 20s and all, they also have some issue with the hormones. I think this history, we should keep it in mind when they come for menopausal or perimenopausal complications.
Yeah. Who is there? Who is there? Yes, Dr. Aarti. Okay, Dr. Aarti from Barampur is asking another question. Okay, okay. Sir, after Aarti. Window of opportunity. What are the window of opportunity of starting MHT?
The window of opportunity is patient less than 60 years and less than 10 years of post-menopause. You have to start that early, and because after 10 years of menopause, it's not advisable to start.
It's a very good take-home message that we should start below 60 years and should be within 10 years of menopause. It is based on global censuses. Now, sir, you have a question. Mic, please. So you want to give, when the ovaries are removed, you should start right away from after the, okay.
Number one cause of mortality in the postmenopause is the heart disease. Compared to any other thing, that's what is the window of opportunity which we have to utilize. But for that sake, for prevention of that, we are not going to give the MHT. If at all, if we give it for vasomotor symptoms. Vasomotor symptoms means we should never think it is only hot flushes or night sweats. It is the anxiety maximum, because we did a study in the postmenopause. More than 50% they complained of the joint pains and muscle aches. And accompanying these hot flushes, these things are there, like body ache, joint pains, insomnia, sleeplessness, anxiety. These things also will be controlled, and they also will come under the vasomotor symptoms, so they respond very well. Unless there is a contraindication to give the hormones, all these things should be kept in mind and given, and there the window of opportunity helps both for the CVS and for the bone health also.
Any other question from the audience? Again from MKCG Barampur, Dr. Anuradha, please. Okay, very nice question. When to start, when to stop?
Anyone can answer.
Anyone?
Like once we have started, how long we will continue? Or
As I told previously that once it is started, we cannot forget the patient. When to start, whom to give, and how long to give, it depends on the symptom first. And minimum to continue, once started, it should be minimum for 5 years, or as long as it should be symptomatic. And during that period also, you have to follow the case, the symptoms is exaggerated or symptom is reduced, and how the patient is behaving with the MHT therapy. And if any exaggerated symptom, any side effect of risk also, you have to discontinue that. And it depends totally on the patient whom you are treating the case.
Any point from this side, madam?
After starting the MHT, you should assess the patient yearly, and if any new contraindications develop, like heart disease or diabetes, or then you have to act accordingly. Constant monitoring. So you have to act accordingly then.
In India, we will start MHT, but none of the patients will continue either more than 3 months or 6 months. Forget about 5 years. I don't know how many of you have given MHT for 5 years.
So what is your clinical experience?
Yeah, it's only 3 to 6 months they will continue. Once the symptoms are come down, they will stop it.
No, patients are...
Yeah, but 5 years is too big, because you have to do continuous monitoring. Even though you are monitoring, better to taper. Sometimes tapering is required to acclimatize the body. Sometimes the very working woman and too tedious worker, even other one in the rural area, they don't feel. Those who are sedentary, they feel more, and gradually they have to take up the dose, very short course and shortest possible time.
So clinician, as
Because
a clinician,
the disadvantages are so many.
so
But
maximum,
shortest means 1 minute. Shortest means how long? Means if you are giving the patient for 3 months, at least in a lowest dose, if it is not benefit, you have to give the more time. It is not that for 15 days or 1 month I will give the MHT, then I will discontinue. It is
Some
not
of the
helpful.
patients have requested for to continue, but of course evaluation is a must. And I have seen in my practice at least 2 years, and they are continuing with the evaluation.
Yeah, I have patients who are on MHT for the past 20 years as well. 20 years old as well. So, yeah, of course the segment is very, very small. It's not like, but most of them go on for 6 months to 1 year.
Now, my
and-
patients also have taken more than
Yes.
5 years.
So now the
if
message
the
is,
patients are benefited, they
it
do
is
take.
not time bound. So we have to, that doesn't mean that everybody will need for a long period of time. It is, you have to, annually you have to counsel the woman and decide whether they want to continue or not after 3 months, 6 months or 1 year. So that is the take home message, that it is not time bound and every woman, but always remember the risk assessment before you renew a prescription, whether the patient has developed any new risk which is a contraindication for MHT.
Yes.
So don't overdrive the MHT, don't underuse it.
that is the take home.
And actually I second you, because the patients, when they get relief from the symptoms, they themselves want to continue
They
it.
want to continue.
So this is another sect of
And
clients.
Jamuna, tell me if somebody is, no, tell me if somebody is on an antihypertensive or an anti-diabetic, don't they come back for a follow-up?
Yes.
They will come back.
So why not for a long-term treatment like MHT?
Next, Jasmina.
So any other audience
But
question?
everybody is scared about the hormones. Are the doctors not scared to prescribe? Yes, more than 5 years we don't allow them to go about. As Meeta said, the risk assessment at every visit is very, very essential. And another thing is, if they stop it, and if they get the symptoms again, restart. Nothing will happen. So, giving hormones up to the 10 years after the menopause or below the 60 years is very safe. And the recent guideline says you can continue after 60 years with a mutual consent from the doctor and the patient. And again, risk assessment is essential. And see if the patient is fit. And if she needs it, there is no other contraindication, you can go ahead after 60 years also.
Okay. Madam, this is my question. Like, we are Google dependent. We do Google searching. So, like, same patient has done Google search and she found like about WHI trial. So, as we know that post WHI trial, there is sudden drop in MHT prescription writing. So, how are you going to counsel about this WHI trial to the lady?
WHI patients were the average age of 67.6 years. So if you do Google, you have to do it properly.
Yes. So proper Google search is needed.
No.
So, to know. So madam, anybody can add, man?
Can I?
WHO results in the context of 40 years old symptomatic women.
Yes.
Only in the, out of the 4 arms, only in the one arm of the study that adverse effect was found. So it is out of the 4 arms. So this fact had to be brought into the, during the counseling, that it is what WHO has said is not sacrosanct. It has to be analyzed properly.
Yes, what sir has said.
Actually, WHI was in 2002 and there are many other positive study report after that. Now it is 2025. Why should we discuss?
Okay, ma'am. Rightly said, like if
See,
somebody is doing. Yes.
WHO is the only study that is a randomized control study that's being done.
Yes,
That is why it is taken as a standard even today. But extended studies are going on. The flaws with the WHO study is we didn't use the natural progesterone. That was a synthetic progesterone which is not at all necessary. Nowadays, we don't use it. And second is age factor. Many of the people who are selected were above 60 years, and it is the dose which is given equally to everybody. But now it is the individualization of the dose. That's why all the symptoms are
And all
very much
comorbidities were there.
controlled.
Patients were not evaluated. Actually, there were so many comorbidities. All
there,
were
there
taken.
are flaws in the WHO study. Of course, that is extended, that is study 10 to 15 years afterwards it is being done using the natural progesterones and natural estrogen. Even combined CEE estrogen also is a combination of so many forms are there. That's why the 17-beta estradiol is the best, and nowadays we are getting very good results, I think. But still, why we are quoting all the time WHO is, it is a randomized control study. It is still, it has not, no other study has beaten that, and we are continuing to refer that study.
Yeah, can I sum up
Yes,
the
ma'am.
discussion?
Yes,
So, yeah, I wanted to clarify a few points. WHI is still talked about because it involves not only the average age they have shown is 63, but the reanalysis, sub-analysis which is going on, huge database of 16,000 women, 7 years of the medicine that has been given. So the reanalysis is done on the younger people. That is between 50 to within 10 years of menopause. And that is how you have the grade A statement saying that it is safe in the younger people, and the WHI is the only RCT from where we are getting all this data. So it still holds good. All our statements are based on the WHI only, not from the observational studies. You cannot say that. So that is what I think the audience has to understand, that it is very, very important study. Second is the counseling.
Yes.
You asked how you're going to counsel. So we are not talking in medical terminology. The fear is about the risk of breast cancer. Maximum fear is about the breast cancer. With the patient, first thing they will ask. So what you're going to say is the chances of you getting a breast cancer is 0.8 in 1,000 women. And that is much lesser than being obese, which is almost 5 to 6 per 1,000 women. So this will go well with the so whether it is so you compare it that way. VTE, one of the things, it can be with any hormones. So I think the counseling has to be based on those absolute numbers rather than just,
Any question from the audience regarding breast
I just
cancer?
want to sum up this one. Like, if we are doing Google search, do it properly. Read WHI trial, initial trial, also read reanalysis trial. So already madam has told, percentage doesn't matter, but it is the absolute attributable risk, which is far lesser, less than 1 per 1,000 cases. So read it properly. So it's like the risk of breast cancer also depends on the type of formulation. It's not like WHO trial was done in old, outdated formulation. Now there are so many modern formulation has come up. So read it properly, and counseling or proper information has to be shared to the patient. Okay, any other question from audience side? So.
Okay, postgraduate, yeah.
I think this is one of the most important thing that you face in the clinician.
Yes.
And part of the question I've already answered. But first of all, before you talk to the woman about whether she should be taking or not, you should be convinced that she is the right candidate. Isn't it? That's most important. So first, how do you convince yourself that she is the right candidate? That means you're classifying that woman into 3 groups. Low risk group, the intermediate group, and the high risk group. So a woman who has no risk factors, so we have to do the risk assessment, and that is where, I was discussing with Ranu that we need to have our own risk assessment tool. So we at least follow the GALE, which is not ideal, but it is better than not doing anything. So do the risk assessment by GALE, and then you will come to a conclusion, what is a 5-year risk or a lifetime risk. So if that shows low risk, you can be 100% sure or at least 95, 98% sure that this lady, the MHT, is not going to cause harm. So you can offer any MHT, doesn't matter, CE, 17-beta estradiol, whatever fancies you. So that is for the low risk. But if she falls into the little high risk group, then you have to think twice before giving MHT, because you yourself cannot be convinced that MHT may do. So you have to balance the risk and the benefit for the moderate group, and then go for a transdermal, because it has seen that the estradiol, that combination has caused. But then again, you remember the WHI, the CEE alone in an hysterectomized woman actually reduces the risk of breast cancer. So if a woman is hysterectomized, then you're going to give her a CEE rather than a 17-beta estradiol. So there are a lot of fine nuances as to when you prescribe your MHT. It is not a simple yes and no. And so that is why you have to understand that first, and then the counseling is, even if you're taking a combination of a CEE and a progesterone, and that too a synthetic progesterone, that is MPA, which we are no longer prescribing. It is 0.8 per 1,000 in a low-risk woman. But if you are giving a dydrogesterone or a progesterone in the DOB study, which is also an open-label RCT, the chances of getting a cancer is not so much.
Madam,
so that is more friendlier.
Like what type of HT you want to, like perimenopausal vasomotor symptom? What are the hormone therapy you want to prepare?
Yeah.
And what
So
should be the
I
route?
said, if the woman is a low risk for breast cancer, low risk for any other risk assessment status you have made, you can prescribe CE, you can prescribe 17-beta estradiol. You have to finalize it according to the health profile of the woman. If the woman has more of, less of HDL, then you're going, or low LDL, high LDL, I would still prefer to go for the CE rather than the 17-beta estradiol. Okay. So the metabolic profile, you're going to decide which molecule you're going to give according to the health profile of the woman. So there's no blanket.
Ma'am, in transdermal patches, estrogen patches, is it
We
good
don't
for
have patch in India. We have the gels which are available. Yes, the transdermal gel are good because most of our women are overweight or obese. Okay. So in obesity, you prefer to go for the transdermal to prevent the VTE. Okay. But if somebody has gone through a pregnancy where the chances of 500 in 1,000 women and the VTE caused by the hormones is 2 per 1,000, so it's quite safe.
What about
See,
tibolone?
for the breast cancer and for the vasomotor symptoms, that is the hot flashes if it is there, for the high-risk patient, hormones is no. Either estrogens or progesterones, because though estrogens, according to the WHI, it has shown the graph that it is going to reduce the thing. It is going to stimulate the progesterone, what we are using to produce the cells, to grow the cells. That's why estrogens also are not indicated, and this is the recent study in 25 it has come out, not to give even estrogens if she has got a medium risk also. Now we have got the fizolinetant, that is the neurohormone, which is non-hormonal. This is proved to be very good. Still it is not available in India. Once it comes out, it is very good. And all other SNRI and SSRI are there, but the control of the vasomotor symptoms is not like estrogens. So whatever is said and done, estrogens are the gold standard for vasomotor symptoms.
So what estrogens, madam, you are going to prefer? Whether you depend on the uterus if it is present, if you are adding a estrogen, what are the progesterone will you want to combine in a continuous way?
That's what. Whenever the uterus is there, there is no question. You have to combine with the estrogen. Otherwise, you should never give hormones, because it proved giving simple estrogen even for 6 months, it is going to have the uterine hyperplasia and then cancers have come out. So you should never give.
Okay, madam is principal, Talcher Medical College.
The answer is, you say progesterol IUCD, especially at menopause transition. You are avoiding all other progestins as of now. The progesterones is what has been advocated because they are metabolically friendly and more, friendlier for the breast. And that is the progesterone, micronized progesterone, and the dydrogesterone. So these are the progesterones you're going to use.
And what about the estrogen?
What about the estrogen? Estrogen, I think, conjugated equine estrogen has stood the test of time. No, that is why I'm saying conjugated equine estrogen in a hysterectomized woman has in fact reduced the rate of breast cancer in a huge WHI. So you cannot just brush it off, but metabolically friendly 17 beta estradiol. So both the estrogens can be used, whether in systemic therapy or in the vaginal therapy. So both are good. Transdermal.
The LNG IUCD. So you are talking about LNG IUCD. So how you want to give LNG IUCD?
LNG IUCD, especially in those women at menopause transition, say they have already got an LNG inserted because of adenomyosis. We are using it quite often so that we are saving the uteruses. With so many AUBs at that particular Ragini's talk was very good. So there, when she's already on an LNG, and you just need to add on a estrogen when they have a symptom.
That is a good point taken.
Then you are going to, continue. But we are not still promoting giving an LNG in the post-menopause along with an estrogen. Okay. If it is already there, we are continuing it.
Yes. So if she is already there, LNG IUCD, we can add on the estrogen.
And one more thing that has come out is, for the medium risk and high risk patients, for CVD or for the carcinoma breast or for the DVT. LNG IUS also, it's not approved in all the countries. And like Australia, it has not approved LNG IUS for the high risk patients. It's only the normal patients where it can be used instead of oral progesterone or the vaginal progesterones. We can use the LNG IUS.
So we have an option
not for everybody.
So
it is still not agreed universally.
If she had LNG IUCD, we can add on the estrogen.
I have to add here one point. Excuse me. So estrogen, when the question of estrogen arises, there are so many routes to apply for the patient. You can go for the oral, but in my practice, most of the time I am preferring for the transdermal vaginal route or the gel route. And for the progesterone, it is always the oral route. And coming to the levonorgestrel, what you are asking for that one, intrauterine, it is a patient-based when there is a complaining of,
That point taken. Yes.
Madam, progesterone is always oral route, not necessary. It is micronized progesterone, you can go for the vaginal. Some of the people, they cannot tolerate oral, insomnia, or sometimes more sleep will be there. Yes, we can go for the vaginal progesterones.
Okay, well taken.
There's no need that oral only. Only dydrogesterone, it is not there vaginal, so you need to give the oral.
Do you want to advise any lifestyle modification along with MHT, or only MHT is enough for the patient?
Lifestyle modification is the first line of treatment, whether you give MHT or no MHT. So there's no debate on it.
So lifestyle from madam. So we can have an expert. If she has taken, yes, that is the only.
So many LNGIs, even in menopause already, we started down. Comorbid condition not allowing to do hysterectomy. That diabetes is severe, severely suspected, even endometrial carcinoma, not operated, not fit in those cases. Otherwise, all the normal patient will not like in our.
You are correct. For MHT, it is not advised.
And for lifestyle modification, I follow my two madams for menopause.
Yes, for MHT, it is not allowed. Not every country is accepting. But you can give it for irregular bleeding or adenomyosis or anything like that, you can give. Not for MHT.
Okay.
So we have.
Yeah.
Given a chance to complete.
Yeah.
Time is up.
So just one, you can sum up with this one, madam. Anything, put some light on this lifestyle modification so that it will complete like therapy to a menopause lady will get completed.
Lifestyle modification is the most and primary and the foremost first choice for the.
Everything is written here. They can.
Madam, nothing else.
Okay, we can move on.
One last question.
Proper diet,
Is there any
balanced,
study for,
balanced diet, exercise, regular exercise, and yoga and all these things.
Everything we are learning from morning, that lifestyle modification.
Yes.
First is to
And
that you have to be very happy and create your own world and create all the passion you want, and your dream has not filled. Create all these things in this period and create the friend circle to make you happy also. That is the most common, and be positive. And then after that any drug, anything.
Mita, is there any study where the duration of MHT affecting the woman after stopping it for her future events?
Yes, yes, there is. There are from the post WHI, lot of studies have come out as to what happens after they have stopped the treatment. So some of them, nothing happens. Some of them, age-related factor, the osteoporosis, the bone health comes back to the age-related loss for people who are on it. For breast cancer.
Does it have any influence on prescription of MHT?
Yes, it does. It does. Yeah. I think that it needs a little longer explanation. We'll have it later. But you people didn't go to the non-hormonal medicines.
Yes,
We were looking forward for the fezolinetant, especially for the breast cancer, high risk, not only survivors. All the women who are in the high-risk breast cancer or MHT not eligible.
I want to add one point here. Always the MST therapy with a prescription and by a consultation of the doctor, not by the Google search or self-medication. It is not a think of a joke that I will start the medication self and come back with the doctors with this side effect. It is a take-home message that whenever it is prescribed to anyone, it should be a consultant with that one, the gynecologist or the proper advice.
And also periodic monitoring has to be done.
Yes.
It should not like once we
And
start
follow up is surely to the, yeah.
Okay.
I think hot flashes are there even at 60 and 70.
Yes.
So I think the non-hormonal
First
prescription will be
initial
very
period, it is the 6 to 12 weeks we have to follow the case, and yearly we have to follow the case when there is the patients are in MHT therapy.
So we'll sum up with the take-home messages.
Fezolinetant has got some side effects on liver, hepatic side effects. So we have to study it before prescribing fezolinetant. It has got many side effects, hepatic side effects.
Okay. Sir has one question.
Okay, so the last take-home messages are, the MST remains the most effective treatment of vasomotor symptoms as well as genitourinary symptoms. The WHO trial findings do not apply to the healthy, symptomatic, less than 60 years or within 10 years of menopause onset. Transdermal estrogen and micronized progesterone offer a best safety profile. Individualize the therapy, right dose, route, and duration has to be seen, and regular follow-up ensuring safety, and that builds the confidence. So empower this woman with a good choice and good treatment. Thanks. So I thank all my esteemed panelists for the nice input.
Thank you, moderators and the audience.
Thank you very much for the moderators.
Thank you, ma'am, for
And,
active participation. And
thanks, Dr. Hara Patnaik and Madam Lakshmi Madam for scientific session. Chairperson for giving the opportunity to participate in this program. Thank you for all the audience for sitting and listening.
बुला बुला उनको सर
आगे I request our facilitators, Dr. Sujata Swai Madam and Dr. Jasmina Begum Madam, to felicitate our panelists. And to also our coordinator, Dr. Pramod Kumar Sahu sir. I request Professor Dr. Bharati Mishra Madam and Professor Dr. Sushil Kumar Giri sir to felicitate our facilitators. I request Professor Dr. Bharati Mishra Madam to felicitate Dr. Sujata Swai Madam and just. I request Professor. Thank you all. Now it's time for lunch session. For faculties, the lunch has been arranged at Suraj Mahal first floor and for delegates at ground floor. And would again meet here at 2:15 p.m. for the post-lunch session. We have got two mobile cell phones. Whoever has missed it, please contact us. Anyone who has missed their cell phones, we have got two cell phones. Please contact us. Cell phone ke hobby ta mili.
Hello. Hello everyone. Myself and Dr. Rajni Hajela, thanks for inviting us to Odisha. And we are from Bhopal. And we take this opportunity to invite you all to Bhopal for the National EZIMSCON 2026. So you are all invited to the beautiful city of lakes, and you will enjoy your stay and enjoy the academic session over there for the national conference. It is on 27, 28 February and 1st March. So we take this opportunity to invite you all.
Please, सब लोग आइएगा. It will be a very nice experience.
Madam, one medal to Dr. Jyoti. Jyoti, aa jao.
सब तो उठ गए लंच के लिए.
अच्छा एबे कौन ऐसे काम करता है इसलिए
हरा सर 2 मिनट आइए वो उसको फोटो लेना है.
हेलो हेलो
Hello.
बैकड्रॉप दे दियो बैकड्रॉप हेलो
Hello. Hello.
months. It's completely like, it looks like a different patient. So she really wanted to look young, and this is how we give a combination of all treatments. So now we are moving towards a holistic and integrative approaches. It's a combination of whole, I would say. So again, before and after improvement also is good in lubrication, tightness, as well as like, the pH is also decreased. So I would say the future we're going towards hybrid energy devices, neurodegenerative peptide therapy. Now AI is everywhere. AI-driven robotic cosmetic gynecological surgeries is going to be the future. And in conclusion, I would like to say for the post-menopausal rejuvenation, it's always the personalized protocols with multimodal therapies, where you do a surgery, we do energy-based devices, do a PRP with the nutraceuticals, hormones. It's on the whole, and everything is like personalized according to what the patient wants. And I think the future lies in patient-centered, ethical, and evidence-based growth. Thank you. And I would also like to invite you for CGCon 2025. It's the second cosmetic gynecology conference coming up in December in Chennai. So where we'll be discussing all the topics from surgery to regenerative gynecology to functional gynecology, menopause, on the whole up to the latest AI robotics and cosmetic gynae. So just take this opportunity to invite you all. Thank you. Thank you.
Thank you, madam. This was a very nice presentation. How often you have to repeat for vaginal atrophy, urogenital
The initial protocol, whether you're going for energy-based devices or the PRP, 3 sessions, where monthly you do 3 sessions, so this is for 3 months. And that effect stays for at least 6 months. So the protocol, what we say is once in 6 months, do a maintenance of 1 session.
Okay.
So early you'll do 2. But some, again, depends on each patient. Sometimes they come at the 4th month, they're saying like, I've got back my symptoms again. In that case, you can do at the 4th. Otherwise, as a protocol, we say 6 months once.
Okay.
Thank you. Any question we will discuss afterwards, but because time is short. So anything from audience can be asked to you personally.
Sure.
Thank you.
Thank you.
Next, I will invite Dr. Rasmi Das. He is Director and Chief Consultant, NAMS Hospital, Bhubaneswar, ex-Assistant Professor, High Tech Medical College, Bhubaneswar, and his special interest in urogynecology and minimal invasive surgery and infertility. And now he will speak on vault prolapse, which is a common complication after hysterectomy and any other vaginal hysterectomy. Now, Dr. Rasmi, please.
Very good afternoon to all. Respected chairpersons, my teachers, and my colleagues. After the high-end talk of vaginal rejuvenation, my job is to say a few words about the vault prolapse. It is a nightmare for all the gynecologists because once you do a surgery and patient come back with the word that your surgery has failed, actually it is a nightmare for all the surgeons. So first I give this credit to my teacher, Professor P.C. Mahapatra, who has initiated me into this gynecology subject, and another is Professor Raja Maheshwari, who has kindled the hope of urogynecology in me. The vault prolapse, usually the treatment options vary from laparoscopy or robotic route or abdominal route, sacrocolpopexy, to high uterocircal ligament suspension, sacrospinous ligament suspension, and ileococcygous suspension, and lastly the colpoclasis in old ladies. But it is not possible to discuss everything, but I will here highlight one thing is the modified high uterocircal ligament suspension. It is a innovation by me. It is a you can think it is a middle of the procedure between the high uterosacral ligament suspension and the Michael coldoplasty. So far I have done more than 500 cases, only 2 failure where no permanent suture was used, and in 3 cases I have to remove these permanent sutures, and there is no ureteric or bladder injury. 2 rectal injury happened, and it was addressed in the same sitting. So what goes wrong? Why we have a vault prolapse? As we know, Delancey has given the new concept of the vaginal supports. Usually we always discuss in our undergraduate, we discuss about these supports of uterus, but the era has gone. Delancey has given the new concept of vaginal supports. Actually it is the vagina which is to be suspended, not the uterus is suspended. Uterus is sit on the pericervical ring. So what goes wrong? Why we have a vault prolapse? Delancey has given the 3 levels of supports. One is the suspension. The uterosacral and macroendocrine ligament give the suspensory support to the vagina, and the attachment is the pubovaginal fascia and the arcus tendinous fascia, pelvis and arcus tendinous fascia, rectovaginalis that we know, and the fusion, the genital body, perineal body, the fusion support. So we always, whenever we do a repair, whether it is a prolapse or a hysterectomy, we usually in prolapse we do the attachment defect we always close, the fusion defect we address. What we don't recognize is the apical support. If you give a good apical support, then there will be no vault prolapse. Or once there is a vault prolapse, you have to correct it with a apical suspension only. So whatever route, whatever surgery you do, you have to give a good apical support. So route can be vaginal, abdominal or laparoscopy, that we know, but my aim is to promote a vaginal route so that it will be better. This is one of the top case I have done in Jamshedpur, where 70-year-olds with history of Manchester repair, then THBSO was done with rectus sheath sling, and then she has a ventral hernia repair, presented with vault prolapse. I have to address this with this method only. That surgery I will show you. It's not exactly that surgery what I have done in that workshop, but the same surgery I have to do. The important step is you have to open the peritoneum, that is vault peritoneum, it is very important. You have to give, very intelligently you have to give a bolt cut and to dissect and enter into the abdominal cavity. That is very important. Then I have to take the marking sutures for the future vault. It is at the same side, but suppose a patient comes after repair, then the vagina are very, because of the excessive cutting of the vaginal wall, it may be very short. In that case, I have to secure a new vaginal vault. But here, once you enter into the peritoneal cavity, then you have to fix the apical support with the uterosacral. Here, I use 2 supports to the uterosacral. One is a permanent one. Once there is a vault prolapse, you should not take another chance. PDS is a good option, but what I have seen is, if you give a permanent suture, it is not problematic. Once you are putting mesh, it may be problematic. But suture, you have to give, it is a permanent suture, proline, 10, you can give proline, one is PDS. 2 suture I give for the apical support. And important thing is, when you are taking the bite, you have to take care of the ureter. On the right side, you have to go away from the ureter. On the left side also, you are going away from the ureter. On the right side, you have to go away from the ureter. So one complication that you can injure the ureter, or there can be kinking of the ureter. But so far in my cases, I have not seen any cases of, because the fear is, if you are going very below, if you are fixing it to the uterosacral ligament at the lower level, then the chances of injury to the ureter is more. So it is better to go away. In the upper side, more cervical you have to go, cephalad you have to go, so that the chances of injury to the ureter will be less. And after you are fixing the suture, you can tie the suture so that patient can be lifted up. That is the only, you can assure that you have put the suture on the uterosacral ligament. Once here in this modification, the same suture I use from the right side and tie up with the peritoneum in the posterior wall. Then on the left side, you have to take both sides. Then if there is no associated cystocele or rectocele, only the apical suspension will take care of. But most of the time there is associated cystocele and rectocele. Here in this case, both cystocele and rectocele are there. So the next step is to, this is the cystocele. What I mean, that is usually what we all do. This is a repetitive procedure. But my point is, always give a apical support to your surgery. That's all. If you are doing a hysterectomy and giving a apical support by macal cholecystoplasty or by high uterosacral ligament suspension prophylactically, then there will be no vault prolapse. During cystocele repair, you have to always dissect up to the ramus. It is ideal. This is the plication of the pubocervical fascia. Usually one can go for a site-specific repair also, but result-wise there is no difference. So the cystocele repair is completed. Okay. Minimal excision of the vaginal wall. Minimal excision of the vaginal wall.
Oh, sorry.
So this is the rectocele repair. What we do, the colpoperineurophy, it is a similar procedure.
Oh, it's time up. Please hurry.
So ultimately, so the ultimate result will be like this. So the aim is to fix a apical suspension to every procedure, be it prophylactically during hysterectomy or in the prolapse repair, we have to do a apical suspension. Thank you.
So thank you very much. It's a nice presentation. So only we have to take the precaution that apical suspension is very much important. Only one case from our experience I have to share that recently we have done in our nursing home. The patient has come after TLH. Done in Manipal hospital, she had already prolapse of all intestine through the vault. Then repair done. Then the 2 more operations has been done. But recently she has come with total intestine came out as vault prolapse, and she has severe pain, and it was done in emergency. The intestine reposed vaginally to abdomen, then abdominally repair done with help of one surgeon, Dr. P.C. Mahapatra, and our surgeon, Dr. Rajat Pradhan, has done, and patient is now okay. It's a nice case, and we have never seen such a huge prolapse, like a huge bag, total intestine came through the vault. So thank you very much. We have running short of time to three of our persons online are waiting. So we have done, we will do one more presentation, Dr. Vineet Mishra, then after it will stop.
Thank you, madam.
Now I invite Dr. Vineet Mishra for his presentation on SUI surgical management. Over to Dr. Vineet.
Person. My condition is extremely precarious because we are into postprandial somnolence. After such a beautiful food which Odisha people serve, everybody tends to overeat and then undergo somnolence. I am here to wake them up. So, respected chairperson, my dear colleague, when you had a lecture on rejuvenation from a star called Deepa Ganesh and a surgical skilled person, both of them delivered, I will have some definitions, some of the videos which are there. I am trying to do this because this is an extremely common procedure to be done by almost every gynecologist who needs to master this. That's the definition of stress urinary incontinence affects around 35% people, and stress urinary incontinence or urinary incontinence is urge, stress, mixed, overflow, and functional. All four of them or all five of them have different symptomatology or different therapy, but all five of them are there in perimenopausal and especially in postmenopausal women. Clinical testing is urinary stress test, where you do Boney's test, lithotomy position, full bladder, and you ask them to cough. She leaks, and you put your index and middle finger by the side and try and press at the symphysis, and it stops. So then there is cotton swab test. Post-void residual is important because it helps you in two ways, that hiding prolapse histocele is there, which in your busy practice you have missed it. Post-void residual will come to your help. Second thing is, if patient is diabetic and has cystopathy, post-void residual volume is important. Then perineal pad test, urodynamic studies, testing, if available, is gold standard. Intrinsic sphincter deficiency test can be done with the help of dye test. Uroflowmetry, detrusor pressure, endoscopy, and imaging are the other investigation that could be done. For a woman who fails or declines conservative therapy, there are arrays of surgical options which are there. How do we choose a surgery? There are nearly 200 surgeries which have been devised till date for stress urinary incontinence. Experience of the surgeon and a surgery where, chairperson, where it was fixing up of the tape or fixing up of the tissue, those surgeries failed. So, anterior, which currently should not be performed. Anterior colporrhaphy with Kelly's plication. All of us thought that used to be when we studied, and probably most of us, when they studied, Kelly's plication was considered as treatment of choice for, and was done after every vaginal surgery. Failure rate was around 40%. Transabdominal paravaginal repair, which was done, that is site-specific repair, around 57% failure rates reported. Transvaginal needle suspension, like STEMIs, Pereiras, RAS, GIDS, which was there, that urethropexy, failure rate was extremely high after 1 year of follow-up. Retropubic suspension of bladder neck, especially with STEMIs, there was lot of failure rates. Then came in minimal invasive mid-urethral slings, which were considered as standard surgical management for stress urinary incontinence. TVT, that is tension-free vaginal tape, TVTO, and TOT. These were the surgeries which were minimal invasive, day care. They became the gold standard. This is the history. Factors influencing the choice of primary surgical approach. Coexisting treatable pelvic organ prolapse. You have pelvic organ prolapse. If you have not demonstrated that with full bladder, keeping the prolapsed uterus in its anatomical position and asking the patient to cough, you will have to repair a stress urinary incontinence in the same patient after you have completed the surgery, and patient brings in lot of dishonor to you. Medical morbidity and functional status of the patient. Diabetes, you have to differentiate between overflow incontinence and stress incontinence. Little leak in an overflowing bladder with lot of abdominal pressure applied to it, patient will mimic as stress urinary incontinence. Tension-free vaginal tape. Armstrong devised it, 14-inch long tape, which the borders were serrated. When you take the tape and if you see, if the borders are plain, well without serration, the tape might fail. So it has to have serration because it will cause micro-anchoring. TVT, can it be done under which spinal, local, or short GA? This is how the TVT tape looks like. Here you will see in lithotomy position, the lower end is basically pubic tubercle and half an inch above it, 1 centimeter horizontal incision is put in. In lithotomy position, the mid-urethra is dissected, and this is a 3 millimeter device needle which is of polypropylene is inserted from below towards the ipsilateral shoulder, and then it is passed, railroaded and brought on the anterior abdominal wall from both the sides. Cystoscopy is done to see whether the tape is passing through the bladder or not. And the most important step which you see now is putting a curved dissecting scissor and applying a pressure, taking out that scissor and closing the vaginal mid-urethra, the anterior incision, and cutting the top anterior abdominal wall, incision, suturing it. That is how the TVT procedure is done. What you need to do is, here we have seen that initially if you don't adhere to the insertion and taking the tape towards the ipsilateral shoulder, it can go through the bladder. We have treated such things. It is to be removed and a next prosthesis is done. Laterally it is put in and the thing is solved. Then came in the transobturator tape. The obturator anatomy is there, and this is the place where the safe entry zone is there, and the obturator canal is far away. So please don't get worried of any vascular catastrophe or any entry into the bladder. So here, lithotomy position, taking two helices at the side of the urethra, you have pinched them, and then about 10 ml of saline is put inside it, and you give in a horizontal incision. Now a curved dissecting scissor is put inside towards the insertion of adductor longus, as you can see this, on both the sides, and then a curved needle is there. You put in your index finger. This was the devised needle which was there, and then it is simply pushed in. The curvature is so devised that it skirts the ramus, and your tip, index finger, brings out the tip of the needle, which has an eye. You put in the tape there, and then you counterclockwise rotate, and the tape comes out from the area which is basically the obturator, through the obturator membranes. Similar thing is repeated on the opposite side, and a curved dissecting scissor is put into it, and another 2 minutes. Then it is put into, the curved dissecting scissor is put into, and tension is adjusted. The midline incision is closed with 20 Vicryl. This was an Indian tape which was devised at the institute, and the tape which is available, which is called Freedom, VM from the Lotus. The VM stands for Vineet Mishra. That is what this company people named the tape. It is widely used. More than 1.5 lakh procedures have been done. This is how the tension is adjusted and the anterior vaginal wall is closed. TVT embryo. What you saw was lot of tissue. Tape is there inside the patient's body. TVT embryo is a prosthesis that comes from J&J. And here only half of the material remains inside the patient's body, because they thought it was proved that the material which is there caught by the obturator membranes, muscle, is the one which fixes. There is no fixation needed. And if you see, midline incision is put in, a guide is put there, and then this is the needle which has a plastic coating around it. Through the guide, this needle is pushed in and it is rotated, which comes out through the pre-decided incision which was put in. And what I want all of you to see is here where the needle which has come out, here, which is probably in the middle of the obturator foramen. And once you saw the outside-in procedure, that was skirting the ramus and it was on the lateral side. So here there are chances that you will have little pain appearing post-operatively in the patient. Here you have a sling which is attached so that your tape doesn't move away on one direction. It is repeated on the opposite side, and same way tension is adjusted after putting not a dissecting scissor between the tape and the urethra, and then the anterior vaginal wall mucosa is closed. Laterally, the tape is cut in a way that it falls below the skin, and one single suture is taken. What happens is TOT and TVT, if you see, here is this dotted is TVT and the solid line is TOT. TOT mimics more like what it mimics the normal pivourethral ligament. If you are doing a TVT and if it rotates little laterally, there are chances that you will have femoral vessel injuries. These are some of the complications which are there. Advantage of TOT over TVT is that you don't need to do a cystoscopy. It is gynec friendly and it is a short day care procedure. Review of literature always shows that TVT and TOT almost have similar outcome over 5 years. Cochrane database also says the same way. We had, our group also did a study and it was published. This is basically the Freedom VM tape which is available, and we had 3 years of data which was there. Results were satisfactory. Friends, stress urinary incontinence in perimenopausal and postmenopausal scenario is a big market. If you simply ask your patient, do you leak? if you cough or have you to run to the bathroom or loo, you will be aghast. 30% of your population will say yes. Medical and physiotherapy, if it fails, this 10 minutes procedure will help her to regain her life. Thank you very much.
Thank you, sir. Thank you very much for a wonderful and crisp presentation on TOT and TBT. And it was a very nice lecture, but we are running short of time, so we are concluding. And we are going to have a lecture from our speakers from outside. It is online lectures.
I request chairpersons and speakers of this session to please sit in the audience. Now we'll be having the panel session, and international faculties will be joining us online. The remaining sessions, video session will continue after this panel discussion. So now we will be having a panel discussion on care in menopause, changing horizons. For this, our moderators are Dr. Maninder Ahuja Madam and Dr. Sasmita Swami Madam. And our experts are Brigadier Dr. Suraya Rahman, Brigadier Dr. S.K. Ratha Sir, and Dr. C. Ambuja Ma'am, and Dr. Maya Padi Madam. Yes, ma'am. Yes, ma'am.
Okay. Then if I come here. Good evening, everybody. Where do we stand? Up, welcome to everybody, along with my co-moderator. I still don't have my presentation here. So in the meantime, I'll be saying welcome to our international faculty, our president, Dr. Suraya Rahman, President SAFAMS, our immediate past president, Dr. Saida Batul. Please unmute yourself, Dr. Saida.
Hi, hello.
Yes.
Greetings from Pakistan and SAFOMS.
Yeah, and Dr. Jinnat Nasreen from Bangladesh. Yeah.
Hi everyone.
Unmute yourself.
Greetings from Bangladesh.
And then we have Dr. Harsha Attapattu from Sri Lanka. And from Nepal we have Smriti. Smriti, where are you? We can't see you. Please, Smriti, go. Hello. Give her entry to Dr. Smriti from Nepal.
Hello. Hello, ma'am.
We can't see you, Smriti.
Okay, let me see, ma'am, what I can do.
Okay, my presentation is here. So, we are today from the South Asian Federation of Menopause Society, which was founded in 2010. And we have had the presidents from Pakistan, Sri Lanka, India, and taking into consideration time period, I may not mention their names. But now we have President Dr. Suraya Rahman from Bangladesh, and immediate past President is Dr. Saida Batul, and Vice President, who will be President-elect later on, will be Dr. Harsha Patu from Sri Lanka, and Jinnat Nasreen from Dr. Sasmita, you know, she is HOD Department for OBGYN, Cuttack, and she's a very senior, renowned gynecologist, and she will be talking on basically on the contraception later on and on the role of vaccines in the perimenopausal and postmenopausal period. So, welcome to all the delegates who are there, and it's very heartening to see all of them so vibrant, and I bring greetings from Haryana, which is vibrant state of active Haryana there. These are just a few glimpses of photographs from Sri Lanka, from Pakistan, from Raipur, from Bangladesh, where we had our biennial SOFAMS conferences, so these are all that. So when we talk about women, we have from India, Dr. Atul Munshi, and our experts, Dr. I'll be introducing them later on. All of the CVs will be there. Woman is not a chapter. She's a book of lifelong changes. So it's a continuous process that goes on. It's not an event menopause. It's a dynamic event. So not a chronological age will define it. That is very important. So we are all here sharing the pursuit of excellence for the advancement of health of midlife women. And we would discuss today is just a trailer of what we have to do for the women's health in future. So it's just the new horizons which are opening up. It's a never-ending process because we still don't know kahan shuru, kahan khatam, where the life starts, where the life ends. So it's like that only. So the fact is that we are living in an aging population, but is it a healthy population? No. Number of menopausal women is increasing, about 1.6 billion in the world. And in India, age of menopause is 6 years earlier. So all the problems, they start earlier in South Asian countries. And even the United Nations Decade of Healthy Aging is there from 2021 to 2030. Because every person in every country should have the opportunity to live a long and healthy life. Just guide me. Where should I keep my face so that I can see the screen and my back doesn't turn up? Can anybody guide me? I'll have to change it. Yeah, we are not shown now. Just the slides are being shown. Please change the view. Yes. And if please change the view. No. Where is the camera? Where is the camera? This is the camera? The PPT is not visible. But then I can't look at them. Anyway, it's okay. We'll manage it. So what we are going to discuss today is basically what the World Menopause Society on the World Menopause Day, 13th October, has advised that lifestyle medicine offers a foundational evidence-based framework for equitable menopause care. Integrating these strategies into clinical guidelines and public health policy can improve quality of care, empower women to manage their health, and reduce disparities in access. Collaborative action among healthcare providers, policymakers, and communities is essential to maximize the impact. So the first part will be concerning what the organization should do, what the government should do. So new concept is now that the hypoestrogenism is actually a case situation of chronic inflammation. So lifestyle changes, including balanced diet, regular exercise, and stress management are key strategies to help mitigate inflammation during this time. So this is what the World Menopause Day, 18th October, the International Menopause Society gave a call that we should have lifestyle medicine in menopause care as the management of menopause. Of course, we are not going against the menopause hormone therapy. MST will be there wherever indicated. But it should be supported by healthy eating, mental well-being, restorative sleep, physical activity, minimizing harmful substances, and healthy relationship. So to discuss all these things today, we have our panelists, our senior most, Dr. Atul Munshi from India, Dr. Saida Batul Mazhar from Pakistan, Zinat Nasreed, Dr. Harsha Taputi, Smriti Maski, and as experts, Brigadier General Suraya Rahman, Brigadier S.K. Rath, he is there, welcome sir, and Dr. Ambuja, where is she? And Dr. Maya Pari. She's Brigadier General Professor Suraya Rahman was the president of South Asian Federation of Menopause Society. I have already heard. Saida Batul was immediate. She is the president now, Dr. Suraya Rahman. Dr. Atul Munshi is very, very senior and very respected gynecologist, and he was the past president of Indian Menopause Society. Harsha Atupattu is from Sri Lanka, consultant obstetrician and gynecologist, D. Soysa Hospital for Women, and he is the vice president, senior vice president of SAFOM. Dr. Churanur Ambuja is a respected senior gynecologist from India. Dr. Smriti Maski. She is the President-elect of EZIMSCON, Menopause Society of Nepal for 2024 to 26, and Women's Health Expert. And Professor Zinnat Nasreen is the Vice President of the SEFORMS. So all of these are now going to talk about this, and we are going to start with our pioneer, our sport, Dr. Atul Munshi, who will be talking about healthier diet, because healthier diet patterns are associated with reduced risk of cardiovascular disease, colorectal cancer, type 2 diabetes, preventing weight gain, lipid changes. We know all of this is there. And there are different types of diets going on, so that sometimes confuses us. So Dr. Munshi will be highlighting what are the changes which are coming up, why do we have to nutritionally critical phase, menopause has to be a nutritionally critical phase, what dietary changes should be brought up, what vitamins should be added, so how these are going to help and in what condition they are going to help us. Please be brief only, because we have other...
Long back, Hippocrates has said that diet,
yes.
long back, Hippocrates
Are
has...
you able to listen, Dr. Zinnat? You are muted. Harsha, can you listen? All of you? No, you are muted, we can't listen you.
Long back,
Okay.
Hippocrates has said that your diet should be medicine,
Or
rather than
slides are
medicine
not
should be your
seen.
diet.
Slides.
And this is very true for both ages, the very young age, adolescence, and at the menopausal age. As it has been mentioned, there is a lot of changes in metabolism, the body mass index, the dietary habits, the food, and other things. As a result of which you require a very balanced diet, which is sufficient of macronutrients, that is carbohydrate, fat, and protein in a proper way. And complex carbohydrate is one thing which should be given. Polyunsaturated fat should be utilized, and sufficient amount of protein should be there. And this is necessary because of various other things also.
So, as Dr. Munshi said, because of estrogen loss, we have the redistribution of the fat, and we need the more of proteins because of the energy balance and muscle building which has to be there, because muscle loss is very much there in the, how much of calcium and vitamin D?
Calcium is very important for prevention of osteoporosis, but the treatment should not start at menopause. It should start quite earlier. Minimum amount available to our normal patients is about 600 to 700. The ideal should be about 11 to 10 to 12 milligram per minute. That should be there. Along with other micronutrients, B complex should be always be there in the body. And vitamin D3 is also important, because sufficient sunlight is not there. Our customs are such that they always go with the full light. They are not able to do other things also. As a result of vitamin 3 is also important for this. So macronutrients as well as micronutrients, both are important for this.
What about soya, flaxseed?
That is basic phytoestrogens, which are normally we are eating, and that is the normal Indian diet which we are doing. As you said, in the Western countries, especially in Japan, Asian country, where the number of other side effects are also less, because they consume more of soya proteins.
Slides are not seen.
Other important part is hydration, because in these cases people don't take sufficient amount of fluid. So that is also important, sufficient amount of fluid during daytime. Evening time we advise not to take too much fluid, so they may not have to get up too much frequently. So these are important parts.
A very important question, Dr. Atul Munshi. Taking diet for a month can make a difference, or it has to be a long time, lifetime course of the dietary adjustment? From the very beginning we should be doing, or we should just change that we were not taking it. So it will take a longer time if we start doing in the...
No, you have to make a complete list. These are the things you are supposed to take whenever
Yes,
patient
you said
comes
the
to you.
first issue which you raised was that we should start these dietary modifications much earlier. That is very, very important. And they are needed in the menopause. Now, Dr. Choran or Ambuja, there a patient Savita comes, her BMI is 28. She's hypertensive. She wants to control her diet, she wants to control her hypertension also. But how as a gynecologist? Because I am not going to ask you to give a specialist diet, but as a gynecologist, what sort of diet you are going to give? Yeah, I'm just.
Hello. Yeah, she's hypertensive, so she wants to control her BP with the diet. First of all, nowadays we believe in Mediterranean diet. Means lot of plant-based diet where we eat lot of fruits, vegetables, and even oil, plant-based oils we eat. And finally, the top of the pyramid is only any sweets, sugars, or anything. But we have to reduce the sweet, salt, everything. And second is, it should be anti-inflammatory diet. That's the one which we should follow. Actually, combined diet is always very important. Next comes the DASH diet, that's specifically for the reduction of the hypertension is advisable. Of course, our Indian diet we should never forget, because all these things are available in the Indian diet. So please follow the diet which is available in the regional phase. And the third very important thing is, we Indians, most of us, whenever we get the time, we'll start munching something. Instead of that, we should restrict the time-restricted diet is very important. Our olden days, people were following the Ekadasi, not to eat on Friday or Saturday, something like that it was there. Now we forgot about all those things. That's why the time-restricted diet. Need not be that it is a 24 hours time restriction. Need not be a 24 hours time restriction. It can be 12 hours or 16 hours, but sticking on to that is very important. Not following 1 or 2 days, but stick on to that one. Follow the diet that is available, like millets, ragi, vegetables, fruits. Instead of going for the non-veg like mutton, chicken, if you follow in post-menopausal age, that's a very good diet, and hypertension also will come down. Along with that one, as Maninder preaches every day, do exercise, do meditation, and have your own me time. Then only the social thing will be there, and you will get the everything, anxiety will be controlled.
So, thank you, Dr. Soran. The basic thing is that we have to restrict our carbohydrates, take more of proteins, but then added vitamins, calcium is required. But of course, along with that, whenever need exercise is to be added. Because diet alone is not going to help. Very important point they have raised. Yes, sir.
Last thing is, don't restrict diet. It is the intelligent inclusion of various diets. That is important at the time of menopause. And small frequent feeds will be better than long fasting or irregular meals.
Yes. So it should be a balanced diet.
Fluid is also very important in this group. Because of something, they restrict taking fluid, water, because going to the toilet or bathroom will be painful. I already said about that. Yes, you showed that. And that is also very important.
Well, there's a little thing which these days people are talking about the intermittent fasting. What is this kind of, because in that case, we will have a very late breakfast and early dinner, so that the digestive system goes into rest for about 12 to 14 hours. So that is one thing which...
Sir, yes, sound nahi aati,
yeah, this is intermittent fasting is coming up in a big way from various in the part of yogic and all. So a late breakfast and an early dinner will cut down, will automatically bring in that intermittent fasting.
Yes, sir. The thing is that I have gone through various diets and I find that all of them are actually controversial. But we are doing in India, Indian diet is much better and with high fibers and all these. We should not be munching in between and taking snacks which are high in salt, and this is one thing. Future is of the nutrogenomics, that is just one slide. Nutrogenomics is the study where we are changing our, which relies on the DNA, transcription, metabolics, and proteomics. So whatever food you are taking, nutrients from food, carbohydrates, sugar, everything, that goes through DNA, changes mRNA pattern and the proteins, and those proteins which are converted into metabolics, then they can help you to prevent those cardiovascular diseases and cancer. So that is the future of the diet only. I think so that's a good point. Here we end. So choose a Mediterranean or a vegetable-based diet, include calcium-rich food, cut back on processed food, like everybody said, add more plant-based meals for heart, bone, and weight benefits, and try soya foods. And as Dr. Sasmita said very rightly, fluids have to be taken in very, very right quantity. Now we come to very, very important point, that is the menopause in the workplace. Globally, women are 7 million, 45 to 59 years, maybe 1.6 billion are also there. So many, 50% of this population is in the working place. So our problem is always where to reach our women. So these women are there in the various posts, in the administrative jobs or even the labor jobs also. So despite changes, demographic changes, we have working for the adolescent, we are working from the antenatal health, but where are the women where we are working on the menopausal health? So this omission has critical implications for workforce sustainability, organizational productivity, and national economic resilience. And women do say that they have problems related to workforce, and sometimes they want to give up, which they should not give up because they still have the responsibilities. So to address this issue, we have Dr. Harsha Atapattu from Sri Lanka. Sir, Anubhika, 56 years old, she is near age of retirement, because our age of retirement is 60 years. And the women start working from 20 years. So whole of the menopause transition and menopause is in the workforce only. So these women have, might be she has back pain while working, weight, or she has some psychological issues when she feels that she needs leave from the work, but she cannot tell people because of the stigma attached to menopause, that I am menopausal, so I need special help. So Dr. Harsha Atapattu, please highlight what are the changes the women are undergoing and how you have to, you suggest the working environment should be changed or the government policy should be changed.
Thank
Dr.
you, Maninder.
Harsha,
Now,
yes.
Yes. Thank you, Maninder. Now, for someone, the menopause may be just mood swings, anxiety, panic attack, low confidence, cognitive changes, but they are not minor inconveniences. There are debilitating chronic symptoms that can directly undermine a woman's ability to manage workload, especially a woman who you described, a 60-year-old lady who is doing a lot of work and with multitasking. So this will undermine the ability to manage workload, lead teams, communicate clearly, and meet the deadlines. Not because the women are not capable. As you said, they are not just a page, that they are a book, but because her health is not supported, which comes with menopause. And there will be reduced productivity, not because lack of skill or motivation, but due to mental exhaustion which comes with menopause, and difficulty in concentration and disturbances of sleep. And increase absenteeism, or they are that presentism, but where they are physically present but not able to function optimally, and withdraw from leadership and role of career progressive, and confidence dips and stigma sets in. And there will be social isolation, as women fear judgment and reluctant to disclose their struggle or feel misunderstood by younger colleagues or male supervisors, and can be particularly harsh in high stakes, fast-paced environments where emotional regulation, mental agility, and multitasking are expected in a woman's daily life. The reality is, many women suffer in silence, fearful of being perceived as less competent or being discriminated against due to age and because of the hormonal changes. So for this, what we should do and what we should actually do in the workplace and create a menopause inclusive workplace. We must start acknowledging the full spectrum of menopause, not just the visible symptoms, but the emotion, cognitive, and physiological burden. So for this, we need to do education and awareness programs, so normalize conversation about the menopause at work, and just, it is not a
Harsha, you are muted.
And then the mental health both offer access to counseling and peer support groups, and menopause is informed what it is there, and women's need safe and space to share and seek help, and training to manage equipped leadership, especially male supervisors, to understand what we have been doing so far. We have been trying to educate women and the healthcare workers, but in the process we lack we miss the men being educated, or they getting incorporated into our system of in the process of empowering women. So this is very important, and there are few things women themselves can do. That is, while they are in the workplace, they can do hydration and cooling. Now we have spoke, Dr. Atul Munshi and you, Dr. Maninder spoke quite a lot on about nutrition and movement. Maninder's motto is always do exercise, work, eat well, have the rest. That so the mental well-being and medical support is very important. So what the healthcare personnel can do to integrate menopause into education, into routine checkups, provide clear, culturally sensitive materials for self-care, life tips, and train the grassroots healthcare workers, who we call the first point contacts, to be more aware of what is going on, and to include the mental health screening as part of the menopause care. It is a whole body, whole life transition, but it is not just a symptomatic approach. So what we should do in tools, training and communication for managers, there should be awareness training and toolkits for the employers as simple particular guides for the managers, and very important to have flexible policies like flex time to medical appointment, adjust duties, and access to quiet rest places for fans and officers where they can rest a little bit, and inclusion of menopausal in well-being programs of health and insurance.
Thank
An
you.
open channel of communication. And just for the last, the Manita really wanted a take-home message to be given to all the participants, that it is a three-way partnership. Can I go to the last slide?
Yes, this one, take home message.
Yeah, that is, yeah. Women need knowledge and tools to manage their symptoms confidently, and the healthcare providers must offer accessible and stigma-free care. And workplace must provide supportive, flexible environment when menopause is not a secret, but shared human experience. So let us remember this and provide and make a better place for women who carry out quite a huge burden in the society. And without a woman, a man can make a house, but a house will become a home by the work of a woman only. Thank you.
Thank you, Dr. Harsha Patu. And you told me that you had a meeting with UNFPA also. So some national bodies are taking up these issues, and it's time that at the level of SEFAMS, we also start taking these issues at the workplace of women, because the 50% of the menopausal women are in the workplace only, and by doing the good collaboration of healthcare providers, workplace people, and the women, we can give the women empowered women and skilled women an opportunity to continue with their work. So thank you very much. So now we come to a very important case. We'll do a little discussion because I think we'll be short of time. From Pakistan, Dr. Saida Batul. This is the issue which I raised in the morning also. What is the most common cause of mortality in midlife women? Is it breast cancer? No. It is cardiovascular disease. But we are not aware of that. We are aware of the cancers. We are talking about that. So, but CVD is the leading cause of death in the, and there were the new theories, new red flags which have come up, which have now recognized, starting from David Barker in 1990, that the adult diseases, they had the fetal origin of adult diseases. So there have been, for the fourth trimester extended care, because there was white paper by International Menopause Society 2023 into the reproductive milestones and adverse pregnancy outcomes which cause the CVD risk in the later on. So Dr. Saida Batul, Akhtar Begum, 45 years, she comes to you complaining that she is gaining weight. Irregular periods, checked her blood pressure, it was 140/100. And on inquiries, she gives family history of hypertension in father, diabetes in mother. She gives history of hypertensive disorders of pregnancy. Now this opens a Pandora box, new red flags for CVD risk factors. What are those risk factors? Because we know well-established risk factors, that is hypertension, diabetes and obesity. We have to know now about what are these sex-specific risk factors and under-recognized risk factors and menopausal symptoms and menopause-related metabolic changes. So this is the...
Thank you, Maninder.
Yeah.
I think this is an excellent introduction into the role of cardiovascular disease and the worry that we have. So the well-established factors you already mentioned, we know to have metabolic syndrome, you need at least two conditions. You have hypertension, you have diabetes, dyslipidemia. That means you have some sort of a metabolic syndrome. These are established. But the sex-specific factors is if a woman has a history of preeclampsia, if a woman had a previous eclampsia, she had previous IUGR babies. There are things that we used to ignore. So it is very important that these sex-specific history, and I think we need to highlight in the first page you mentioned, there's now that FIGO passport, pregnancy passport, and that needs to be, we need to get into that, because once the pregnancy over, we forget it. We don't come for follow-up in the South Asian region. They only come with the next pregnancy. They miss out on the contraception. They miss out on the diabetes screening at 3 months. They miss out on whether the hypertension was settled or not. And then you have that menopausal risk. Those women who have more hot flashes, have a very bad experience of their menopause, they also tend to later on have more Alzheimer's, more problems. So these are various markers that we tend to miss. Women who have PCOS, who are now, they are metabolic syndrome at a young age, and midlife they're going to get worse. So I think these are things we need to think of and make people aware. If a woman had placental abruption in the past, if she carries that, and I'm very excited about this pregnancy passport. It's just been introduced a couple of years. But when I went through it, I said, this is such a good thing. It is digital. And I think, Maninder, we need to champion this at our level as well, and at all people who are working in reproductive health. So these are important risk factors which we have to think of.
Thank you.
There are under-recognized risk factors because somehow we take obesity so lightly. Everybody in 30%, 40% of people in India and Pakistan are obese. So we just don't take it as a serious thing. And a child being born IUGR, we think, oh, this child will pick up. But that child is programmed for hypertension. That child is programmed for obesity. And we are not aware of that. So the socioeconomic conditions, the intimate partner abuse, the poor health, poor literacy of women, they are all adding to so many problems that somehow our women are bogged down, and woman like Mrs. Akhtar we are talking about, this is so worrying that with her family history, with her personal history, we have to act quickly, control her blood pressure, look into whether she's also a pre-diabetic. If she's BMI is not right, let's work on it as well. So there's so many things to be done.
Thank you, Dr. Saida Batul. So this opens a window of opportunity for all of you. When you have to prescribe MHT, please look into her history of adverse pregnancy outcome, her history of PCOD, menstrual cyclicity, hypothalamic amenorrhea, miscarriages, IUGR, low birth weight, preterm birth, because all these conditions, they show a endothelial dysfunction, and this endothelial dysfunction, if present, will cause the CVD in the midlife women. So these red flags should be taken into our history taking now, That is very, very important if we want to. And at this time, we should identify women and take them, empower them with the proper management of blood pressure, weight, diet, nutrition, exercise. Call them back again and again after 3 months. Then after 6 months, 1 year, every year, if gestational diabetes, you have to call them back again. So what is our opportunity now? This is our opportunity, maybe from the school health program, maybe from the extended postnatal care, maybe from the perimenopausal transition, but that is occasionally patient come to us with abnormal uterine bleeding out. So we have to look into red flags for the then secondly, don't forget immune factors like rheumatoid arthritis, systemic lupus erythematosus. If they are present, they are also going to cause the menopause, cardiovascular disease, metabolic problems later on. Now we come to Dr. Zinat Nasreen from Bangladesh. A woman's relationship with menopause is complicated. 3/4 of women in the United Kingdom feel that the menopause has caused them to change their lives, and that say it has negative effects of their life. So what is the partners? They are feeling helpless. They should also be involved. Social system should also be involved. Or when the personal interrelationship problems are there, what should they be doing? So sex can be off the menu for many of them. 42% of women say they just don't feel like doing it. Husbands come and complain like Ajit Vistel, she doesn't want to do, she says, I don't want to do. So these are interpersonal relationship, social relationship. So what do you have to see about these, Dr. Zinnat, about these
Well, thank you
relationships?
very much. Thank you very much. Greetings from Bangladesh for all. Well, this is a very good question. Well, because good relationships is one of the important pillar. I mean, one of bedrock for happiness and overall well-being of menopause women. And that is why IMS has incorporated this good relationship in the lifestyle medicine recommendation. So good relationship is not only with the husband, actually. She should have, it is always better if she has good relationship with her friends, colleagues, children, neighbor, and of course husband or partner. So we know that when women and men age and the sexuality diminishes, it is obvious. But for women, it is more pronounced because of dramatic change of estrogen deficiency. And that is why sometimes there's a disharmony between them. But it is also important that there should be good relationship, good communication, mutual support. Sex is not always, though it is an important bridge for harmony, but at the long way they came together, they have to understand each other, they have to respect each other. And they should
please a little loud. Yes.
Yeah, I am telling that they have come across a long way together. So sex is not all, though it is an important bridge for the harmony, but they have to respect each other. Their relation should be on love and respect, mutual support, lifestyle adjustment, and the professional guidance. So they can manage themselves with having such good relationship in that way. At the same time, women should understand, men should understand, and if they really feel dyspareunia, and because of this dyspareunia, GSM, if the woman is really feeling that she can't have sex, definitely she should come to the providers. And the important thing is that most of the women in this southeast region, they're very oblivious, they're very silent, they don't open up. So healthcare providers have an important role to ask them, and if there's a problem, there's lots of solution. So at the end, what I want to say, that if dyspareunia or other sexual problem, there's definite very good treatment. I mean, cognitive therapy, couple therapy, local hormone, and so on. And so, but most importantly, they should love each other with the respect, with the bond, and with the mutual understanding, and change their lifestyle pattern. And women should give them the empowerment. Thank you so much.
Yeah, thank you. So all of you realize that the interpersonal relationships between the husband and wife and the society are very, very important. Now, even as a gynecologist, as surgeons, as a healthcare providers, we are busy in our lives. So what is the time when we get to each other, especially when the woman is passing through that stage? Most of the husbands don't even know what the menopause is meaning to them. So we have to perhaps train them also, that is the time. Now we come to the very important, the central adiposity is increasing. So, Dr. Smriti, because the patients don't come with a play card that I am suffering from this thing. Bano visits you, she is slow in walking, BMI is 28, she is a little difficult in breathing. When she gets up from the chair, she takes 4 of arms of the chair. What could be the possible issue? So please hurry up because we are short of time. So how we are going to, just case introduction, quickly you take your diagnosis and then the management. Dr. Smriti?
She couldn't join. She couldn't join.
She could not join? Okay.
No, she wrote
this
in
thing.
her.
I'll skip this case for the time being because it is about that patient is having sarcopenia and we have to diagnose sarcopenia when the patients are coming to you, when they are sitting you, they are difficulty in getting up, they are difficulty in walking, they are slow in walking, they are bent in walking. You have to diagnose sarcopenia and start giving the patient proper advice about osteoporosis also, sarcopenia also, and proper training in exercise also. That is very, very important. So, this is the take-home message, highlights early signs of functional decline. That is when we should catch up the patients at early times of functional decline which is there. So slow, regular, structured exercises, every woman can regain strength, stamina and confidence, and it should not be only aerobic exercise, it should be resistance and weight training also. So these are the community clubs which we should have for the elderly for their exercising programs. Now we come to important topic of sleep disorders. That will be, yeah, Dr. Suraya Rahman, please in short explain what are the sleep disorders and how you are going to help these women, because I think there is a problem about the audio also. You are
Bangladesh
muted.
And thank you,
Dr. Suraya, you are muted.
For focusing on the 6 pillars of lifestyle medicine. Yes? Can you hear me?
Yes.
Can you hear me?
Yes.
Am I audible? Yes. Hello?
Yes, madam.
Hello?
Yes, yes.
Am I audible, Maninda?
You're audible, you're audible.
Can
Please
you
go
hear me?
ahead.
Actually, they have muted Harsha and...
Yeah, okay. So I just want to thank the moderator for focusing on the 6 pillars of lifestyle medicine in menopause care, which is the theme of the World Menopause Day this year. It's an important and very relevant topic, especially for the low, middle income country like ours. So I have to talk briefly on sleep, to be more precise, restorative sleep, which refers to the quality of sleep that leads to improved daytime activities and overall well-being in general. I'm going to address this issue from a broader perspective to give you an insight, a deeper insight, and shall try to stop at time allotted. Can you start to the beginning? Can I have the slide
Not
for
audible,
the first,
not
Maninda?
audible.
Not the...
Yeah, slide is seen.
Okay, last one. This one?
Yeah.
You start from the beginning, please.
Okay.
Yes. No, it is not the one. The first slide, please. Can I share my presentation?
These ones?
No, not the one.
Introduction?
Not the one. The other one. The blue.
Introduction. Whatever I'm showing here, it's being delayed. Now it's there.
So sleep plays an important role in maintaining good health and well-being throughout life. During sleep, body works to support brain function and maintain physical and mental health. It is recommended that all adults, including older ones, need sleep between 7 to 9 hours at night. Children and teenagers may need more. So sleep disorders are conditions that affect quality, timing, and amount of sleep a person should get in a previous night. So there are many, over 80 sleep disorders that can impact your quality of sleep, your timing of sleeping, whether you have regular difficulty in failing to sleep, If you feel tired during the day, even after sleeping at least 7 hours the night before, or it becomes difficult to perform regular daytime activities. The next one. So the major categories of the sleep disorders are given by the International Classification of Sleep Disorder. This is the latest one, the third edition one. They are insomnia, circadian rhythm sleep wave disorder, sleep-related breathing disorder, central disorder of hypersomnolence, and parasomnias. The next one, please. If you want explanation, I will do that later on, if there is time. And among the over 80 types of different sleep disorder, the most common are chronic insomnia, obstructive sleep apnea, restless leg syndrome, narcolepsy, shift work sleep disorder, delayed sleep phase syndrome. And the REM sleep behavior disorder. We don't have any statistics or any study. It is the statistics given from the American literature is 100 million Americans of all ages report of not having an adequate amount of sleep. So what are the causes? The next one, please. It could be the medical condition like heart disease, asthma, pain, or a nerve condition. It could be a depression or anxiety disorder. A mutant gene could be responsible. The medication that you are taking every day, that could be responsible for, then the stress, excessive stress condition that you may be facing. Then substance abuses like sedatives, caffeine or alcohol, and the night shift workers. So what happens if you don't get enough sleep? So there'll be difficulty in learning, remembering or making decisions. It's basically cognitive changes. The personality changes like irritability, there'll be lower reaction time, accidents more happen in these patients. Sleep loss can also contribute to the development of health conditions like depression, obesity, diabetes, and heart disease. Next one, please. So for the diagnosis and test, sleep diary can be maintained, which gives you a details of one's sleep habits. You can keep a smartwatch or a device called Actigraph that can review the cycles of rest and activities. And sleep specialists can perform a sleep study called polysomnogram if the problem is chronic or difficult. So the next is, there are several types of treatment options like proper sleep hygiene, melatonin supplements, and use of continuous positive airway pressure or implantation of neurostimulator for sleep apnea, and light therapy. Then medications which are, the supplements which are offered are for insomnia, a group of medicine, other group, and for narcolepsy, we give stimulants or wake-promoting medications. Next one. So the most important thing is focus now the take-home message that how to get enough or better sleep. So we have to follow a regular sleep pattern, wake up and going to bed at about the same time each day, even on weekends, maintaining an environment that promotes sleep, quiet, cool, and dark environment, white noise or earplug may be used, meditation or slow deep breathing exercise before bed, a warm bath, a soothing music, or a reading may help. We have to avoid the electronic gadgets, any electronic readers, smartphones, computer screen, or TV. And we can put it on the night mode setting that will reduce display light while using in the evening. We have to avoid caffeine and nicotine throughout the day because the stimulant effect of caffeine can last up to 20 hours. Avoid chocolate, sweets, or excessive alcohol at least, or a large meal at least 3 hours before bedtime to avoid sleep disruption and weight gain. We can set aside a worry time during the day so that these do not arise at night. Avoid using bed only for anything other than sleep or intimate relations. Exercise every day if possible because it will improve sleep. No nap after 3 p.m. And if you do not fall asleep within 15 minutes, get up, leave the room, and go to some other room to do something relaxing like reading, listening to a quiet music, and return to bed when you're feeling drowsy or sleeping like. If your sleep is disrupted because of your partner's late night activities or snoring issues, then we have to consider solutions. So these are the needs that I have offered. And if you need, take help of the professionals or the sleep experts or the sleep specialists in these cases. Thank you. Thank you for your
Thank you.
sharing.
Now just one question for the audience. How many of you have sleep problems? Raise your hands. Be honest. Be honest. Again, be honest. I'm raising my hands. I can raise 2 hands also. So what I advise is stop counting what you earn during the day. So
I
that
do
will make
agree
the
with
sleep-
Maninder, because whenever we call you, you are ready. Whenever we call you, at 12 o'clock, at 2 o'clock, 4 o'clock, any time, you are ready to answer the phone call at the first instance. So I know you are sleep deprived.
Okay. So don't do that. Sleep is very important. So I'm looking better because I now look into my sleep. That is a fact.
Yes,
it's
you
a
are
fact.
correct.
If you don't get up from your bed before 6 hours of sleep, at least 7 hours of sleep. So I am keeping my watch just to look at this thing. Sleep in the morning, how many hours I slept. If I have not slept that many hours, I'll again put my cover on my head and try to go to sleep. At least I'll relax. So thank you very much. I think it was a very enlightening sessions about new things. Interpersonal relationship, then sleep, diet, exercise, all these issues they have been taken, which we were, and basically red flags of the before prescribing menopause hormone therapy. Please mark your OPD cards now with these new red flags so that you don't prescribe MHT when it's not indicated. Thank you very much. Now I'll hand over to my co-moderator who have been waiting there patiently.
Thank you, Dr. Mahendra, for the excellent panel discussion. So now coming to the very pertinent fact, many of us see a woman in her mid-40s in the menopausal transition, still potentially fertile, but unsure of her safest and more suitable contraceptive. Let us explore her options. So this is the case. Dr. Munshi sir. So she is 46-year-old, para 3. She has mild hypertension and her menstrual cycle is little irregular, but BMI is 27, little obese, and the past contraceptive use. Oh, slides is not visible. She has discontinued oral pills 2 years ago due to irregular bleeding, currently using Udral method. Her FSH is 18 international unit per liter because she came with amenorrhea. So is contraception really needed at 46? Is fertility already very low?
46 is one time when you can give any type of contraception, provided you know the whole history, what she has taken, what she has not taken, is she requires any other thing also.
So even in 46 also we have to give some contraception.
Yeah, comorbidity should also be ruled out.
Yes.
She should have irregular cycles or other thing, whether she is menstruating or not, because when menstruation occurs, unfortunate pregnancy can also occur. So that's why you have to be careful about it.
So yes, though fertility declines markedly after 40, spontaneous ovulation and pregnancy remain possible until menopause is confirmed. 1 to 2% of women more than 40 years may still conceive. So unintended pregnancy in this age group carries higher maternal and fetal risk like hypertension, diabetes, miscarriage, chromosomal abnormality, and also the mental condition of the mother is very much depressed. Hence, contraception is recommended until 12 months of amenorrhea after the age of 50 years and for 24 months if less than 50 years. So after menopause also we have to...
At least for 1 year you should give it.
Yes, 12 months. If it is less than 45, then for 24 years. So our next question is to Dr. Hasapattu sir. What are the preferred contraception options for Mrs. R?
I think the best would be the cost-wise, because they are having less fertility. Condoms will be a good option if they are liking that. And the other thing that comes into my mind is the intrauterine contraceptive device,
Yes.
because
So she is 46
this is not the
years,
time to manipulate with the hormones. So better to go for something
So LNG IUS is an excellent
non-hormonal.
choice in this age group. This controls the heavy bleeding, provides endometrial protection, and can be continued till menopause. And also, if she is not willing to take that, we can also give POP or DMP also.
Yeah, and if she has heavy menstruation, the LNG IUS,
Yes.
the Mirena will be a very good option
So
because
everybody,
that
we are in
protects
a
the
dilemma.
endometrium
Can
as well.
we use combined contraceptive pills in this perimenopausal woman? She is 46 years old. So this is Professor Saida Batul Majha from Pakistan. Madam, can you give her oral contraceptive pill, combined pill? So Ambuja madam, can you enlighten? She is 46 years, without any high risk factors. Can you give her OC pill? She is 46 years, without any high risk factors.
See, if the patient is fit, without any comorbidities, no smoking, and should not be fatty. Her BMI must be between 23 to 25, and such patients, yes, we can use.
So in carefully selected healthy non-smoking
Not
women
hypertensive,
up
not
to 50
diabetic.
years,
It should be controlled.
Yes.
Yeah.
So use low dose 20 to 30 microgram of ethinyl estradiol formulations, check blood pressure, BMI and deep vein thrombosis risk.
Once upon a time, it was a contraindication because high doses pills were used. But now, preferably low dose pills are available with 30 and 20 micrograms. So I think we can go ahead, especially countries like ours.
So to Dr. Jinath madam, so how to transition from contraception to menopausal hormone therapy?
Well, yeah, thank you so much. It is very important, you know, when they're on oral contraceptive pills, then they are having less, oh my God. So if I don't know which type of contraceptive she's taking. If it is oral contraceptive pill, it is better not to give a MHT because both of the estrogen will be higher for her. But if she's on norgestrel intrauterine system, that is Mirena, probably it is the best. In that case, if she's symptomatic, then we can prescribe, if she's symptomatic, particularly vasomotor symptoms or genitourinary syndrome of menopause, then we can prescribe her low-dose MHT with discussion with the pros and cons and shared decision.
Thank you, madam.
So, thank
so
you.
if she is on LNG IUS, we can retain and provide the progestin component of MHT, so we can keep that. And just don't.
Right.
She's not there. So
Can I tell one word? Now, estratrol is a compound that is the placental estrogen that is coming out, and that is used now as a contraceptive which can be used in the perimenopausal period. It is not available in India, but it is in Australia and America it is available, estratrol combination.
Yeah, and it is less thrombogenic.
And natural progesterone combined.
So what if the lady has additional comorbidities like diabetes, obesity or migraine?
Ma'am. Okay, so this is something left for you.
Thank you.
Thank you.
So use WHO medical eligibility criteria for individual as the case. COC is contraindicated if vascular disease, smoking or migraine with aura is there. Progestin only or LNG IUS safe in diabetes, obesity and hypertension. Non-hormonal methods like copper T and barrier method remain fallback options. So how do perimenopausal guidelines guide us in decision making? FOXY GCPR 2023 recommends individualized selection, progestin IUS as first line for women with heavy bleeding and discourages DMPA more than 45 years. WHO MSc 5th edition, age is not contraindication, classify according to the comorbidities. And IMS practice points 2024 emphasize integrating contraception, bleeding control and menopausal symptom management in one plan. So we have to integrate everything and plan the contraception in those moments. So this is for Surya madam. For women using HRT, is contraception also required?
Yes, I think if she is on combined HRT, which cannot be, considered as an contraceptive, and women on contraceptive HRT cannot be advised to rely on this contraception only.
Yes.
So the next option could be a progesterone-only pills with HRT to provide effective contraception. And I think a better or a good option could be intrauterine system like Mirena, and eligible women under the age of 50 years, combined oral pills as an alternative to HRT can be given.
Okay, thank you. So only HRT is not a contraception, we have to add something.
Yes, I think so.
We can use this encounter for preventive health counseling. So during this period, we can screen the woman for breast, cervical and metabolic health, discuss with her regarding the bone health, cardiovascular risk as madam discussed beautifully, lifestyle modification, and reinforce that perimenopause is a time for contraceptive protection, preventive screening and preparation for menopause. Take-home message, what do you mean?
Okay. Yeah.
So Anna, this is a case number 2. She is Mrs. S, 47 years, para 2, living 2, menstrual history, irregular cycles, occasional skipping 1 to 2 months, moderate flow. She has symptoms of hot flushes and premenstrual headache. Medical history, she has history of migraine with aura for 3 years, smoking 5 cigarettes per day. She is borderline dyslipidemia, normotensive, and current contraception she is not using, she is using the withdrawal method. She wants a reliable method till menopause with minimal hormone if possible. Yes. So what are the safer contraceptive choices for that lady? Atul sir.
Mirena would be one of the good choice for this.
Yes,
You
so
can put
Mirena
it.
will be the best
And-
choice for her. And as madam told vasectomy, the male
Yes.
partner should also take some responsibility.
Tubectomy or vasectomy is another alternative.
Yes. But we have to empower the woman, so she has to take some. Can she use combined oral contraceptive? Ratha sir, she is
better
having
not.
migraine
Better
with
not.
aura. Can she use the oral contraception?
Not contraindicated.
It is not contraindicated, you have already written because.
So yes, so migraine with aura is MEC category 4. It is not acceptable. The risk is much more. So she cannot take OC pills. If she chooses the LNG IUS, does she still need to stop it after menopause?
No, you don't have to.
No, not necessary.
So
Let it
not
be.
immediate removal is required because she is
Yes.
also having heavy menstrual bleeding.
For 1 year you associate, you can keep it and then you can remove it.
Yes. So LNG IUS can stay up to 5 years and if inserted more than 45 years may remain till menopause. It provides contraception, endometrial protection and can form the progestin component of future MST if systemic estrogen is added. Sir, how do you confirm menopause while on hormonal contraception?
Suraya madam.
So check FSS twice 6 weeks apart. If both is more than 30 international units, then she is menopausal. So she is having so much of contraindication, migraine, smoking, hypertension. So how to handle her vasomotor symptoms and migraines while she is using progestin only contraception?
See, lifestyle changes is one of the important things we must
sir.
take care of.
Yes, sir.
And there are other methods, other newer things have also come up.
So non-hormonal
Non-hormonal
options.
treatment.
Yes. SSRI, SNRI, gabapentin or clonidine for hot flushes. For migraine prophylaxis, maintain hydration, avoid triggers, use prophylactic agents if needed. Reassess yearly once menopause is confirmed.
Excuse me. Hello, can I just say one point here?
Yes.
Why don't you consider the low risk lifestyle measures
I
here?
am talking about tomorrow.
Yes, Madam Dr. Surya, yes.
नहीं कल के लिए बोलना है क्या तो अच्छा है तो बोलो.
Dr. Suraya, please, again.
Yes, Madam.
Yeah, the low risk lifestyle measures and non-prescription strategies. Why should we don't keep in mind?
Migraine. She said about the migraine, those should be reduced.
Dose. So this is the last. This is Mrs. Y, 55 years old, occupation housewife, medical diabetic, previously vaccinated with HPV vaccine, has come to you for a pap smear. Is keen to know about the routine vaccinations she should take. I think we have one session on vaccination, so just one slide. Atul sir, please highlight what vaccination you will advise if a perimenopausal woman comes.
Commonest is influenza in this age because it is repeated attacks, and after corona, lung problems have increased like anything.
Yes.
So every year, influenza should
That
always,
is
that is
every
one
year
important
she
thing.
should take, yes. So
And
Tdap booster dose should be taken. Pneumococcal vaccination singles, that is herpes is also.
Sagal is shingles.
Yes.
That is another thing which is to be taken care of at this age.
Yes. Influenza.
Ideally, all vaccination can be given. Patient is working, then you have to give it vitamin B also.
Sir, what about HPV? It was being discussed in the morning. Can we give HPV vaccine?
HPV, if there is a possibility of contact or something else, then we have to give it, not routinely. Age is 43. Age limit is 43.
If the patient didn't have any screening throughout her life, she
No
didn't
need.
have any vaccination, should we give her now?
HPV, no.
So that is another school of thought. Perhaps, sir, what do you say?
No,
So we have another session on adult
in the
vaccination.
menopausal year, no. In the perimenopausal year, up to age of 43, it can be given.
So thanks to our panelists and experts for this discussion.
Special thanks to our faculty from SAFOM's country, Sri Lanka, Dr. Harsha Attapattu. Please raise your hands so that people can see you now nicely. Dr. Suraya Rahman from Bangladesh, our president. Dr. Zinnat from Bangladesh. And Saida Batul is there. Dr. Smriti was not able to join. She is our young upcoming menopause specialist from Nepal. So thank you very much to all of you for being so contributing. And I think these are the topics we should continue later on in details also. Sir, do you have to say any comments? Dr. Horda,
my only comment is, when you asked
Dr. Askarta, do you have to make any comments?
kind of HIV researchers sadly passed away.
On the whole, sum up about menopause.
What was the question?
Yeah, we are closing the session.
See, one important thing is proper nutrition is an important part of the menopausal treatment. And as I said intelligent inclusion is important. As far as contraception is concerned, you do require contraception up to 1 year after menopause. And various options are available, you can do it. As far as vaccination is concerned, influenza vaccine is a must, HPV vaccine is only up to 43, and singles, another thing, SOS when it is necessary. Tetanus whenever it is necessary, if there is injury or something. Yes, pneumococcal is added to it, but it's slightly costlier. Everybody can't afford it. That's a problem.
How many of us have
Influenza
taken?
taken by everybody.
I have taken.
You are a rich person.
Anyway, how many of you would like to learn more about the menopause? Raise all of you hands. All of you want to learn about menopause now. At least not for yourself, for your better half's sake, interpersonal relationship. So we have to update the husbands also about the problems of menopause. Families have to know, society has to know, workplace persons have to know. It has to be recognized as a thing to
Already we are behind schedule and we have to wind up the session, madam.
Yes.
That's
Thank you, madam, for the fruitful discussion. Now I request our moderators, Dr. Maninda madam and Dr. Sasmita madam, to felicitate our panelist, Dr. Atul Munshi sir. Now I request our experts, Brigadier Dr. Asker Ratha sir and Dr. C. Ambuja madam, to felicitate our moderators. I request Professor Dr. Tusakara sir and Professor Dr. Lucy Das madam to felicitate our experts. We'll continue with the video session, that is genitourinary problems in midlife. For this, I invite upon stage our chairpersons, Dr. Jayashree Patnaik madam and Dr. Nirmala Pipara madam and Dr. Shushma Verma madam to the stage. And now the talk will be on UV prolapse, and Dr. R.K. Purohit sir will join us online. Now it's over to our chairpersons.
Hello.
Now I invite our next speaker, Dr. R.K. Purohit. He will be
Yeah.
speaking on uterovaginal prolapse.
Can I share my video?
No? Is he here?
Yeah, I'm there. Online.
Okay.
Good afternoon to you all.
We cannot see you.
Your sharing is not turned on. So, if you can help me. Anybody who can help me? Yeah. Hmm?
We cannot see his Ask him. We cannot see his picture.
Yeah.
Yes.
Is there? Yeah, my video is there. Is it coming?
Yeah.
Is there video?
We can see the picture of the operation.
Yeah, thank you very much. So I'll show you the how to.
We could not see your face, sir.
Okay, I don't know how to. Mute video. Yeah, I don't know. No, I cannot. I don't know. Anyway, I'll tell my topic. So, see, this is a case of valve prolapse. I'll show you in case of a large prolapse, you see how we can plan. So, planning is when the uterosacral is coming outside the hymen, we do go for a vault like the suspension operation, like on the sacrospinous fixation. So this procedure I will show you. So after the vaginal hysterectomy, cystocele repair, enterocele repair, then I am going for a hydrodissection, holding the vaginal wall longitudinally below the ball closure suture, and then give saline, then a vertical incision just to cut the vaginal wall. Then dissect the rectum and mobilize the rectum from the vaginal wall. Otherwise, the rectum will be dragged toward the ischial spine. So, we will go for a sacrospinous fixation. So, only cut the vaginal wall, cut by a scissor, mobilize the fascia, mobilize the rectum, and then by a finger, we can go for a finger dissection and toward the tip of the spine. So this is mobilization. Mobilize the rectum, otherwise it will be dragged towards and sometimes you may have rectal problem. So this is very interesting. We will show you how to get clearly the ligament. Now see toward the tip of the spine, this is a rotating movement, perforate the rectal pillar. So this is a very much splitting operation, and then put the speculum, insert the speculum through this rand we made. Then by a devour retractor anteriorly. So this technique I will show you how to get a sacrospinous fixation in case of a vault prolapse or when the uterosacral ligament is seen outside. So you will have to hang the vault to the sacrospinous ligament. So take a suction cannula, metal is better, and mobilize from the lateral wall. And this one you will have to have rectum retractor. This is a Brisky retractor. And see how in a different patient, not the same patient, how you can clearly see you have retracted the rectum, lateral wall, and by this suction cannula you can dissect. I think you are able to see the video properly. So this is how to mobilize the fascia from the lateral wall and this rectum. So by this rectum retractor, mobilize the fascia and see the ridge. One ridge is seen, this ridge, and that is the ligament. Yeah, that is the ligament. So you can bluntly dissect by a suction cannula, just little pressure, and get the white-like, fiber-like structure. This is the ligament. This ligament we will have to hold properly by Alice forceps. Many times people, the doctor, they fix the thinking that this is ligament, they only suture the fascia, that is why there occurs a failure. But here you see, you keep little jerk and see the patient is moving. This is the bearing the load, and that is the ligament. Again it confirmed by a finger whether there is a continuation of this ligament toward the spine. Then take a Deschamps suture carrier. This suture carrier will insert. This is a different patient. And see we are holding the ligament. One hold, pull. So there occurs a curvature. Just below the curvature, insert. This is the strong ligament. At this time, you can also little pull. So this patient will move. So this is 100% confirmed. And then this loop, there will be two pairs. So two loops of suture will be there. This will fix to the bolt. So proper anchoring of the suture to the ligament is highly required. So under vision, isolate, dissect, then do it. And you will have to have a Brisky retractor, rectum retractor, only then it can be possible. Then take a Alice forceps which is atraumatic Alice forceps. Now see any bleeding is there, and you can coagulate with a bipolar if there is a bleeder, and then pull all the retractors out and fix to the bolt. So this is how we can have a better fixation and go for a subcuticular fixation, subepithelial subcuticular. So this will give a very good outcome, and this patient will have a better. See, such a big prolapse, this even after repair, even after everything, still this vault is outside, and these cases they require fixation. They require anchoring to the ligament, bony point. So anyway, but only this sacrospinous fixation also is not sufficient. In a case of big prolapse, we will have to have repair of the cystocele, antrocele, and then uterosacral, also the high plication. These are all required because the middle portion of the uterosacral is stretched one in a case of prolapse. So that does not function. So you will have to regain the strength either by a small mesh or go above that, the mid portion, high plication. So this is how uterosacral, cystocele, antrocele, and then sacrospinous fixation, composite repair. So composite repair if you do, then only this patient will not have a recurrence in the future. Otherwise, only fixation may tear sometime, so we will have to have all fixation. So this is how subcuticular. Then close this rand we made below the suture line with a 2 suture, 1, 2 suture, so that this vaginal one incision is closed. But complete closure we don't do, just below the, or you can say a part of the upper part of the rand will be made open, so that you can, during the suture tightening, this suture will enter in and it will not be exposed. This is a proline suture we have given, this proline number 1 for the sacrospinous fixation. Now we will have a 7 throws. So 7 like 3, 2, 2 like this 1. So in that way you can have knots, 6, 7, more than 5, 6 knots you can give. And this is the place. You take your push and it will go to the level of almost the spine. So this is how we can fix and go for a fixation. So in cases of bulb prolapse, in cases of big prolapse like procedentia and other, you will have to have this fixation, otherwise there is a chance of recurrence. And this, our technique is a splitting technique. So there is no cutting, nothing. You just know the split and you get the ligament, then fix. So it does not fail. Otherwise, only and take this Deschamps thread carrier under vision. With a needle and needle holder, you may puncture the vessel, puncture the nerve sheath, and this patient may have a problem. But with this, in this sort of technique, even this patient will not have backache. Backache is a common side effect of this operation, but if you properly encircle the ligament, then and suspend and anchor the ligament, then she will not have backache. Now again go for this perineal repair.
Sir, kindly sum up, if you sum up, because we are running short of time, sir.
Yeah, it is over, madam. It is over. It is the last. So this is the post-op. On 5th day, you can have this sort of features, and the vault will be 2 phalanx above. So, so this much is the. Of course, I could not show my face. I don't know how, but this is the video that you can. I think you have enjoyed this video, and anybody can practice.
Sir, very nice presentation of. Sir, your camera is switched off. Kindly start it. And it was a wonderful presentation of rectocele repair, sir.
Yeah.
Kindly switch on the camera, sir. Connection khatam ho gaya. I think it is this.
Yeah, you can proceed. I think I'm not an expert in this. I don't know how. Is it okay? No.
Thank you, sir, for your live demonstration of the surgeries. Thanks a lot, sir. It was a very wonderful presentation. Now we are going to start our next lecture on vulvectomy. Our next speaker is Dr. Ashok Kumar Padi, and he is going to speak upon vulvectomy.
So it's not visible. So good afternoon, Revert chairpersons and my faculties present over here. So today I'm going to speak and give some tips and tricks to the audience, especially to the youngsters. Because what I feel, nobody is a born surgeon. Nobody learns from mother's womb. It is years of efforts, it's the years of toiling, so many years, and years of sleepless nights that will help you to become a surgeon. It's not a one-day job. So with this background, so first of all, we tried with vaginal rejuvenation for vaginal atrophy. Second thing is a valve prolapse, which is a failure, because failure comes to repair of that prolapse. And third is should not be ignored, that is malignancy. So most common one of these is for this midlife people is malignancy. I think people are not happy with these tough situations. You need to treat these situations by surgery. So today I am going to the tips and tricks. So one should be, before any surgery, you must know about the anatomy and the staging of any cancer. For treatment, maybe a surgical modality, maybe a radiation, maybe chemotherapy, whatever it may be. Two things are very important. One is anatomy, second is staging. So you should be thorough about the staging. I'm not going to details of the theory because of the running short of the time. So I will only highlight on the silent points. So this is the tricks. For stage 1A vulval cancer, we need a simple vulvectomy. That means we will take skin and superficial fascia. That's the only thing. Radical means you have to go over all the layers with adequate margin and adequate base. Adequate margin, what do you mean? To up to the inferior layer of urogenital diaphragm, that is just above the bone, when you are able to feel the bone. So that is the depth, that much of depth you need to require. Along with that, you have a wide margin. So this is my simple tips for. And I think all of you are aware of vulval anatomy from the first year MBBS career. I am not going to details, but you should know where the vessels are there. Because you take one during the excision of this the vulvar cancer, you may encounter some vessels. So you should be well taken care of. These vessels, they are very important. You may have to tie dorsal artery of clitoris. Along with that, in this caudal lateral part, you may encounter internal pudendal branches of internal pudendal vessels that should be taken care of by tying or with a vessel sealer, whatever device you have. So relevant terms I have already described. So today I am going to go radical vulvectomy on two cases. Margin is the concept of margin important for oncology concept, and at least 1 centimeter margin for radical vulvectomy, so that you can in a fixed specimen it comes to be 8 mm in a pathological specimen. So the surgical tips, I'm doing in one page I can to describe proper vulval incision and marking, adequate margin, dissection up to inferior of urogenital diaphragm, ligation of suspensory ligament of clitoris with vessels in the cranial part. At craniolateral part, the dissection of adductor fossa is encountered. At caudolateral part, you encounter the internal pudendal vessels that should be taken care of. At the caudal part of posterior vulvar tissue is dissected from the perineal body. You should be very thorough because you may injure the rectum. That should be kept in mind while dealing such cases. At caudal part, dissection process over the rectovaginal septum and tension-free margin. That is everywhere it is required. Maybe in episiotomy, tension-free margin closure. And flap reconstruction is required if it is required. So with this background, I have two cases to show. I will take maximum 7 minutes. Boss, video is not coming. I think. This is a vulval lesion of around 2 to 3 centimeter. So first point is mapping and planning of incision with adequate margin. You have to plan it properly, preoperatively. So in the OT also you plan it, then you go for hydrodissection with normal saline and adrenaline, because that will delineate the tissue plane in a better way, so that can have a good margin, good delineation of tissue planes. That is important. I will only tell the tips and nothing more. So you take a margin, at least 1 centimeter margin. You see? So my scalpel, my blade is 1 centimeter away from the margin. So that is required. It's very easy. It's not a difficult job. So the most important problem is when you're dealing in the vaginal side. It's really difficult because you have to take adequate margin, 1 centimeter margin. And near the urethra and clitoris is a really difficult job. That should be taken care of while dealing such cases. So you see, this is 1 centimeter margin. Then I'm going to dissect it layer by layer. You may start inner incision with adequate margin is very important. Either you start from inner side or from outside. It's up to you. Doesn't matter. So either you can use a blade or you can use a cautery, monopolar cautery. It's up to you. So after taking the margin, you hold up the tumor tissue, the cancer tissue, and try to give a traction with this cautery. That is very important. At the same both you traction with the Alice forceps, along with that you cut with adequate margin. That is very important. Up to inferior layer of urogenital diaphragm. So the white structure that comes in your way is nothing but inferior layer of urogenital diaphragm. I think this is a small closure. Here primary closure is achievable. Without tension you can achieve a primary closure. Primary closure means there is no need of any flap. So if the gap is more, you may need a flap, you may take the help of a plastic surgeon. But here it is not required. It is simple apposition. You are just appositioning both the margin. That's all. So very simple. So proper apposition of both the margins without tissue tension is your motto, should be your motto. So that is achievable with the primary closure here. But if you are dealing a large lesion or the large cancer, vulval cancer, then definitely you have to take the help of, because that is primary closure is not possible without tension. In that particular case, you need to take a flap. You see the margin of at least 1 centimeter from the cancer. So coming to the second case, I cannot fast forward otherwise, because we are running short of time. This is view after primary growth. I am coming to case 2. This is a larger lesion, larger growth. Again, the same principle of hydrodissection with adrenaline in normal saline. And then I am mapping of almost 1 centimeter, you see. Again, so you may use a cautery, monopolar cautery. So the thing is that you have to take care of the hemostasis, very important, particularly 2 to 3 areas. More important one is near clitoris, where we need to ligate the dorsal artery of clitoris, and another is the caudolateral spaces, caudolateral region. That means you are encountered with the internal pudendal vessels. So your motto is to go up to the inferior layer of urogenital diaphragm, that white structure that comes in your way, just above the bone. So try to feel the bone. If you try to pull bone, the fascia over the bone is nothing but that is the inferior layer of urogenital diaphragm. So you can use a bipolar or vessel sealer if they are trying to take care of the vessels. So another maximum 2 minutes I will take. This flap surgery, this is a big gap. So after taking out the primary tumor, you have a big gap where primary closure is not possible. I think there will be much tension if you are going for a primary closure. So what you need to do is that you need a flap. You need to put a flap in that area. For that, initially we took the help of the plastic surgeon. So gradually assisting lots of cases with the plastic surgeon, we ourselves are doing. And many times Dr. Giri is considered as a pioneer for this flap surgery, what is called a lotus petal flap, and we have learned from Giri sir all these techniques. So ligation of blasters of clitoris is important, as I told, already mentioned. So take out the mass with adequate margin and base, that is your motto. So there is a big gap, you see, and primary closure is not possible. So what you do is a technique flap. For that we are backing. We are getting, it is type of a lotus. So this is not a lotus petal flap. So we are cutting this flap here and we just put it there in the large gap, nothing else. No, not a big deal. So we are taking this flap, we are putting a lotus petal flap here, taking care of the vascularity, which is very important, because many times many perforators that come in your way, that should be taken, because vascularity should be maintained. That is most important thing. Yeah, just 1 minute. So we put the flap, you need to know where to close. the two margins, the earlier margins, the forward margin and the lateral margins. So that is the big basic point. If you get 2 points, that your job is 50% over. So
Yes,
this
sir.
is the immediate post-op image of this lotus petal
Yes,
scarf.
Dr. Ashok,
Thank
you
you
have-
so much. Thank you so much.
You have demonstrated very nicely, very nice operation done. Any question? We can allow only one question from the floor, if any. So,
Sir, really wonderful presentation, video presentation. What are the post-operative problems you face in such cases, sir? These are the cases of simple vulvar.
Many a time we encounter with a seroma or a hematoma, but it's unlikely. Hardly we encounter, because what I feel is that you are taking care of surgery properly. You start your surgery properly, plan accordingly, take care of all the vessels of that combined way. You will definitely land. You won't land in any complications. That's my message to the
I
juniors
invite
also.
all the speakers for a quick photograph. Dr. Deepa, Dr. Rashmi Das.
I request all the speakers of the session, Dr. Deepa Ganesh Madam, Dr. Rashmi Das, Dr. Vineet Mishra Sir, to come on the stage. I request our chairpersons, Dr. Jayashree Patnaik Madam, Dr. Nirmala Pipara Madam, and Dr. Shushma Verma Madam to felicitate our speakers for this session. Dr. Rashmi Das Sir. Dr. Vineet Mishra Sir. Now I request Professor Dr. Sujata Mishra Madam and Professor Dr. Kirti Rekha Mahapatra Madam to felicitate our chairpersons for this session. For Vineet, on behalf of Vineet Mishra, sir. On behalf of Dr. Vineet Mishra, sir. Yeah, medal. Now the next session will be on different aspects of malignancy. For this session, I would like to invite upon stage our chairpersons, Dr. Chandrika Prasad Das, Professor Dr. Tushar Kara sir, Dr. Arnab Basak, and Dr. Sasmita Das madam. Welcome on the stage, chairpersons. Dr. Chandrika Prasad Das, Dr. Tushar Kara sir, Dr. Arnab Basak sir, Dr. Sasmita Das madam. It is over to our chairperson to introduce our speaker for this session.
Because of paucity of time, we will straight away go to the sessions. The first speaker is Professor S.K. Giri. Who doesn't know Professor S.K. Giri, Pan India? You know, he's a figure in the domain of gynec oncology. He has pioneered many gynec oncology surgery, and he's a par surgeon excellence, oncosurgeon. So wherever, whenever in Odisha, anywhere outside you need at the dead of the night also, he is there to help you. So he will be dealing with a very important topic. You see, benign gynecology also deal that. We are also dealing day in and out. That is endometrial cancer. What are the recent advances? So we have seen many presentation of endometrial cancer, but you see, many times he says, you see, one of the thing I remember, and this is that you accidentally, you are doing a hysterectomy without doing a biopsy. So it comes to be endometrial cancer. So he has got a beautiful collection of cases like that. After that, what to do? So perhaps the suitable subject which are needed for the clinicians he has got, and now the podium is yours, sir. Professor S.K. Giri, he was the professor and HOD Gynec Oncology of Acharya Harihar Cancer Institute. Also, he was the director of HRCC Cuttack. So podium is yours, sir.
Thank you, sir. Thank you all the chairpersons. And good afternoon, everybody. We are 1 hour late. Mic already 1 hour late. We do not want to make any more late. So I was given a topic on endometrial cancer and recent advances. It is an easy topic, but very difficult to speak. Very difficult to convince people, because there is a new guideline has come, new staging has come, and it is difficult to make people understand what is the new guideline and how we can go for it. So, but I'm trying to do as far as possible, and this is the typical features of persons. Nowadays you see in the airport all these things. The obese young girls are taking the pizza, all these things, coffee, all these things in the hand, and they are the cause of obesity, and obesity is the cause of, obesity is the factor in malignancy, and mostly endometrial carcinoma. And you know, these are the patients, the very typical features of patients of endometrial carcinoma. So we know the endometrial carcinoma, it is a disease of 6th and 7th decades. Now it is coming down, and now we have seen patients of 23, 24 years old girls having endometrial carcinoma. And obesity, hypertension is there. And 80 to 90% cases are found in more than 50 years of age, and median is 63 years of age, and less than 5% are less than 40 years of age. More aggressive in advancing ages. The more the patient, the woman advances in age, they becomes more aggressive in nature. And typical clinical history of PMB. Usually it comes with PMB. We are taking about PMB, and you see the probability of endometrial carcinoma with PMB. If it is 9%, if the woman is less than 50 years of age, and if it is 16% for those of 60 years of age, and 28% woman is 70 years of age. If a 70 years old lady comes with PMB, around 28% of them will have endometrial carcinoma. And the age more advances, around the 80 years old lady, it is around 60% cases they develop, they are found to have endometrial carcinoma. So the first classification was in Buckman's in 1983, type 1, type 2. And this type 1 is good, type 2 is a bad. But I don't want to go in detail of this, because type 1 is a estrogen dependent and type 2 is estrogen independent. But question comes nowadays, with these things are not coming into our practice, because that is substantial heterogeneity in type 1 and type 2. And clinical utility is now not at all defined, and only this provides a conceptual framework for understanding endometrial cancer pathogenesis. This is a concept, we are getting a concept. It is a estrogen dependent, it is estrogen independent. But now it is staged and treated as per the surgical and histopathological criteria. This is all endometrial carcinoma are staged surgically and histopathology examined, and it is treated after that. But question comes, there is a limitations of the classification of Buckman's classifications. So it is subjective classifications, because 1/3 of the high grade endometrial carcinoma had high, because I say it is high grade or grade 1, grade 2, or grade 3. The other one pathology will say, no, it is not grade 1 or grade 2 or grade 3, it is something different. So like that, there is a disagreement of grade assessment between pathologists, one pathologist to other pathologist, there is change, and there is a pre-op or post-op change in grade. One pre-op, once you have done case of grade 3 endometrial carcinoma, after surgery it may be grade 2. So grade 3 endometrial carcinoma, the treatment is different than grade 2. So there is a lot of problems, lot of interval probability is there, and difficult to identify the high risk factors. In a grade 2, there may be some high risk factors are there, which will be very difficult in these classifications. So, and there is chance of over and under treatment. So looking at this, so this is the case. This is a 54 years PMB, diagnosed as endometrial carcinoma grade 1, and surgical staging done, and primary tumor diameter was less than 2 centimeter. This is and on hysterectomy, it was grade 1. On hysterectomy after surgery, it came out to grade 2. Now it is not that much bad because it is now low grade. And my inversion less than 50%, no cervical extensions, and no LVSI, no low risk, and no adjuvant treatment, vault growth. But she presented with vault growth after 9 months. Because there was no factors for adjuvant therapy, so no treatment was given. So vault growth after 9 months, and it came out to be, the vault growth biopsy came out to be grade 2 endometrial adenocarcinoma. Now question of what to do. There is a lot of dilemma on this particular issue. And but we did ISC, that is a molecular markers, that is came out to P53 abnormalities. So once P53 abnormalities, then we have given this adjuvant therapy, all these things are there. But had we done earlier, during treatment, perhaps we could have avoided these recurrences, we could have given the adjuvant therapy prior to that, or we have done more aggressive surgery. So hence the question of this is systematic classification by endometrial, this is improved classification, that is a by molecular classifications. This is to identify, to classify tumor as per biotypes, to enable precise risk stratifications, to modify management decisions, and these are the risk stratifications so that if you find a P53 in a grade 1, grade 2 disease, now it becomes a high risk. If you find a pole mutations in grade 3 disease, it becomes a low risk. This is how we are thinking in that line. So this is WHO has also classified in 2020. The molecular classification is now endorsed by WHO. And these are all the different how we can do all the classifications, all these things. We should go for pole mutations, which is very expensive and a lot time taking. So usually we do not do so frequently. But if it is that we can do, if pole mutation is not mutant, pole is not mutant, one can think of MMR. If again, this is a little bit of complicated things, so which will be more understood by the persons who are dealing with endometrial carcinoma, not to everybody. It is for the postgraduates, one can learn it and we can take this. So PIGO has got done now 2023 a very complicated classifications of endometrial carcinoma, and it is this needs repeated reading to remember. For postgraduate, it becomes a really difficult task to remember the PIGO classifications. And so it is very little changes in PIGO classification. What are the changes they did? They're very interesting changes, which is, so in stage 1, A1 cancer confined to the endometrium. Stage 1, A2 cancer is less than 50% Maya invasions. Stage 1, A1B is more than equal to 50% Maya invasion is there. And stage 1, A3, because one ovary was involved, they're thought to be very high grade, high risk disease, but it's not nowadays. The figure is done in a very precisely that it is not, it may be low risk because it is a low grade tumor. Like that, stage 1C is a aggressive. They have made it, this is endometrial carcinoma divided into aggressive and non-aggressive. Non-aggressives are stage 1, A1, A2, A3, 1B, 2A. Okay, but aggressive tumors are stage 1C, stage 2C, and others. So accordingly, we plan out that, and all LVSA patients are grouped under stage 2B. Now there are many other subclassifications there, and management depends upon. So we do the surgery first, then it should be pathological stage, and then we should go for a molecular classifications. And the surgery is best by minimal invasive surgery. And molecular classifications, lymphadenectomy should be done depending upon situations, but one can do for a sentinel lymph node biopsy. And depending on that, there is a lot of criteria how to do, what to do, when to do, when not to do, all these things are there. But once sentinel node biopsy, you can prevent a lot of complications of lymphadenectomy. So one can do ovarian preservation, can be done in C endometrium. They are telling, so C endometrium, if it is low grade tumor, stage 1, A1, A2, low grade tumor, less than 50%, 55, salpingectomy should be done when the ovarian preservations. And fertility preservation can be done. What is when there is atypical hyperplasia, EIN, or stage 1 A1 disease with no Maya invasions. A1 means there is no Maya invasions. And non-aggressive means stage 1A, stage 1 A1, A2, 1B. Okay, so one should do hysteroscopy biopsy and to bring, and there should be, it should bring from it should be removed from the base. If there is polyp, it should be removed from the base. And there should be expert gynae pathologist. And before doing fertility surgery, we should go for expert ultrasound and MRI to be done. There is no my invasions. And one should do pole mutant if possible, and P53 mutant, it should not be mutant, it should be wild type. It means this P53 normal. So should be aborted in MMR. When the MMR deficiency is there, fertility also should be avoided. So this is case 2. This is a case, interesting case, came to me, sent by Purna, when we were investing into infertility investigations. She was 30 years old, BMI more than 40, infertility for 4 years with one spontaneous abortion at 2 months with normal male factors for cavity evaluations. On diagnosis to be done, there's endometrial polyp arising from the posterior wall on 10th January 2023. And grass biopsy was done. It came out to be grade 1 endometrial adenocarcinoma. But she was bent upon going for continuous to have pregnancy. And so I did my MRI, it was no my invasions. I did out of all, it is little bit of pole is expensive, MMR is expensive. I did only P53, it came out to be P53 mutant. So P53 mutants should not be allowed to go for a fertility preservations. So now, but patient was bent upon going for, I want pregnancy to continue. So I had to go for the conservative management with progesterone, LNG, IUD, and after 1 year, after repeated biopsy, history biopsy, it was negative. There is no that malignancy. So I asked for, that is IVF. On first cycle of IVF, she conceived, and she conceived. You can see ultrasound finding of our pregnancy, and then she delivered on 30th April 2024, and you see the child. So yes, there is no dictum that don't do that. Depending on patient's wish and desire, one should go for it. So it can be after surgery, 2 minutes more. So after surgery, it can be divided into low risk, intermediate risk, high intermediate risk, and high risk. And one should know histophysiological versus molecular risk stratification depending on visibility and availability. You should have availability of the resources with you. But now it is not that expensive, so that we can prevent a lot of these. This is recent classification as guidance has come 2025 last June or July 2025. And so this is one example of what to do. There is if a person has come with stage 1 B disease. B disease means more than 50% my invasion. Okay, so if you do not do molecular stratification classification, it becomes intermediate risk. So treatment choice is vaginal brachytherapy versus no adjuvant treatment. But if you have got molecular classification with my hand, so if a pole mutant, it becomes low risk, and we do not have to go for no adjuvant treatment. If it is a NSMP ER positive, NSMP no specific molecular profile. So NSMP ER positive or MMRD, it falls into intermediate risk, and we can give vaginal brachytherapy or no adjuvant treatment. Now, if it is a NSMP ER negative means high risk. Any NSMP with a non-specific molecular marker profile with ER negative and estrogen receptor negative, it falls under high risk, and we have to go for concurrent chemoradiations plus minus brachytherapy or else chemotherapy. So now you see, from vaginal brachytherapy, we are going for concurrent chemoradiations. Now, if it is pole mutant, again it becomes high risk. Again, the same thing as ER negative, NSMP ER negative. This one more example is stage 2 C disease. Stage 2 C disease is a aggressive variety of malignancy, early malignancy. So if it falls under high risk variety, so if you do not have any molecular marker with us, so it will go for concurrent chemoradiations plus minus brachytherapy plus minus or chemotherapy. But if you have got pole mutant, it becomes low risk. It became MMRD plus myoimmunogens plus no cervical extensions or no LBSI, it becomes intermediate risk. If MMRD plus any MI plus cervical inversions plus minus LBSI or only LBSI, so it becomes a high intermediate risk where EBRT plus minus brachytherapy has to be given. So when it is pole mutant or ER negative NSMP, it falls under high risk variety. So like that, many things are there. So there are many things which we can done it. Yes, over. Now it's over. So now this is I have already told how to deal with different risk category. So we have learned. So what we have learned so far is a molecular classification is the commonly encouraged in high-grade histology recommended in all endometrioid adenocarcinoma. Pole mutation analysis not always available, may be omitted in low risk and intermediate risk endometrial carcinoma with low-grade histology. Pole mutant in high grade is a low risk. Pole mutant in stage 1, stage 2 is always a low risk. So stage 1, stage 2 is pole mutant is always a low risk. Multiple classifier now, there are many things. They have classification with P53 plus MMRD, P53 plus pole mutant. So they need to be dealt separately. So P53 requires chemotherapy or concurrent chemotherapy plus chemotherapy. MMRD only RT better than CCRT. If patient is coming MMRT, so you can give either radiotherapy or you can think of immunotherapy is now the treatment can be given here. And pole mutant, no therapy or excellent result with concurrent chemotherapy. But in pole mutant, if it is high advanced stages, stage 3, stage 4 diseases, one can deaccelerate disease. We may give less dose of radiotherapy. We may not add chemotherapy. So NSMP to be treated as histopathological criteria, but ER negative should be 13 to carry. It is a high risk variety. Thank you very much for patient listening. Thank you.
Sir, you have beautifully told about the recent advances in the endometrial cancer. Yes, we understand that. Today there is a understanding or changing, updating of the classification of the endometrial cancer in 2023. Though complicated, but yet it has simplified. The second point is that molecular classification, that is very important. Earlier we are not using any this molecular classification or other study like gene study, but today we have to do that. But one thing, sir, that how to recommend today regarding diagnostic hysteroscopic biopsy in case of endometrial cancer? Do you recommend or not?
Hysterostomy biopsy is the gold standard. In any case of coming with PMB, one can do people biopsy. But if you ask me, hysterostomy biopsy is the gold standard because you can locate the lesions, you can locate the small lesions elsewhere, you can know the cervical endocervical lesions can be also excluded. So it is a gold standard. But there is a controversy that if you do hysteroscopy, there is spillage. There is spillage, but spillage does not matter. If you do DNC, there will be spillage. So it does not matter at all. And nowadays, with fluid positivity of SIT fluid or fluid is not regarded at all. So one can do hysteroscopy better.
So actually the controversy was that there is, as you are telling rightly, that there is chance of spillage of the endometrial cell, the cancer cells through the endosalpinx, and which may lie in the ovary or some other structure. But as all of us know that the route of spread, mode of spread in endometrial cancer is direct spread, not hematogenous. It is the direct spread. So therefore, there was a doubt or there was a fear that yes, endometrial cancer cells can go through the endosalpinx, may lie on the other structure in the pelvis and the abdomen. So therefore, we are not doing. But today, sir has cleared that yes, we can do that, but with what understanding?
Now, the route of spread is not always direct. It is lymphatic mostly. So we are very skeptical of lymph node metastasis also. But yes, there may be direct spread. But again, there may be spillage. But spillage is not taken into consideration in staging purposes. There is no time. You can talk to me privately. I'll be happy to answer you privately.
After a very exhaustive talk by Professor Giri, I'm going to invite Professor C. Ambuja ma'am. She is from Telangana. I know her when I was working in Karimnagar, and she is going to talk on breast cancer and hormone therapy. We all know it is not restricted to the elderly. Even if we find in the young population breast cancer, because of new hormone studies and adjuvant and immunotherapy, the things are changing. And Madam is going to highlight on the topic. Over to you, Madam Ambuja, Madam.
Thank you, Madam, for your introduction. Am I able to, are you able to hear me?
Yes.
Yeah. And thanks for the organizers for giving me the chance. Next. Yeah. And this is such an important topic because, yeah, usually in every house we have breast cancer patients. I think so. How many of you are having the patients, or either your mother, sister, male breast cancer, somebody? Nobody? Nobody is there? All of you are very, I really wonder nobody is lifting the hand. Because this problem came when my sister had breast cancer at the age of 45. I was thinking that breast cancer will not affect my family because there is no family history. But suddenly when my sister rang up that I'm able to feel some lump, so I ran to her and got the biopsy done, and it turned out to be malignancy. So that then got interest. What Bapre, what am I to do for this? How to take care of this person? So every woman goes into the menopause, but 1 in 8 definitely they are hit by the cancer breast in the world. Many survivors face severe menopausal symptoms, yet for cancer breast, hormone therapy is a red flag. We think 10 times before prescribing the hormone therapy. Can we ever safely balance relief and risk? How to change for the next? Yeah.
I'll do it, no problem.
Next. No, don't do it. Ask that. Sir, please, IT person, can you come here?
I'm there, I've done it. But good.
Yeah.
Good. Go for it.
This year, that's why there is a lot of importance for the breast cancer. Every year, awareness programs are going on. Every story is unique. Every journey matters. Yes, and that's the importance of doing the individualization for any breast cancer patient, how the things has changed. So, today I am going to discuss what is the incidence of breast cancer in general. Yes, madam?
I'm doing it.
Yeah, it is there. Thank you. And when you are using MHT, what is the incidence of breast cancer? How much incidence it is more? Whether we can use MHT for the patient or not? And if it is a low risk, how much increase will be present? If it is a high risk patient, what is the incidence of breast cancer? Whether we can use MHT or not? And what about using the MHT in the cancer survivors? These 4 things I am going to discuss now. So in general, you know, this is the first cancer, either you take worldwide or in India. About 2 decades back, cervical cancer was the first in India, but now it has taken, the breast cancer has taken. Cervical cancer is at the same level, it has not increased, and even ovary it has not increased, but cancer breast has increased. 2 things should have happened. One, the longevity of the women has increased, and as the age increases, breast cancer risk also increases. And second, without anything also it can be there, because urbanization is the one where the breast cancer is increasing. Many people are moving from the rural areas to the urban, and alcohol, smoking, whatnot, and then eating the junk food, all these things, environmental factors are causing the DNA damage, and antioxidants are taking place, and reactive oxygen species are responsible for that. And whenever the DNA is damaged, the cell senescence takes place, which we don't know how it is going to react, this cell senescence, whether it will end up in the cancer or the cells will die. These 2 things can happen. And as the age advances, that's one of the problems that will happen. And especially in India, breast cancer occurs 1 decade earlier. By age-wise, if you take, previously it was not there, now the incidence of breast cancer in the younger people has increased. Means below 50 years, 50% of the people are having, and after 50 years, the incidence of breast cancer is 50%. Means younger age, we never thought it will be how, but it is the thing. And between 50 to 70 years, it is next. 46% are prone to have it. As I told you, urban areas, it is more than the rural. And breast cancer without using MHT, that is there below 50 years, baseline risk is 8, and lifetime risk is 2%. And 61 to 70 years, as the age increases, the incidence of breast cancer also increases. Next. Just I will explain this. A 48-year CEO, severe vasomotor symptoms and GSM, no comorbidities, ready to take hormones, but she is scared of cancer breast. How are we going to counsel her? So the thing is, what are the things which we are using for any hormone therapy? Either it is estrogen plus progesterones. We are not directly going for the other Tibolon or anything like that, or SSRI, SNRI. These are all the secondary things. The basic first is the estrogens and progesterones. Estrogen stimulates the breast cells and it induces the stimulation to the progesterone. So progesterone-induced stimulation will be present. That is why both estrogens and progesterones stimulate the breast cells in the beginning. Olden days, that's a different thing when synthetic progesterones we used, but even if you use natural progesterones, we are going to induce that one. Advances in 21st century, all of us know that it is the natural microprogesterones, estradiol, which we are using. And non-oral routes, that's very important, which has come more. And risk stratification before starting the MHT is the one which we have to do to reduce the breast cancer incidence. Next. This risk depends upon the type of estrogen, dose of estrogen, and number of years what we are using. If it is less than 5 years use, the incidence increase from the normal is only 1 per 50. This is the statistics what is done. Suppose with MHT, without MHT it was 3 for 50. With MHT it is a marginal increase is present. But 10 years use, substantial increase is present. So when only estrogen is used, the lower risk of breast cancer compared to estrogen and progesterone. Less than 5 years, no significant rise, but more than 10 years, there is moderate rise. According to WHO study, where they used the synthetic progesterones, there is 24% higher risk is present. Risk will continue for several years after stopping. That we should understand. Don't think that we stopped estrogen and progesterone, it's not going to induce. No, it is going to increase. So we have to do the surveillance for that with the mammography. Originally it was there, but WHO study, which again continued, even though the study has stopped, people continue to analyze the things, what is happening. This is the one which is followed in 2010, Journal of Clinical Endocrinology. It showed, you can all see, the breast cancer incidence actually, with the estrogens it is less. With the progesterones, it is more. Next. But because of the use of the natural progesterones, what is the effect of it? Dihydrogesterone, all of you see, a marginal increase is there. It is just like the same like the basal breast cancer. Means originally the breast cancer incidence is there, a little rise of the dihydrogesterone is there compared to other synthetic progesterones. If you analyze estrogen and breast cancer, without a progesterone, estrogen alone appears to have a little or no impact, but estrogen may increase breast cancer risk by inducing the progesterone receptor. This is what I was telling. So you should be very, very careful. This has come out very recently in postmenopausal women using HRT. Progestins are likely the primary hormonal agent that elevates the breast cancer risk, but still estrogens also can cause. So as far as we are concerned, it is contraindicated. Next. Yeah, so this is the risk stratification we have to do. When these things are present, it is called the intermediate risk. That is, lifetime risk is 12.5 to 20%. High risk factors, more than 65 years family history is present. That is, more than 20% risk factor will be present. Estimates a women's risk. By doing this, we can find out 90 years, up to 90 years, what is the risk for that patient of the breast cancer. Next. So with this you see, obesity is the one which has got extra risk factors. But recent study in 2025 has proved that obesity has got no relation for the extra risk compared to either drinking or for the smoking. Actually, exercise reduces this. What did we understand by this? If there are no risk factors, if the patient is normal, we can give the MHT for the patient. What about, she's a 49 years perimenopause, irregular scanty periods. Her maternal aunt has got ovarian cancer at the age of 60 years. Second degree relative had cancer breast at 60 years. What is the role of genetic testing? MHT, yes or no? Is there any alternatives? For any patient, what we do in the beginning, risk stratification is the first because patient is not suffering. Next. So assess the risk first. In this patient, presence of both breast and ovarian cancers in the maternal side, and we have to do the BRCA mutations for this patient. Next. When do you do the genetic counseling? There is more than one relative with the breast or breast and ovarian cancer, even if the second degree relatives, cancers occurring at the younger age, cancers are of the same side of the family or male patient. You have to do the genetic testing. Next. Yeah, go back. Go back. No, next. Yeah. This patient, 49 years, perimenopausal. No, next, please. Yeah, next. You look this. Next. So, what is the recommended approach? First, detailed history taking is important. Offer genetic counsel before testing. If indicated, test for BRCA1 and BRCA2. What is this BRCA1 and BRCA2? These are the proteins that are liberated from the breast cells which give protection for the cancer cells not to develop in a normal person. Mutation of these cells in the next generation, it will be transmitted from the mother to the offsprings. There they will develop the cancer. So that is what is the BRCA1 and BRCA mutations. By doing the genetic test, we will know. Next.
Madam, we are running behind the schedule. Kindly
give me 2 more minutes, I'll finish.
Sure.
So if BRCA1 and 2 are positive, there is chance of developing breast cancer 65 to 80% of the cases. Next. So step 4, if it turns out to be positive, what are we going to do? Counsel regarding this one, and risk reducing options, we should tell them about the prophylactic surgery and chemo prevention. Next. For this patient, we advised her to go for the risk-reducing surgery. She refused. But what are we going to do with this patient? Are we going to give the hormones or not? Patient herself is not suffering, but she has got the family history and BRCA positive for that patient. So if she is suffering a lot, we can go for the short-term MHT. Don't prolong it, but following the patient is very important. Wherever it is possible, go for the non-hormonal options for this patient. Next. Next. What we know, non-hormonal things we were discussing all the time about SSRI, SNRI, and the latest one is the neurokinin 3 receptor antagonist, that is fezolinetant, which is a non-hormonal and very effective. Complications are less. That's what is very important. Local estrogens, can we have it or not? This patient, she has got dyspareunia. Do we use local estrogens or not? Yes, we can use local estrogens, but only thing is with caution. Otherwise, a normal person, we don't do so much of surveillance. For the patient who is at risk, definitely we have to do the risk stratification and then follow-up of the patient. And if test is negative, what are we going to do? Routine population screening for breast cancer and ovarian cancer as per guidelines, and treatment also as per guidelines. When do we do immunohistochemistry? Now, two things are there. BRCA1, BRCA2, when are we going to do? And immunochemistry, when we are going to do? BRCA1, BRCA2, if the family history is present in the relatives, close relatives, then we will do to find out what is her chance. But immunohistochemistry we will do. If the patient herself is suffering, with the breast biopsy, we will do the immunohistochemistry to find out whether this is, is it going to react to the drugs what we are going to give or not. That's the one. What are the things we will do next? She is 55 years. She herself is suffering with the cancer. So next. Immunohistochemistry we will do. That is the ER1 and 2 and progesterone receptors and HER2 and Ki62. These three things will tell whether they are positive, means will they respond to the tamoxifen or aromatase inhibitors, and Ki67 will tell cell proliferation whether it is present or not. Next. Next you go. Yeah. Estrogen progestin regimes were associated with excess breast cancer risk, and excess risk was also seen with estrogen only regime. There was no excess risk with vaginal estrogens. I think I made it clear. Yes. Any patient who is suffering with the cancer cervix, whatever stage it is, as it is on today, MHT is not indicated, but vaginal estrogens can be given with a better surveillance, and we have to go for the non-hormonal methods. Obesity was not associated with excess risk. Instead, it attenuated the risk. This is the latest thing, that is the Lancet, it has come out. And go back. The breast cancer risk remained elevated 5 to 10 years after cessation of MHT with most of the regimes. Next. Next. Yeah. Next, you go for the next. Yeah. Practical pearls, what we can say with this is, prefer non-hormonal therapy first, avoid systemic MHT. For this case, where she has herself suffered, local estrogens for GSM if quality of life is poor, transdermal plus normal natural estrogens is gentler if systemic therapy absolutely needed. Regular breast screening is mandatory. Document informed consent and oncologist concurrence. Next. Yeah. Where are we standing in giving the MHT to breast cancer? You see this conclusion, this has come recently. Despite possible changes towards safer MHT prescribing, our data collected largely in early millennium, means this is 21st century, show that at least as large breast cancer risk elevations in MHT users as seen in older studies. We have not come one step ahead also. So, as on today, for all breast cancers, either the history, strong family history is present, with the risk stratification, if we come to know intermediate and high risk, or the patient suffering, no MHT. I think I made it clear. Thanks for the patient listening.
Thank you,
Thank you
Professor
very much.
Ambuja, for
Thanks
dealing the
for giving
subject
me
so
one extra
extensively.
time. Thank you very
ma'am.
much.
Thank you, and giving and highlighting the role of medical hormonal therapy very judiciously. You have to prescribe, looking into the epigenetic and genetic genesis of the malignancy, and to focus on the phytoestrogens and local application of the estrogen depending upon the patient. Very judiciously, you have to go for hormonal therapy. Thank you. We move on to the third speaker. Dr. Chandrika is going to introduce the third speaker.
I invite Dr. Anu Patni, who is the professor of Mahatma Gandhi Hospital, Jaipur. She will be speaking on ovarian tumors in elderly and update. So it's over to Dr. Patni.
Can we clarify, time is 10 minutes or 15 minutes?
I think it's 12 plus 3.
12 plus 3.
Good evening, everyone. First of all, I would like to thank Dr. Hara, Dr. Bhagya, Dr. Giri and their team for inviting me for this very prestigious and well-organized conference. I will try to be very crisp and fast because we are already delayed. So today we are going to talk about ovarian tumors in elderly. And happy to be on IMS stage after quite some time, but IMS is very close to my heart. So we all know the disease burden of ovarian cancer. Epithelial tumors are the commonest with a lifetime risk in 1 in 70. There are 4 major types, serous being the commonest. Among serous also, high grade and low grade are different because their molecular pathways, their outcomes, response to treatment, and diagnostic criteria are different. So in elderly, we mostly come across high grade serous ovarian cancers. And unfortunately, as for cervical and breast cancer, currently there are no screening guidelines for ovarian cancer in place. According to NCCN and SGO, for women with hereditary risk, you can do TVS and CA125 every 6 months, beginning between 30 and 35 years or 5 to 10 years earlier than the age of first diagnosed ovarian cancer in the family. But we still come across most ovarian malignancies in advanced stage. So elderly women usually, when they present to us, an ultrasound, a good ultrasound is sufficient to diagnose ovarian malignancy in this age, and it has to be ruled out in elderly. When a woman with younger age presents, we have to have a plethora of differential diagnosis and label the mass as either suspicious or non-suspicious, but we suspect every ovarian mass in elderly female, that is 60, 65 and above, as cancerous unless proved otherwise. So MRI enables a specific diagnosis, and it should be used for characterization when ultrasound results are indeterminate or equivocal, especially in younger patients. These are a few MRI pictures. I have to just fly through. But in elderly patients, CT, in my personal experience, CT is the preferred technique because we have to be very sure of the operability status of the patient. So CT is the preferred technique in pre-treatment evaluation for nodal and metastatic spread. And PET-CT can be used for lesion detection and treatment follow-up in suspected recurrence, but also de novo, because we have to be very sure whether it is operable or not. We all know the use of CA125, 19.9, CEA, etc. These markers are used for screening, diagnosis, prognosis, response to therapy, and for monitoring recurrence. CA125 is a little hyped, but it can be positive in various other non-cancerous conditions and other malignancies as well, but it has a higher sensitivity in elderly and postmenopausal women as compared to younger women. So elevated CA125 in a postmenopausal woman with a sonographically confirmed ovarian tumor has a positive predictive value of about 80%. There are a lot of other markers, multiple marker tests as well, which are not FDA approved. But the definitive diagnosis can be confirmed only pathologically by removal of the ovaries or in advanced cases sampling of tissue or ascitic fluid. Immunohistochemistry comes to our aid when we are in doubt whether it is a primary or a secondary ovarian mass or the type. Then molecular diagnostics and miRNAs are things of the future. So now coming to the actual topic, what are the challenges that we face with ovarian cancer in the elderly? The initial approach is the same that I talked about till now, but with increasing age, there is an increased prevalence of comorbid conditions, polypharmacy, functional dependence, cognitive impairment, depression, frailty, poor nutrition, and limited social support. So it is not surprising that many older adult patients who present with advanced ovarian cancer receive less aggressive therapies than their younger counterparts and have poorer disease-specific outcomes because we have to limit the treatment. And it is not true only with only advanced. Sometimes for staging also, she is not fit for surgery. So in early cases also, this is a challenge. So for older patients, they should undergo a geriatric assessment at their initial presentation to determine whether or not they are appropriate candidates for cytoreductive surgery or even staging surgery. So according to that, we determine the treatment strategy, dividing the patients into patients who are candidates for surgery. They should proceed with primary surgical therapy. Who are not candidates for surgery should be offered chemotherapy, provided they are also candidates for medical treatment. There are different assessments for that also. And who are candidates for neither have to go for palliative or hospice care. So staging, there can be two types of surgery. One can be a staging laparotomy or staging surgery for ovarian cancer, or it can be a cytoreductive surgery. Staging is also very important for early cases because the outcome is based on staging, and it has to be done meticulously for best outcomes. So you do all these procedures, peritoneal cytology, multiple biopsies, omentectomy, pelvic and para-aortic lymphadenectomy, all these, because with increasing stage, the outcome, 5-year survival goes on reducing. And most of the patients, as you can see here, they present in stage 3. Almost 55% of them present in stage 3. So we have to be very careful that we give them full surgical benefit. So to assess for operability, geriatric assessment is done, which provides clinicians with a formal way to evaluate a patient's functional status, comorbid conditions, cognition, and other factors. Unfortunately, a validated instrument for assessment for the older patient for ovarian cancer is not yet available. However, there are a few tools which I will just like to mention. you can go either with the PACE tool, the pre-operative assessment of cancer in the elderly, the frailty tool, the comprehensive geriatric assessments, modified comprehensive geriatric assessments, and geriatric vulnerability score for the pre-chemotherapy assessment. The PACE tool involves all these factors: activities of daily living, instrumental activities of daily living, depression scale, mini mental state inventory, fatigue inventory, performance status, and physical status classification by American Society of Anesthesiologists. This is just example of tool for independence in activities of daily living, which can be bathing, dressing, toileting, transferring, etc. This is a tool for instrumental activities of daily living, which can be ability to use telephone, shopping, food preparation, housekeeping, laundry, finance, etc. This is a fatigue inventory. This is the Karnofsky performance status scale, which most of the time as oncologists we use in our clinical practice. And this is from 0 to 100. If the patient is able to carry on normal activity and to work, no special care is needed. She is placed in the 80 to 100 category, is considered as having good performance status, and we can safely keep her for management by surgery. Then if she is from 50 to 70, she is unable to work but able to live at home and care for most personal needs. And below that is the lower category, that is poor performance status. This is the physical status classification, which is used by anesthetists. We assess with Karnofsky score or performance status, and then we send for pre-anesthetic checkup, and the anesthetist places in category 1, 2, 3, or 5 based on 1 being normally healthy patient, 2 with mild systemic disease, and worsening so on with 3, 4, 5. So patients with 1 and 2 can be safely taken up for surgery according to anesthesia risk. These are modified scores which comprehensively place all the categories of daily living, instrumental living, toxicity, comorbid conditions, etc. But not validated, but based on the score you have to assess. So it is not only staging, as I said, you have to assess for operability also. This can be based on CT scan, which predicts, if you can see these, this is a slide that I took from a recent presentation. If you can find, CT scan sometimes picks up these small predictors of suboptimal cytoreduction, like diffuse small bowel mesenteric infiltration, porta hepatis or celiac axis disease, extensive diaphragmatic disease, matted bowel loops and mesenteric retraction, etc. These will indicate poor operability. We have to basically attain complete cytoreduction or CC0 if you are planning surgery. So as far as possible, it is best to assess preoperatively, especially in the elderly, whether we will be able to achieve CC0 or not. So based on these criteria, we calculate a peritoneal carcinomatosis index, either based on imaging or a Fagotti score based on laparoscopy. With these scores, we calculate the possibility of CC0, and CC0 is the goal and the good prognostic factor for newly diagnosed either early or advanced ovarian cancer. But even if an elderly patient is fit for surgery and we take her up for surgery, we have to keep certain things in mind that can happen. One is the hazards of hospitalization. We all know nosocomial infections and prolonged hospitalization can have an impact not only in the elderly, in the young also, but more so in the elderly. Then there is increased 0 to 13% of post-operative mortality in elderly as per SEER Medicare database, and they found that with increasing age, this post-operative mortality possibility or percentage goes on increasing, especially more so with emergency surgery. If you have to, suppose she comes with subacute bowel obstruction or something, then the incidence of post-operative mortality is more. Then These are certain comorbidity indices which can also be taken into consideration when we calculate post-operative possibility of post-operative mortality. So these are certain studies that have been done for outcomes of older females with newly diagnosed ovarian cancer. They're very small, but each one of them have shown a poor overall survival with increasing age. I cannot go into detail of every. This is another large survey which indicates that morbidity also goes on increasing with increasing age. Then there is non-traditional discharge. Many of the almost 14 to 33% of these patients are not discharged to home, but to another super specialty or hospice facility or some non-traditional location. So that means some complications have developed and outcome will be compromised. Many a times we have to omit chemotherapy altogether, or there is a substantial delay in initiation of chemotherapy or modification in planned chemotherapy even when it is indicated. Then if she is not fit for surgery, there are multiple randomized trials which have shown that survival outcomes appear to be similar among patients who undergo a primary versus interval cytoreductive surgery, and perioperative complications are lower in patients receiving NSCT. But we have to assess whether these patients are fit for chemotherapy. So patients with newly diagnosed advanced epithelial ovarian cancer and a high perioperative risk profile should receive NSCT. These are the latest ASCO guidelines uptake. And these are the vulnerability scores which assess the feasibility of chemotherapy in that particular patient. And 5 prognostic factors of poor survival have been identified: low serum albumin level, low ADL score, that is activities of daily living, low instrumental activities of daily living, lymphopenia, and high score on hospitalized anxiety and depression scale. So these are the various cutoffs, and according to that, survival is compromised. So basically, chemotherapy also has to be planned very carefully. Then there is maintenance therapy with polyadipyribose polymerase inhibitors, which are given in BRCA1, 2 or homologous repair deficiency patients. Advanced age has not been shown to be, olaparib is the drug that is being mostly used, and it has shown excellent response in non-compromised patients. And advanced age has not been shown to be an independent predictor to toxicity to these, but one should closely monitor for hematologic and renal toxicity and use appropriate dosing according to renal function. Not many studies have been done prospectively. In recurrent disease, slightly oncologists deviate from the traditional chemotherapy and use pegylated liposomal doxorubicin or weekly topotecan for older patients with recurrent disease. I'm finishing last. Especially with platinum resistance, given their better toxicity profile, and there are other drugs that need to be studied. So ACOG guidelines for referral to gynae-oncologists say that postmenopausal women with elevated CA125, ascites, nodular or fixed pelvic mass, evidence of abdominal or distant metastasis should definitely be referred to an oncology facility, because one size doesn't fit all, and we have to manage these patients, these challenging situations very, very carefully. Thank you so much for your patience here.
Thank you, ma'am. You covered a vast topic, and you have started from staging the carcinomas, then taking us through the preoperative scoring. That was wonderful, very comprehensive, and also you have discussed about the post-op and neoadjuvant chemotherapy. I think it was wonderful listening to you. Thank you so much.
Thank you, ma'am, for the valuable insights. Now I request our experts for this session to felicitate our speakers. I request Tushar sir, Arnav sir, and Sasmita madam, Chandrika madam to felicitate our speakers. I request Dr. Anita Shah ma'am and Dr. Dilip Sarangi sir to felicitate our chairpersons. The next session will be on tits and bits. For this session, I request our chairpersons, Dr. Jamuna Devi ma'am, Dr. Ajashwini Patel madam, Dr. Vedai Thakur madam, and Dr. Sanjay Swain sir to chair the session. Now it's over to our chairperson to introduce our session and our speaker for this session. Madam ko laptop connect ho. Madam ko laptop connect ho. So that I can change the slides. Actually, they only know. Eta ଆପଣ କତନ ଏଟାର ପ୍ରେଜେଣ୍ଟ କରି ଦେବେ ଏଟା ମୋ ଲ୍ୟାପଟପ୍ ହଁ you want to present in your laptop
Hello. So this good evening to all. This session is on several topics. And the first topic is by Dr. Krishna Kaveri Patnaik. She is a consultant in our district headquarters hospital, Cuttack, and a very senior most consultant of ophthalmology there. She will take on the subject eye care in menopause. Please, your stage, please.
Good evening. Excuse me. Good evening, esteemed panelists and delegates. Today my remit is eye care in menopause and how hormonal changes, that is decline in estrogen and androgen, impact vision and what you can do about it. The average age of menopause is 47.5 years in Indian women, and by 2026 we estimate 103 million women to suffer from it. The hormonal collection which impacts eyes are that during perimenopause and menopause, the levels of estrogen, progesterone and androgen fluctuate and decline, resulting in changes to the eye's delicate tissues and tear production, leading to various issues. The eye structures which are impacted the most are cornea, where the cornea becomes less stiff and more elastic, affecting the way light travels into the eye and leading to frequent occurrence of dryness. So much so that it has been found that 47% of women in the postmenopausal phase suffer from dry eye compared to only 4% of women in the premenopause age. This can impair vision and cause eye discomfort, especially in women who use contact lenses. Estrogen decline also has a effect on the cloudiness of the lens, increasing the susceptibility of the lens to age-related changes in cataract formation. There is reduced blood flow to the retina, which has consequences for the retina's health, and this reduced circulation leads to many eye problems, including macular degeneration, ARMD, and others. So what are some of the eye conditions which we commonly see during menopause? By far, the most common is dry eye, followed by age-related vision problems, cataract formation, glaucoma, which again here, this is very important for these menopausal women, as 58% of women over the age of 40 in comparison to men are more likely to have glaucoma in the glaucoma population. Diabetic retinopathy, ARMD, hormone-related therapy, eye problems, and contact lens intolerance. Dry eye as a menopausal problem is due to tear film instability and increased osmolality of the tear film and inflammation of the ocular surface. This is one of the most compelling features of dry eye disease, and it occurs more frequently in women than men. In fact, the female sex has a significant risk factor, with women above 50 years having nearly double the risk than in men at 7%. The tear film basics are it is composed of three major components: the lipid layer secreted by the meibomian glands, the aqueous layer secreted by the lacrimal gland, and mucin layer secreted by the conjunctival goblet cells. All of this are necessary to be in the proper homeostasis to maintain ocular surface homeostasis. By influencing the above mentioned mechanisms, sex hormones play a role in pathogenesis of dry eye disease. Both androgens and estrogen have known effects on the synthesis of components of the tear film. Androgen binding results in secretion of lipids from meibomian glands. Lower levels of androgen and estrogen leads to decreased oil production and evaporation of tears. So what are the general symptoms of dry eye? Scratchy, gritty or sandy sensation, blurred or changed vision, burning or stinging, light sensitivity, stringy discharge of the mucus, watery eyes with excess tears. The first line treatment here for all of you gynecologists are lubricating eye drops. You can give it in your clinics. If ineffective, the second line treatment includes anti-inflammatory medications such as steroids and immunomodulatory eye drops such as cyclosporin, which has to be referred to an ophthalmologist. In severe cases, depending on underlying cause, punctal occlusion, eyelid corrective surgery, scleral contact lens and autologous serum tears may be indicated. The role of hormonal therapy in menopause related dry eye has been investigated and plays a potential role in treatment. As regards hormonal replacement therapy, which is given to postmenopausal women, there is an increased risk of dry eye in women taking estrogen and estrogen plus progesterone HRT. Given the high prevalence of DED, it is important for gynecologists and for primary care physicians to understand DED, to recognize its symptoms, and to start initial lubricating therapy, and to identify patients for ophthalmology referral. The age-related problems are presbyopia, as in all, and this condition worsens on the onset of menopause. Estrogen decline contributes to lens clouding and quicker cataracts. Glaucoma, which is the leading cause of irreversible blindness and known as the silent killer of the eye, is often found in women who represent 59% of the glaucomatous population. So we can't really discount this figure. It is likely that menopause affects the biomechanical properties of ocular tissues, resulting in the increased in percentage of glaucoma seen. The estrogen deficiencies play a role in developing glaucoma in both genders. However, women have an unique risk factor for developing glaucoma involving the estrogen pathway. The mutations in the estrogen receptor beta associated with ocular hypertension and early menopause, that is less than 45 years of age, is associated with 2.5-fold increased risk of developing open-angle glaucoma. The estrogen therapy in postmenopausal women causes 0.5 to 3 millimeter mercury decrease in IOP, and estrogen treatment has been shown to increase the outflow facility in female patients. Thyroid issues frequently crop up during menopause, and they also are significant where ophthalmology is concerned. Due to the loss of estrogen's protective effect, estrogen generally has the anti-inflammatory and antioxidant properties are reduced. It means less protection for ocular tissues against oxidative stress and inflammation. So thyroid eye disease symptoms we should all be aware of. They are red, scratchy, dry or irritated eyes, bags under the eyes, swollen puffy eyelids, gritty feeling in the eyes, bulging of one or both eyes, that's proptosis, and increased light sensitivity. And in very severe cases, Graves' eye disease. Diabetes is also associated with menopause, but so far we have not been able to find a correlation between menopause and diabetes, although diabetes is mostly seen in menopausal women with the complications like diabetic retinopathy, which is one of the most common microvascular complication, and the leading cause of visual impairment worldwide. The drop in estrogen levels in menopause is associated with hypertension. This can damage the blood vessels in the retina, causing a condition known as hypertensive retinopathy. Macular degeneration is due to the decline of retina, because this estrogen has a protective effect on the retina. The hormonal loss weakens retinal cells, making them more vulnerable to damage and degeneration. So how do we prevent ARMD? This by combining lifestyle choices and regular eye care, like quitting smoking, eating a nutrient-rich diet, especially leafy greens and fish, rich in omega-3 fatty acids, engaging in regular physical activity, protecting eyes from ultraviolet radiation. This is the hormonal medication, the HRT therapy as a replacement during menopause to alleviate symptoms are what is used by you gynecologists. One should keep in mind that these medications increase the risk of blood clots in retinal blood vessels. So regular ophthalmologic checkup are necessary to help monitor and manage any ocular complications related to hormonal treatments. Another important lately eye problem in menopause is the use of bisphosphonates, which are commonly prescribed for postmenopausal women to prevent bone resorption. These drugs have been associated with inflammatory eye diseases, the most important one being scleritis, which is vision threatening. Lifestyle factors that can worsen vision changes: stress, increased stress raises cortisol levels, reduced hydration, lack of adequate nutrition in the diet, prolonged screen time. So when do we need to seek medical attention? If you have a sudden loss of vision, pain in eyes, or if number of floaters increases suddenly, you should consult your doctor, who may refer
2
you to
minutes
the
more to
ophthalmologist.
wind up.
It is recommended to visit the ophthalmologist from time to time to make sure that the changes that occur during menopause are not hiding something worse. So what can you do to maintain your eye health during menopause? Use artificial tears, practice good eyelid hygiene by warm compresses to help open oil glands, stay hydrated. Manage screen time by following 20-20-20 rule, that is every 20 minutes look at something 20 feet away and blink for 20 times. And reduce screen brightness to minimize eye strain. Increase omega-3 intake in food. Adjust your environment by using a humidifier in dry climates. Reduce irritants. So what is the take-home message? The key message for eye care during menopause is that hormonal changes can significantly impact eye health, primarily causing or worsening dry eye and potentially increasing the risk of conditions like glaucoma and cataract. So, as a request to all gynecologists here, I would advise you to advise your patients to have comprehensive eye exams annually or every 6 months if they have risk factors like diabetes, hypertension, and thyroid disease. They should seek professional advice if they experience persistent symptoms like severe dryness, pain, sudden increase in floaters or flashes of light, or significant changes in vision. Thank you all for a very patient hearing and for giving me the opportunity to speak here.
Thank you for finishing in time. And the most beautiful organs of the human being is the eyes. And mostly this is exclusively for women. This is very, very true. So you have explained everything from the perspective of menopause, all the hormonal changes and how to take care of. Thank you very much.
Thank
you. If one or two questions, maybe no questions. Okay. So next speaker, please.
Thank you so much.
Now may I invite Dr. Ashok Kumar Behra. The most important one is metabolic syndrome in menopause. It is a silent storm. I think we are going to listen to him how to face this storm. Over to you, sir.
Respected chairpersons, honorable delegates, ladies and gentlemen. So my topic today is metabolic syndrome in menopause. Is it extension of PCOS? Now the menopausal years, at present, a woman spends about 3 decades of her life, or little more than that, in menopause. And on the way, in this way, she faces a lot of challenges, health challenges, social challenges, psychological challenges. I'm not going to talk about social challenges and psychological challenges, but I'll talk about health challenges. And most important of the health challenges is metabolic syndrome, because it itself gives rise to or leads to many other health challenges or health problems. What is metabolic syndrome? It is itself not a disease, but a cluster of high-risk factors. Those increase the risk of cardiovascular disease, and it comprises mainly abdominal obesity, which otherwise looks very innocent, signs of prosperity, and dyslipidemia, insulin resistance, hyperglycemia, and hypertension. The prevalence generally, it is higher in men when compared with premenopausal women. But this gets reversed as menopause approaches. But this reversal or higher incidence of metabolic syndrome is not abrupt. It happens gradually. The incidence of metabolic syndrome increases gradually between 6 years before the final menstrual period and 6 years after the final menstrual period. Approximately 13.7% new cases were seen at the time of final menstrual period by the SWAN study. 13.7% of metabolic syndrome is already there at the time of onset of menopause. Overall incidence of menopause is about 32 to 58%. It varies from country to country and between race to race. What are the health risks associated with metabolic syndrome? It leads to type 2 diabetes, cardiovascular disease, cerebrovascular disease, fatty liver disease, non-alcoholic, which has got a new name now, metabolic dysfunction associated fatty liver disease, cancers. More common amongst them is breast, colon, and endometrial cancer, sarcopenia, loss of muscle mass. Now, what are the diagnostic criteria of metabolic syndrome? Metabolic syndrome has got these diagnostic criteria. These are standardized diagnostic criteria. Abnormal glucose in the form of either impaired glucose test or impaired fasting glucose, insulin resistance, or type 2 diabetes mellitus already there, or it is diagnosed at the time of first screening. HDL cholesterol, which is low, or the triglycerides, obesity, central obesity, waist circumference, waist hip ratio, BMI, hypertension, others like microalbuminuria, which is only WHO criteria. So these are the clinical and lab criteria based on which diagnosis is done, and this criteria has been recommended by all these organizations, of which WHO in 1998, National Cholesterol Education Program Adult Treatment Panel 3, 2001, American Association of Cases for Endocrine Diseases, Center for Endocrine Diseases 2003, American Heart Association, National Heart, Lungs and Blood Institute 2003 and 2004, International Diabetic Federation 2005, but the consensus definition which is now used is consensus between International Diabetic Federation and AHA, NHLBI, that is in 2009, the criteria is this, which is fasting glucose should be more than 100 milligram per DL, or drug treatment for elevated glucose, that means diabetes mellitus type 2. Hypertension more than 130/85 or already on medication for hypertension. Triglyceride more than 150 or already under treatment, specific treatment. SDLC less than 50 or already under treatment. Central obesity, microalbuminuria is not required in this recommendation. 3 should be there out of all these criteria to tell that it is metabolic syndrome. Now coming to the risk factors and pathophysiology, I have to tell that the risk factors and pathophysiology of metabolic syndrome are not very clear. It is very complex, very complicated and not very clear. These are aging, lifestyle factors, hormonal shift, that means declining estrogen with advancing age towards menopause, central obesity, insulin resistance, and other hormones like role of glucocorticoids. Now first aging. Aging as such causes obesity in men, women both. After the 3rd decade of life, it is told that, or it is there that, for basal metabolic rate reduces, that means consumption of energy reduces. So we need less 50 kilocalories per day after the age of 30. In every decade, this increases by another 50. So if we continue to take the same amount of food and our physical activity remains the same, so we develop fat, we deposit fat. That is how the aging causes deposition of fat. Where? Then I will come to it later on. Where this fat is deposited. Lifestyle factors like sedentary lives, lack of exercise, all these things, no proper diet, junk food, street food, all these things also lead to this metabolic syndrome. Now, most important is hormonal shift. This hormonal shift starts with the menopausal transition. Gradually, the estrogen declines, so the endocrine environment becomes less and less estrogenic with advancing age towards menopause. As you know, estrogen is everything for women. It is not only required for reproduction, for everything, starting from the skin of the woman to everything, estrogen is required. So when this is declining, then there is abnormal deposition of fat also. That gives rise to central obesity. Why central obesity? Because there are two types of, we should not look at the fat or the adipose tissue simply as a tissue which stores energy and releases it on demand. So it is not that. It is itself endocrine, adipose tissue and adipocytes are endocrine organs. They also secrete many substances which have endocrine and paracrine activities. So, these fat cells are different. In women, usually before menopausal years, before transition, the fat cells which are more active are confined to the gluteal region and the thighs. So, they deposit more fat in these areas. The typical women looks that shape of the fat deposition which is called is pear-shaped. Whereas males always develop or deposit fat in their abdomen because the pre-adipocytes in the abdomen.
Sorry, sir, you have 2 more minutes.
Okay, thank you, madam. So, it is more because the receptors are more in androgen receptors are more in the visceral fat, so they deposit more fat in the central obesity. The visceral fat is not stable, it is labile. There is more of lipolysis, so that releases free fatty acids. Free fatty acids gives rise to insulin resistance. That is how there will be metabolic syndrome. So this is what all the adipocytes secrete. I'm not going into the details of it. This leptin, adiponectin and resistin, that give rise to deposition of fat. This is how insulin resistance, free fatty acids changes the tyrosine phosphorylation to serine phosphorylation. The left side is the normal pathway of glucose utilization and uptake. The second one is the insulin resistance pathway. So where glucose properly not uptaken or it is not utilized. Next is hyperactive hypothalamo-pituitary adrenal axis. So more of cortisol is also seen in this and it is directly related to insulin resistance. Is metabolic syndrome in menopause extension of PCOS? Now metabolic syndrome and PCOS they are overlapping features, but they are not directly extension of one another. Declining estrogen can exacerbate insulin resistance and weight gain, which may amplify metabolic syndrome risk. Women with PCOS may experience a worsening of metabolic features in menopause due to this hormonal shift, but menopause itself doesn't extend PCOS. PCOS symptoms like hyperandrogenism and irregular periods often diminish post-menopause as ovarian function declines, but the metabolic issues can persist or worsen, resembling or contributing to metabolic syndrome. The key difference is PCOS is a reproductive and a metabolic disorder, with specific diagnostic criteria, often starting in adolescence. Metabolic syndrome is a broader cluster of cardiovascular risk factors not tied to ovarian function. So there are many evidences to this. So ultimate my answer is that PCOS, metabolic syndrome is not an extension of PCOS. Now diagnosis of metabolic, like any other condition, it depends on history taking and all these tests so that we can fit into the diagnostic criteria depending on the lab values. Now the management is very simple. I'm not going to more of the management because already many things like hormone therapy has been discussed, prevention, everybody knows, healthy diet, regular physical activity, weight management, quit smoking, try to cope with stress, medication, if already all high blood pressure, hypertension, hyperlipidemia, all these things to be done, and HRT. Most important therapy is HRT. Now, but in the backdrop of WHI recommendations, we are many times scared to prescribe HRT. But good thing is that recently on 10th of November 2025, US Department of Health and Human Services has announced removal of the broad black box warning from all HRT products. So now we can freely use it. Okay, so this is all about metabolic syndrome I had to say. It is preventable, but prevention should start at the time of transition, not after it has happened. Then most important is, most of us know, is exercise, diet, all these things, followed by the pharmacological diet. Thank you.
Thank you so much, sir. I think it was a wonderful talk. And as you said, I think we can reverse this if it is identified early and specific treatment is taken and action is taken. Thank you so much, sir.
Next speaker is Professor Bharati Mishra. Her topic is mental wellness in menopause. She is a well-known professor in Odisha, and now stage is her. Madam, please.
Okay. Slide do. Where is mine? Give it. So, good evening, everybody. Respected chairpersons and respected President IMS and other delegates. So, I will start. So, before I start, I am profusely thanking Harapatnaik, Abhaya and Bhagya for allowing me to prepone my talk today, although the audience is very scanty, but I'll do my duty. Thank you very much, sir, for allowing me. And as if seeing their vigority and how active they are, andropause has not stopped both of them. So we talk a lot about menopause, but male also do suffer, but it is their self-esteem and enthusiasm and work which keep them mentally active to do all sorts of work apart from their professional life and family life. So hats up to them. So now I will be talking about menopause. Occurs between the age of 45 to 52 years. In India and women it is very common, 46 years they are telling. By 2026, 103 million of women will be menopausal in India. So relation between menopause and mental well-being, while physical symptoms of menopause are well recognized, its psychological aspects remain unexplored. An association between menopause and mental well-being is widely reported. Do you know schizophrenia is two types? One is bipolar disorder, one is unipolar. Bipolar is depression and other things occur, suicidal tendency once. Another is excited, euphoric, dancing, other things occurs. So this disorder increases in menopause in some women. Unipolar also is affected. So you have to take history, whether there was a history of these things in the beforehand of the patient who has appeared for the menopause now. Perimenopause increases the risk of new onset mood changes, even women, emptiness syndrome to suicidal tendency, all of you know, without prior psychiatric disorder. So two types of disorder, one was there exaggerated due to menopause, one has not there appeared first time in the life. So depression affects over 40% of Indian women during the post-menopause because of different factors. And you know, anxiety disorder, nearly 1 in 2 women experience anxiety during menopausal transition. That is there. The prevalence of anxiety among postmenopausal women ranging from 35 to 80%, 72% women suffering from mental exhaustion. They are exhausted. Previously, they will be taking mental strain so much during work. Now, little strain, family strain, other strain, work strain, they cannot take because there is the exhaustion of the brain because of the lack of estrogen and the hormones. There may be menopausal transition may have higher suicidal risk vulnerable to women. The prevalence of suicidal ideation in women of age more than 50 years is 8%, 41 to 45 years 13%, less than 40, 30% of course. So more than 50 years of women also have 8% suicidal tendency. Bipolar disorder menopause prevalence, new onset bipolar disorder can occur in 70% of the women. 68% women with existing bipolar disorder experience at least one depressive episode of menopausal transition. Sleep disturbances, we have discussed a lot very nicely from madam about how sleep is affected. 50% of the women experience poor sleep quality after menopause with prevalence of rising that one. And in night you will not get sleep, it's a personal experience. In daytime you will feel like dozing, as discussing with Ashok sir also that. So that happens maybe because of menopause. So I thought I may be menopausal because I am having all these things. So frequent awakening and insomnia are often linked to vasomotor symptom and hormonal changes. There is a confusion between the vasomotor symptom, hot flushes or flushes, and mental confusion and palpitation and other things, whether you are having psychiatric wellness syndrome is affected or it is due to the menopausal hot flushes and that thing. So there is a confusion and overlapping. Brain fog mark the memory lapses. Poor concentration is coming due to perimenopausal age. Early menopause and estrogen decline increases the cognitive impairment and dementia. So estrogen and menopause is not affecting only eye, what she have told, and metabolic syndrome. So many things, vigor, figure, whiteness, fairness, everything disappear. But we have to work on that in menopausal society, how to make them fit. So these are the hormone changes can occur. So these are very good slides. Pathophysiology of mental disturbances in menopause. Hormonal transition, neuroendocrine dysregulation via HPV axis, estrogen is less, progesterone less, FSH little less, then it will be high, LH is high. So hormonal instability. Neuroendocrine effect of fluctuating estrogen, dopamine, serotonin, GABA, NE, vasomotor disturbance and sleep disturbances. Role of KNDI neurons. KNDI means kisspeptin, neuronin and dynorphin hormone. Kisspeptin, you know everything. So estrogen level less, KNDI hypertrophied, increase NK3 level and vasomotor symptom, hot flushes as everything is more common. CNS estrogen receptor pathway, estradiol level less, loss neuropathic support, cognitive decline, anxiety, depression, confusion, exhaustion, other things occur in mental wellness. So risk factor for mental illness during menopause, previous episode of depression, comorbid anxiety disorder, distressing and adverse life events, family life, lack of quality sleep, high BMI, smoking, hormonal variation. So what is the manage? So lifestyle modification is the most important thing. Always it is there going, every age it is going. First is exercise. Get up in the morning. I look to two madams. One is Sindhu madam, one is Sama madam. Look to them. Can you not see their mental wellness? Have you ever seen them unhappy? Have you ever seen them not doing their work? How Sindhu madam came in the morning in the fasting and do. So follow them, what they are following. First is get up in the right time after a good sleep. Do meditation and exercise and yoga and everything. Diet should be nutrition, what you have discussed today, and it should come more protein. In a menopause, protein amount should be more apart from the green leafy vegetables, walnut, etc., etc. regular exercise. I do regular exercise. First I was going morning walk and everything. Now I have shifted to my treadmill and other things I am doing. I am doing that. Without that, you will not get sleep, concentration, everything will be less. If you do more exercise, your antioxidant is there. So they will take care of your body. So do. Refraining from alcohol, spicy food, sleep hygiene, very good. Somebody told 7 hours sleep. And afternoon nap, power nap you have to take certainly. If you are not taking together, 6 to 7 hours sleep is good. It causes healing and from the body, and it can also reduce the weight. Stress management could be body weight reduction, our triggers, cognitive behavioral therapy. If you are very much unrest, mentally not feeling well, feeling low and depressed, go to a psychiatrist or send the patient to a psychiatrist. So pharmacotherapy, menopausal hormone therapy, okay. Earlier known as hormone replacement therapy, MST now, HRT now MST. Some guidelines do not recommend MST for the first line therapy. Doctors have seen a positive effect on mood with MST. An individualized approach should be treatment for individual patients. There is an evidence that estrogen has antidepressant effect, particularly perimenopause. Estrogen is not recommended for history of breast cancer. One line about Alzheimer's. Alzheimer's, they told that in menopausal more common, but somewhere I read that more estrogen can cause harm to Alzheimer's patient. Type of MNC, you know what are the vasomotor symptom and symptomic estrogen, topical estrogen, everything. I give topical estrogen for those who are having urinary symptom, dyspareunia and dry vagina, etc. You give local. And those who can afford, you can give tibolone, you can give transdermal. And tibolone is best way, the hormone therapy, because it also gives little androgen, progesterone, androgen and estrogen. Androgen was there in ovary, which is not lacking. It is for lack of libido and that one. Sexual life also we have to talk, because there is so many things about sexual life benefit even after menopause. Menopause is 50. They can go up to 60, 70 like that. But what is the effect? They can feel so many things, age-related problems, and minimum cardiovascular disease minimum like that. We feel shy to talk about that with the patient, but talk it freely and help them. So tibolone is the answer for an intact uterus. Reduce mood swing and reduction of depression, anxiety, improve sleep, sense of well-being by help of MHT. So then consider right regimen, small doses, whatever anybody has told, least amount doses for a least time. Side effects you have to consider. See the contraindication what is there in MST before giving that. Palpate the breast yourself and do a PB, do a perspeculum examination, do a pap smear, then BP examination.
2 minutes more.
Then you have to, okay. Then route of administration, type of hormone you have to decide. North American Menopausal Society, MST remains the first line in healthy women. Non-hormonal option like SSRI, SNRI, gabapentin, NK-arginine are viable to MST with a contraindication where it is there for mental wellness. The National Institute of Healthcare, NICE guideline, HRT, BMS, but not routinely recommended. And these are the things which you are giving. I also refer my patient to psychiatrist or medicine fellow to give all these drugs. I give only HRT and calcium and other things. American College of Obstetrics and Gynecology, SCOG guideline, lowest effective dose for shortest duration, tailored to each woman risk benefit profile, because MHT is having so many things. Pharmacotherapy, all these things, gabapentin, neurokind and SSRI, SNRI, all can be given also to clonidine also is a indication for mental wellness. Approach-based cause, sleep apnea, continuous positive behavioral pressure, restless leg syndrome, dopamine agonist, primary insomnia, give melatonin and other product, depression-related sleep issue, give antidepressant, may improve sleep quality, chronic persistent sleep problem, refer to sleep specialist. Recently, I had been to Hyderabad. I have seen a very big hospital, only sleep therapy. So management of depression, already I have told you. Cognitive defect, estrogen plays a role in cognitive therapy, neuroprotective effect of HRT been told. So then by another important thing is that dysbiosis vaginal dysbiosis. Nowadays, previously it was vitamin D, now it is the vaginal microflora. Also it is related in menopause. Also you can give, I am started giving my pregnant patient infertility, other thing, vaginal preparation available. Now also you can start with vaginal and for dysbiosis, microflora, ecoflora, other things, products are available for that also decreases mental, it is related, so one new point. Then urogenital infection, strong association between infection that causes depression. Recurrent UTI I have not seen in menopause, and the other things I give a long total carnibiotic and microbiome, and also this one that can also reduce the anxiety indirectly. And then urogenital health has to be maintained, sexual activity has to be maintained, cosmetic surgery has to be done, treating vaginal infections can be done. So to summarize, menopause is significantly mental health impact, hormonal shift of serotonin, dopamine, acetylcholine, and depression, anxiety, insomnia, cognitive decline, and sexual dysfunction. Holistic care, balanced diet, regular exercise, adequate sleep, social engagement, lot of social work, charity, health education, awareness program has to be done by menopause, if it's there, by doctors, by all menopausal gynecologists. And therapeutic approach, hormonal early MHT, barometer symptom cognitive. Non-hormonal, all things I have told, that is to be dealt with by for a mood elevation and tranquilization. Treating infection all by restoring clindamycin, metronidazole topical, hormonal balance, dydrogesterone, vaginal estradiol can significantly improve mental well-being also by treating them. So one line before that, before going to that, always go for yoga, meditation, regular work, regular habit, and whatever you have not done during your working time, menopause is a transition, you are released from menstrual problem and other things, you do that one. Singing, dancing, swimming, all things you have not started, start your things. My friends have started writing, and I was a dance, they'll know that whenever there's a music, I can stop myself. Dancing is the one form of best exercise because it's not give pleasure to you, it gives pleasure to others, and also it's a form of exercise. Whatever extra diet you have taken, lunch and dinner, it will be digested and it will be. So I pray God to keep all the menopausal lady mental well-being okay and active till the last. Till the last you have to be active 80, madam has told 80, beyond that also only. And I am happy to declare that we are going to do the 100th birthday celebration of my madam Professor K. Bai on 5th of December. She is mentally active, though physically little youth. So she is very spiritual and very, very regular in her habits. Thank you all for allowing me.
Thank you, madam. As usual, the eloquency lured the whole audience, but everything you have told about the illness of the mental health and their complications, along with that, that should be some wellness for this mental health. Thank you very much.
Thank you. I think without much ado, may I invite Dr. Arnab Basak. He's going to talk about vaginal dysbiosis in menopause, which is an important topic, and we all need to learn from that. Thank you. Over to you, Dr. Basak.
Okay. Thank you, chairpersons. First of all, very good evening to all the seniors, colleagues, and friends. And thank you, Haro sir, for calling me. Last year when he came to Kolkata, he said, you have to come. So I'm here, sir. And thanks to the organizing team and the scientific committee for giving me this talk. Vaginal dysbiosis in menopause. The terminology may be new, but the concept is not too old. Before we understand what this dysbiosis is, I have to talk a little bit about the vaginal microbiome. Vagina has got a very complex ecosystem, which consists of different microbials. Predominance of lactobacillus is what we see. It also contains small numbers of parasites and funguses, and the microbiome is in a very dynamic state. That means it keeps moving from one state to another. Now, the reason for that is it is a composed of diverse bacterial community, predominantly lactobacillus, that's what I said. Now, estrogen dominance, it promotes proliferation of these vaginal epithelial cells which accumulate glycogen. Progesterone predominance, on the other hand, induces epithelial cellular lysis, so glycogen is released, and this glycogen is acted on by the lactobacillus, which we all know, and lactic acid, which lowers the vaginal pH. Now, till this, we are we know all this. But then, what is this changing vaginal microbiome? The dynamic state of alteration of this microbiome depends on several intrinsic and extrinsic factors. The intrinsic factors are the hormonal fluctuations that we see during the menstrual cycle, during pregnancy, and especially in the menopause. It is also age-related because as we become more and more old, there are certain cellular changes that takes place. The cellular metabolism also alters, and also ethnicity, because Southeast Asian women, they are less prone to dysbiosis than the other group. Extrinsic factors consist of diet, so unhealthy diet leads to dysbiosis. Smoking, definitely yes. Antibiotic treatment, we know that it kills all the good bacteria. Stress, nowadays it's like this new panacea, or it is something like the vitamin D3. Anything you blame on stress and vitamin D3. So stress definitely contributes to dysbiosis of different nature, which I'll come to later on. Maintaining hygienic practices. Now, some women do douching and all those things, which should not be practiced, and also sexual habits. Now, when we talk about the composition of this vaginal microbe, we have to think of the 5 states. And what are these? The community state types, or CST as it is known as, in asymptomatic women consist of 1, 2, 3, and 5. Now, these states, if you see 1, 2, 3, and 5, they are predominantly lactobacillus, predominantly. The group 4 is polymicrobial. That means it has not only got lactobacillus, but it has got other aerobic and anaerobic bacterial, which includes the Gardnerella, Atopobium, Mobilincus, Provetella, Streptococcus, and Mycoplasma. So this group 4 is the diverse forms of microbiome is what causes the problem. Now, as we said that because of the preponderance of the estrogen, there will be a gradual shift from childhood till the menopause. So as you can see in the childhood, there will be more of this anaerobic bacteria. And so as the estrogen starts coming in, there will be low preponderance of the lactobacillus, there will be Gardnerella. And then in the reproductive age group, they will have only lactobacillus, which again converts into less of lactobacillus and more of the anaerobes. So this is the gradual transformation, the dynamic changes that takes place. So also if you look at the changes during the reproductive years, in the prepubescent woman, there is less estrogen, so polymicrobial flora. When there is more estrogen, there will be preponderance of lactobacillus, and then again, they go back to the more diverse things. Now they say word speaks 1,000, picture tells us 1,000 words. If you look at this particular picture on the left side, in the pre-puberty, you have thin vaginal epithelium, thin layers of mucus, low estrogen, low glycogen, so we have low lactobacillus and higher concentration of the other microbials. In the premenopausal, or when we say the stage 1, 2, 3, and 5, you have thick epithelium, thicker layer of mucus, higher estrogen, high glycogen, high lactobacillus, and low polymicrobial diversity. So these are this is the time when they are less prone to have dysbiosis and infection. Now, if you look at the postmenopausal, in the symptomatic group, they have thinner disrupted vaginal epithelium, thin layers of mucus, low estrogen, low glycogen, so they have low lactobacillus, high diversity of microbials, and high vaginal pH. But when you start giving HRT, the situation changes. So this is what we have learned, that when there is estrogen preponderance, there is less of dysbiosis, less of chance of infection. In the menopause, it just reverses. Now, how this vaginal microbiome maintains reproductive health, that is very interesting. If we look at the defense role, it shields against the microbes That is not very difficult to understand. It produces antimicrobial substances, stimulates the immune system, protects the integrity of the mucosa, favors secretion of mucus, and maintains the protective pH, that is 4.5. So if you look, the acidic environment is unfavorable for growth of the pathogenic organism. Production of antimicrobial compounds such as the bacitracin, biosulfactants, hydrogen peroxide, these are all antimicrobial. So basically, they will decrease the amount of the harmful polymicrobials and also induce an anti-inflammatory and immune response. Cervical mucus contains mucin, that is also protective, it's a barrier function. So also the vaginal secretion, which contains numerous amounts of polypeptides, the different calprotectin, secretory leukocyte proteactors, protease inhibitors, and the likes, and also the immune mediators that are released, the cytokines, the chemokines, and the immunoglobulins. These have all got a huge protective role as far as the vaginal infection is concerned. Now, what causes vaginal dysbiosis? As I told you, intrinsic and extrinsic factors, so it is no big deal. Treatment with antibiotics, they kill the good bacteria. Failure to comply with vaginal hygiene, as I said, using soap, deodorants, douching, overcooling the area. This bacteriosis of the intestine, if somebody is not eating healthy, having frequent, stomach upset, those are the women more prone for dysbiosis. Violation of the hormonal imbalance, I have spoken a lot. Inflammation of the pelvic organs or PID. Stress, as I said, stress, madam was also talking about, stress and vaginal dysbiosis. Change of climatic zone. Now, these are the causes of vaginal dysbiosis. Now, what are the symptoms? The first thing is the patient may not have any symptoms. That is the most important thing. But if they do, then they can complain of itching and burning. Usually that is associated with the infection. Decreased libido because of dyspareunia, pain during intercourse, indigestion disorders which can be associated. It is not a cause. Vaginal discharges which are gray or yellowish, so these are polymicrobial infections they can have. This leads to a weakened state of immunity, further increasing discharge, and then leading to chronic fatigue. So and also I must mention that, as madam said, that it can lead to depressions. So these are some of the symptoms. Now this is a very interesting slide. Just I'll take 1 minute in this. The menopause microbiome. What happens is the microbiome is not only vaginal, it is also in the lower urogenital tract, the urinary tract, and it is also in the whole of the gut. So this polymicrobials that you can see, the blue are the vaginal and the urinary tract, those blues are the lactobacillus. Now the lactobacillus, what it does is it releases the conjugated estradiol into free estradiol and the glucuronides. The free E2 is now converted, that is estrone is converted, estradiol is converted into E1 or the estrone. Likewise, conjugated progesterone is also released, and this causes this release of all these microbiomes acting on the two different hormones leads to a very dynamic stage, not only in the uterus and the vagina, but in the urinary system as well as in the gut. So, in the gut, there is a concept, that is another talk, that's another talk altogether, the estrobolome or estrobolome, what they say. So it's very interesting that estrobolome is basically dysbiosis happening in the gut, which leads to the urogenital problems. So that is, as I said, this is a new concept, little difficult to understand maybe, but it will be clear with another talk on this. So vaginal dysbiosis, health issues. As I told you that it can lead to infections, bacterial vaginosis, trichomonas vaginatis, candidiasis, senile vaginitis, sexually transmitted infection.
You have 2 minutes.
Yes, I'll be done. I have 3 slides. And the non-infection could be cardiovascular health, metabolic, like they are more prone to type 2 diabetes and obesity, bone health, mental health issues, fertility concerns, and gynecological cancers. Cancers mainly cervical cancer and the endometrial cancer. Now, the recent advances, as I told you, is there is a linkage between the microbiomes of the gut, the lower genital tract, and the lower urinary tract, causing dysbiosis, which may be responsible for certain infective, inflammatory, metabolic, and malignancy as well. So there is a huge linkage. The chain of linkage is very, very huge. Managing this condition. Well, quickly, everybody has spoken about lifestyle, increasing your fiber in the diet. Plant-based food is very crucial. Fermented food like yogurt, kefir, and miso is basically the Japanese diet. Processed food should be as little as possible. High sugars, high fat, they are also not good for gut biases. Reduce intake of alcohol and caffeine, and regular exercises. Exercises also causes increase in the gut health. Probiotics and prebiotics. Probiotics we all know, lactobacillus and everything. What is prebiotic? Prebiotic is basically a plant-based food which is for the beneficial effect of this beneficial bacteria. So the probiotics feeds on prebiotics. So this is the simplest way of talking about it. It could be oral, it could be tropically delivered, and you have to maintain appropriate perineal hygiene as well. So only probiotic will not help. Managing dysbiosis with antimicrobials and antifungals if there is an infection, so you give targeted therapy. Syndromic treatment, that's what we give. Stress management is very, very important. Cognitive behavioral therapy is very important because, you know, thoughts leading to feelings, leading to action, these are all part of this dysbiosis game. The gut health especially. Hydration, very important. Drink adequate amount of, and I think this is the second last slide. I'll finish it. Fecal microbial transplantation, or the poo transplantation, what they say. So, you know, they transplant other patients' stool. So with this, I have come to the end of my talk. I think I've done a little bit of justice to this topic. And let me invite you, take this opportunity to invite you for the Endogene 2026 that's being organized at Kolkata. And this is the national conference of the IAGE. It's on 20th to 22nd of March. And I welcome you all. Thank you.
Thank you, Arnab. I think it was a wonderful talk. And gut microbiota is a big topic. So thank you so much.
Thanks.
Yes. Thank you.
Thank you, sir, for the excellent talk. Now it's time for felicitation. So I request our experts to felicitate our speakers for this session. I request Dr. Sanjay Shwahi madam, sir, and Jamuna Devi madam to felicitate our speakers. I request Haraprasad Prasad Patnaik sir and Dr. Bhagyalakshmi Nayak madam to felicitate our experts.
I think it is one of the best session, even though crowd is thin, audience was less, and I really enjoyed this session very much. The speakers were on time, and they spoke very well. And I really want everybody to clap for all the four speakers of this session.
Moving on to the next session, it is a mixed bag session. For this session, I request our chairperson to join on the stage, Dr. Joshnamai Panda madam, Dr. Radhakanta Panigrahi sir, Dr. Leena Baru madam, and Dr. Ranjana Bhandari madam. Please join us on stage.
We are running late, but everybody should understand that if we speak on time like this, everything will be on time only. Thank you very much.
Dr. Ranjana Bhandari madam. Now it's over to chairpersons to introduce our speaker and the next session's topic.
Hello. So good evening, everybody. Now this is the last session, and after this we'll be having cultural program. So first, madam is Dr. Sushma Verma, and she has an expertise in high-risk pregnancy, minimal access surgery, assisted reproductive technology, and menopausal management. Her topic will be contraceptive needs in elderly. Madam, the stage is yours, madam. Thank you.
Thank you, ma'am. Today, topic of my lecture, first of all, I want to thank Hara Patnaik sir and organizing team for giving me this opportunity. Today, topic of my lecture is contraceptive needs at menopause. We all know the famous picture of movie Badhai Ho, which humorously reminded us about the unexpected pregnancies which can happen at late 40s or early 50s. An age when many women assume that they no longer need contraception. And in reality, menopause is a gradual transition. It is not an overnight event. That's why contraception remains is important during the perimenopause, not only for prevention of unplanned pregnancy, but also to relieve from symptoms like heavy menstrual bleeding, irregular cycles, and hormonal fluctuations. We all know that once the elderly woman gets pregnant, there is higher maternal and perinatal mortality, and the annual risk of death associated with using no method of contraception exceeds far than using any method of contraception. So, and the risk of pregnancy without contraception in women between 45 to 49 years of age is 2 to 3%, which reduces to less than 1% by 50 years of age, and it becomes almost nil at 55 years of age. Over 40 years, whenever female becomes pregnant, it will always remain unaccepted, associated with stress, and usually ends up in abortion. And apart from this stress, there is increased risk of congenital and chromosomal abnormalities of the baby. There is increased risk of spontaneous abortion, increased pregnancy complication, increase in the maternal morbidity and mortality. So do we need contraception at perimenopause and menopause? Yes. Woman is advised to continue use contraception until she has no periods for 2 years when she is less than 50 years of age. And she should use contraceptive method for 1 year if her age is more than 50 years of age. And if she is a pill user, already she is a pill user, then she is advised to take contraceptive till 59 years of age, but it should be in the lowest possible dose. So before prescribing any contraceptive, we should know the personal history, family history, sexual history, medical and surgical history. We should assess the cardiovascular risk, cardiovascular disease, and cerebrovascular disease in the patient. We can assess the cancer risk, and accurate measurement of blood pressure is very important. So the contraceptive options which are available are tubal occlusion, vasectomy, barrier contraception, combined hormonal contraceptive pills, progesterone-only pills, and intrauterine devices like IUCD or LNG-IUS. Surgical sterilization is most accepted, and it is highly effective and safe method, and it reduces the risk of PID, ovarian cancer, as well as from the STDs. And vasectomy is more safer and has minimal complications. Barrier method, until unless we use it consistently and through correct use only, we can achieve contraception. And it is highly effective if used properly, and it protects us from the PID as well as from the STDs. Another way of contraception at menopause is combined oral contraceptive pills, which uses estrogen as well as synthetic progesterone. And any low-risk woman who do not smoke and who is not an hypertensive or who is not having any risk factors for cardiovascular disease can use oral contraceptive pills beyond 35 years of age. But we should have a careful personal and family history and accurate measurement of blood pressure it is very important to give prescribe before prescribing any combined oral pills. Contraceptive benefits are there with COCs. Apart from that, we have non-contraceptive benefits also. It reduces the menstrual blood loss, it regularizes cycle, improves dysmenorrhea, acne, hirsutism, improves PMS. It treats perimenopausal symptoms like hot flashes, insomnia. It improves quality of life, sexual life. It suppresses endometriosis and ovarian cyst. And there is increase in the bone mineral density if the patient is using COCs regularly. And in postmenopausal women, COCs has a bone sparing effect also. So we can easily prescribe COCs to menopausal women also. About the cancer risk, there is decreased risk of ovarian cancer, which is most important benefit of COC, and effect continues for at least 20 years after stopping medication. And there is definite reduction in the endometrial cancer also. And this protection also continues for 20 years and more after discontinuation. There is reduced risk of colorectal cancer, and steroid contraception can be easily prescribed to those having a strong family history of colorectal cancers. And it has been proved that there is increased risk of hepatocellular adenoma with OCPs, but there is no associated increase in the liver cancers. So we can prescribe it in cases of liver cancers, but in the minimal dose. Cancer risk, there may be increased chances of cervical cancer, and there is increased risk of dysplasia and CIN of cervix with 1 year of OC use, and there is increased risk of invasive cancers after 5 years of use of OCPs. And regarding the breast cancer, already Dr. Ambuja has said, current user and recent users have slightly increased risk of breast cancers, which may be related to early detection and accelerated growth of the already existing malignancy. But in many studies, it has not been proved that OCP use is associated with carcinoma breast in older users. Regarding the cardiovascular and cerebrovascular risk, low dose of OCPs is not associated with the with myocardial infarction or stroke. But incidence of myocardial infarction and stroke increases once if the pill user is a high dose pill user, and smoking, hypertension, and estrogens are additive to the effect of cerebrovascular and cardiovascular diseases. And there is reduction in the risk once the patient is stopped taking OCPs. And there is increased risk of thromboembolism in COC users. There may be 3 to 6-fold increased risk of venous thromboembolism, and due to this, women who have a higher risk of VT due to obesity, smoking, family history of VT or cardiovascular disease should undergo a personal risk assessment and should be advised to avoid taking OCPs. And one of the side effects is the pill may mask the onset of natural menopause, and it will be difficult to know when to stop using OCP pill because patient is going to have regular periods and we are not able to say when is the actual menopause happened. And what are the contraindications for COC use? It should not be given to any patient having undiagnosed bleeding PV. It should not be given to current smoker, uncontrolled diabetes, hypertension,
Madam,
patient
only 1
having
minute left now.
stroke, migraine. In these patients, progesterone-only pills can be used. LNG IUS and implants are the better options. But the disadvantage with POP is they alter the menstrual bleeding pattern. They causes oligomenorrhea, amenorrhea, and chaotic bleeding. Copper intrauterine devices are ideal for many women and are well accepted, but they may increase the menstrual blood loss and dysmenorrhea. LNG IUS is a better option for these women because it is alternative to hysterectomy and reduces the blood loss and dysmenorrhea. Other hormonal contraceptives include vaginal rings, implants, patches. It can be considered in women who desire to avoid daily intake and who are forgetful. So when to switch to hormone therapy? If the patient is already taking OCPs, we need to take few levels of serum FSH, if it is FSH and LH ratio is more than 1, low estradiol level, that is more than 20 picogram per ml, FSH more than 30 international unit per liter, done twice in 6 weeks apart, can be considered as menopause. Also, it is important to prescribe hormone contraceptives in obese women. Long-acting reversible contraceptive method like IUDs are highly efficacious in these women, and the risk of failure of oral contraceptive or any contraceptive is greatest in patient having BMI more than 35. And hormonal contraception can be a safe choice in obese women in absence of any other high-risk factors. Emergency contraception includes use of OCPs, progesterone-only pill, copper T380, but the safety of emergency contraception in menopausal and perimenopausal women has not been studied very well. So to conclude, contraception and menopause transition is different from that offered at the younger age. The age requirement and BMI and presence of comorbidities and symptoms of menopause need to be taken into consideration for prescribing any contraception. For users of both hormonal and non-hormonal method, the time at which it is safe to continue contraception provides a window of opportunity to discuss the risks and benefits of HRT for the management of menopause. So until unless we could not educate our patients regarding the contraception during perimenopause, this can be seen in our OPD, where 2 old women are pregnant and sitting in the OPD and waiting for their turn and saying that we thought we were done having kids. So thank you for patient hearing. Menopause is marvelous. Do not afraid of it. Thank you. Thank you very much.
Madam. It was very good. And so one has to be very judicial use during the, just after menopause, during the menopausal, perimenopausal age. And after seeing all the histories and all, family history, personal history, past history. Thanks a lot, madam.
Thank you, ma'am. Thank you very much for patient hearing.
Our next speaker is Dr. Indira Palo. And if I'll read her CV, then it will not end. I like to only tell that she is a very good academician. And she has conducted many CME. And she is just an elder sister to me and my core mate. I welcome to the dais to the man. She will going to speak on holistic approach to menopause.
Thank you, Chairperson, respected organizer, and the delegates present till this time. Actually, my topic is holistic approach. From the morning until now, whatever discourses we are listening, the first and last slide of every speaker is the lifestyle modification and holistic management. So what a holistic management of menopause at all? Whenever a patient, as a healthcare person, suppose a patient comes to us, an elderly woman, comes to us with a vaginal itching or something, dryness or infection, as a healthcare person, we should not see only to that problem only. It is an opportunity for her and opportunity for us to see her as a whole. Because you know the elder people in our society are not much care. As patient has been brought by her son or daughter-in-law very reluctantly. And it is our duty to look after them as a whole person, not the problem itself. That is what the holistic management of the menopause. What actually holistic means? It has derived from a Greek word, means holos, means whole. The goal is not only treat the disease, but also to prevent it. Empower the individual to take the active role in their health journey. Holistic means looking at the whole of something rather than just its individual parts. Holistic approach to health considers the entire person, her mind, her body, her spirit, and what is her social life, who else are staying with her, who is there to take care of her, instead of just focusing what the patient is complaining for and for what she has come to her. It is not possible to attain the best possible health if you don't have a proper balance in life about the mind, body and spirit. We, from our undergraduate class, we are reading WHO defines health as a state of complete physical, mental and social well-being, and not merely the absence of disease or infirmity. And this definition itself defines the holistic approach of the healthcare personnel towards the society. Now, the fourth dimension of health has come, and it has been included in the definition, but it has not come to update book. That is the spiritual aspect of the person, and it is meaning a purpose, hope, love, faith, and fear of a person. That also is accountability. When we can say that this woman is well, there are not only her the physical, emotional, social, mental, also she should have a spiritual, recreational. She should have, you give only food and shelter, that is not enough. She should have some recreational activity, and also occupational safety and financial safety is there. There are many studies are there found that holistic therapy is effective in treating a variety of conditions, including menopause. Because you know that menopause is not a disease. Menopause is only physiological transition, and we as a healthcare personnel to provide when there is a problem. We are now facing a great challenge. Most of the women are living in their late 50s, and a lot of people are there who are in need of your help. And holistic therapy is a broad term, and that encompasses a variety of ancient, also modern practices, and it has been shown to be effective in treating a wide range of physical and mental health conditions, including the menopausal health management. So what exactly holistic means? It includes 5 different aspects. What is the mind-body therapy? That is by yoga, meditation, biologically based meditation by vitamin or supplementation or dietary changes, manipulation of body, massage, reflexology, Reiki, like that things, energy healing, Reiki, therapeutic touch, reflexology, and holistic medicine system like Ayurvedic, and also modern practices are there. So these are the basic 5 ingredients of a holistic management. So how to implement a holistic in a menopausal lady? So you have to take care of her physical health by engaging her in regular activity. You should look for her mental health, how should practice gratitude and mindful meditation even a few minutes in a day. You should take care of emotional health. Social health is very important, because who is taking care of a person, whether husband, children who are staying with her or not, whether she is engaging herself in social activity or not, and last but not least, spiritual health. Now, whichever faith you believe, be in there and attend all the prayers and meetings, and that is also very good for health. So the common holistic practices are mind-body therapies, physical and body-based therapy, diet supplement, and spiritual emotion support. What is the basic principle of holistic medicine? It has seen that it is based on belief that unconditional love and support are the most powerful healers. If you can correlate yourself that these things at a person ultimately responsible for their own health and well-being. So other principles are all people have an innate immunity and healing powers, and just you have to discover it and practice it. The person, whenever a patient comes, it should not take as a person, it's not a disease, take or consider as a person. Healing takes a team approach involving the several parts of the holistic department, and treatment involving fixing the cause of the condition, not easing the symptoms. That is the most important. You should not give what is the root cause, you should go there and treat there. The key principle that whole person care, that is the holistic, means it should look beyond what is the complaint for which she has come to you. You should look for the physical, mental, emotional, and social being, and give an opportunity for the patient to have an active participation, and try to focus on the preventive aspect, because prevention is better than the cure. And yes, no, the woman plays a different roles in different phases of life. Is a median phase of personal growth and exploration, the mother phase, queen phase. Now she is in a crone phase of the end of the, and it is a time for reflection of legacy she is acquiring and sharing the accumulated wisdom with the society. Whenever you take these 7 pillars of the wellness of the of menopausal women, you should not exclude the humor and community service. That is the most important thing apart from all these things, whatever discussed. And she should have a sense of humor and a community approach should be there. And most of the thing is the most important is emotional health, and she should realize who she is, self-awareness, self-regulation and management and social awareness should be a part of the emotional component. Now many women are working in a workplace, and workplace emotion and so communication and workplace social community is very important for a proper workplace and personal life balance. And these are the energies she should have in a plenty so that she can correlate all the workplace negative energy properly. Coming to the yoga, breath work is a type of holistic therapy that involves using intentional, mindful breathing exercise. It promotes physical, emotional, and mental healing. Every day, few minutes of this breath work is very important. Next, the aim of meditation is to focus and be present in the present moment and to relax and clear mind, and also help to improve the mobility and reduces the pain. Yoga is another type of holistic therapy that uses physical postures and breathing exercise. Yoga can help to improve flexibility, balance, and strength. Massage is another form of holistic therapy that has been used for centuries to promote relaxation and well-being. Acupuncture also there are so many sessions they are doing, and they use the needles to stimulate the specific points of the body. So all of these holistic therapies can promote physical, mental, and spiritual and social well-being. What we can do? We can have such type of pamphlets, we can explain everybody, can empower our menopausal journey with the holistic lifestyle. Today we have learned from the His Excellency Rajyapal Sir that first part of empowerment is awareness. How can we our women? We can have such type of pamphlets, and you can distribute in our OPDs, and you can integrate with the conventional medicine. Not only holistic medicine, we can integrate with the current medical practice that is called integrative medicine. Some alternative therapies should be given if at all required. And after the holistic therapy, whatever the problem she has, suppose there is any cardiovascular disease problem, she has to be addressed properly. And if there is an eye care problem, she has to be addressed properly. And if there is osteoporosis, involve orthopedic physician and yoga industry. And it is better to give, there is wrinkles, and how to take a cosmetic care, and also how to take,
Another 1 minute.
how to have a makeover. So awareness of breast problem, awareness is the first step on the prevention of empowering the women, awareness regarding the cervical cancer, awareness if there is any psychological or emotional problem, you should address it properly, and you need the family support and meditation required, and also so many problems should be addressed properly. Though Indian women have a positive attitude towards menopause, still that does not alleviate the problems associated, also the long-term implications. So basically prevention is better than cure and should be started in early 30s. Holistic management is a form of healing that considers the whole person, body, mind, spirit, and emotion in the quest for optimal health and wellness of a postmenopausal woman. You can take advantage of the art of living discourses, which have a distressing diet, exercise, walks, color therapy, and aromatherapy also. Thank you all for giving me an opportunity to speak something about the holistic therapy.
First of all, I like to thank you. You have ended it in time. And from the opening batsman, Dr. Professor Gangadhar Sahu sir also addressed this problem, and you are the closing batsman. Thank you so much. Next speaker.
It is my time to introduce Dr. Shakti Kumar Tripathi. He will be speaking a older molecule with a newer approach, that is Placentrex, from womb to wellness, exploring the regenerative power of Placentrex. He is the new sensation in Odisha. Shakti, this is your podium. Please.
Thank you, respected chairpersons and my mentors and teachers. I am blessed to speak few words in from my teachers, and what a great moment for me. To start with this old molecule, I think every doctors, those who are in practicing periphery and also in medical college, they are using this molecule placentex long back. But we'll explore more how this molecule can be used in regenerative medicine practice and what are the regenerative medicine practice that I am doing in my setup that we will explore, because this is a new dimension. We have to explore more, then we'll get the benefit for not only for the menopausal women, so lots of things are there for infertility practice that can be clearly elaborated. So to start with my topic, from womb to wellness, exploring the regenerative power of human placental extract. So I am from the land of Ma Samleshwari, Ma Shyamakali, and everyone present here, I am inviting here to Bargad from 25th of this year only, from December. That is one of the greatest world record on the open air theatre, the largest open air theatre, that is called Dhanu Jatra. They are celebrated for 9 days, and I think everyone for all over Odisha and abroad also they come here for this program. I invite everyone for this event. So thank you, Hara sir, Bhagya madam, for this opportunity and entire team, so that I can speak few words in front of you. What I am today because of my teachers, what I learned from my teachers. I learned spirituality from my teachers. This is the letter I got from Sindhu madam last 5 years before. I learned leadership from my teachers. I learned to be like him, like a teachers who always inspire minds, ignite imagination, and shape our future. Some of the teachers they are not only teachers inside your classroom, they are teachers outside the classroom also. These sir visited my home long back, and I kept this picture as my treasure. Some of the teachers are like our second mothers. They always guide us, always protect us like our mother, and always inspire us to do our best. These are our teachers, and I am proud to be SCBN and from this institute. Some of the teachers, not only direct teachers, they always inspire you to do more in reproductive medicine practice. And there are many teachers, I not call a teacher, they are my elder brothers. They always behind us and always tell, go ahead Shakti, we are behind you. So this is the support I always get from my teachers. And I think my wife, Ipsita, she is a dermatologist. And my daughter, Kavya, is the youngest member of the all association. I think every society event, they both are present, used to come, but this time I am missing them, both of them. So I learn from each and every part of country and abroad. But one thing I learned from my teacher, Professor Dr. Gangadhar Sahu sir, discipline, discipline, and discipline. And that I always follow that. And another thing I learned from Professor P.C. Mahapatra sir, when you are committed, then you have to deliver. That thing I always carry out in my practice, and I think with the blessing of my teachers, I will continue that also. These are some of the ethical points or the pillars in our practice in reproductive medicine practice, also in regenerative medicine that I am going to deliver in next 5 minutes. That is, first, do not harm. What you are doing, that should be ethical. It should be affordable. It should be evidence-based, and experience always matters. Many senior doctors are sitting over here, always experience matters. So what is the purpose of this study or this topic? This is for what is new, what is about regenerative medicine. I think I am blessed to the new regenerative medicine unit that is started in the Bargad, that is by none other than Professor Dr. P.C. Mahapatra sir. And what we are doing in our center, not from human placental extract, what is the other things that in regenerative medicine practice that we will discuss in next 5 minutes. So this is a small picture I will show you. This is a picture taken by Dr. Ipsita, my wife. This is before and after picture. This is a non-healthy topic also that we treated with human placental extract along with other molecules also like PRP. So we always go for a combined therapy approach. So what is human placental extract? I think everyone has lots of experience on these molecules. I am not going to more of the theory part. What we can do in our day-to-day practice, that I will deliver. So this is extract, aqueous extract of the human placenta contains several bioactive therapeutic molecules starting from DNA, peptides, amino acids, growth factors. And that is a clear-cut protocol for the placental extraction that normally done in different laboratory. And followed by what is the indication, how this can be used. It can be used in the tissue repair, anti-inflammatory action, neovascularization, and lots of clinical use in case of recurrent pregnancy loss, in case of a PID, in RIF. There are lots of indications are there. This immunomobility effect is also there that can be used. And this is long back, the article, it was by Dr. B.N. Purandre in 1970. In that era, he established that this molecule can be used for the blocked tube. And from that day, these molecules are using. If you are combining this molecule along with the other antibiotic like azithromycin or doxycycline, definitely you get a better result. And you can avoid some of the surgery that is needed, particularly DHL or some surgery, you can avoid. And I have experience of more than 12 cases that I have avoided a DHL procedure or a cannulation with this molecule, and I have all the data with me, and some of the already delivered also. So we have the evidence, but how you are using, that always matters. This is comparable with also provident iodine also for the wound healing or the dressing part. You can safely use this molecule, particularly in the cervical erosion also. That also evidence-based. And in ovulation induction protocol also, in my infertility practice, I am also using in ovulation induction practice. So there is lots of indication, but we have to explore. If we more and more explore this is a very low-cost molecule. Every patient can afford. In a low socioeconomic status, you can be used. But how we can explore, that always matters. So in IVF practice also, I am using this. In menopausal symptom, the conference is basing upon the menopause. Then this is in menopause age group of patients from the vaginal rejuvenation. Lots of indications are that we can use this molecule. Then what is next? What is next about regenerative medicine? Everyone talk about this is PRP, stem cell. I am telling you something new that we have started first time in Odisha, and that is called exosome. What is exosome? Exosome is 100 times better than PRP. And we are regularly using in thin endometrium. We are using in the poor ovarian reserve because our concept is a own biological child. If you are giving a donor child to any couple, you no doubt you are giving a child, but you are never give a satisfaction to the couple. My concept always that I give a child their own biological child. Maximum time we will try that we can increase the AMH level, or the agiospermia cases we can get more number of sperms so that we can give their own biological child. Then you can give the satisfaction to the couple that you have given a own biological child. So lots of indication you can use, ovarian rejuvenation, endometrial repair, male infertility. And in male infertility also I am using this molecule. What is exosome? Exosome is like a cargo. Like you are ordering some fruit from the Zomato. Then the food is delivered to you. Similarly, this exosome is the cell-to-cell communication is there by mRNA. What is the message you want to deliver? That simply deliver to the targeted area and you get the result. So it is cell-free. Exosome is cell-free, low risk of immunity, no tumorigenicity, which is there in stem cell. So we have to explore more on this area. We have first time started, I think in Eastern India, the first time we have started exosome and getting the best result. And in also some cases like in poor ovarian reserve, before IVF also we have done, and they are also beta HCG positive. So this is the exosome machine we have started. And also Dr. Ipsita using lots of indication, particularly in poor ovarian, in case of skin condition, in hair, and also in case of non-healing ulcer. So this is the male infertility patient exosome therapy, followed by I have done this TISA procedure. Can you play the video? The time. Video, please. So there are lots of indication that we can use this molecule. This is TISA procedure normally we do in our setup. After post-exosome therapy, first time that we are not able to get the sperm, and after the TISA, then we got the sperm, and we are happy that we can give them this couple their own biological child. That should be, as a fertility specialist, our motto should be there. In very poor ovarian reserve, 0.2 AMH, how we can rejuvenate the ovary and give them a baby by their own egg. Because we are discussing about the perimenopausal age group. Because the upper age limit of the fertility in case of a ART law is up to 50 years. So in 50 years, a 45-year woman is coming to you. How can you give their own biological child? This is the concept we can deliver each and everyone so that this can be propagated. This regenerative medicine should be propagated to each and everyone. This is how the TISA we do. This is called the energy-based device we normally do in our practice. Just a small video of 2 minutes only, then I will conclude. Play the video, please. This is in regenerative medicine practice. Normally, we use lots of indication. We had discussion about the stage urinary incontinence was there. But in initial stage, we normally do the energy-based device we used to do. Please play the video. So this is the procedure. This is called the gyno laser. Normally, we do in cases of sexual dysfunction, in stress urinary incontinence, in lots of cases of severe vaginal infection, vaginal rejuvenation cases, we normally use this. Due to time constraint, I am not able to see the all videos. And lastly, this is the all mechanism. What I am telling, everything is evidence-based. You go and search in the different Google Scholar, you will get lots of articles on this gynecology and everything, but how you are practicing. And my last slide, with the permission of my, this is some of the videos normally we use in case of gynecology, in vaginal rejuvenation cases, and along with the combine this human placental extract along with PRP, so that we get the best result. This is called the holistic approach. Combined along with counseling, along with everything we combine, and lots of indications are there. And we have buffet of lasers, like more than 12 lasers. We can go all indication, that in for vaginal rejuvenation, we can go for hirsutism cases, in pigmentation cases, lots of lasers are there that can be used to justify this group of patients. And this is called in this, how this gynoderma connection is there. This is related to, we do lots of buttocks cases also. Lots of patients coming with a vaginismus. They are not able to have a successful intercourse. We have done more than 30 cases of vaginismus cases. They are successfully conceived also by giving the buttocks treatment. This is how this buttocks is done. I am not able to show you the whole video because of time constraint. And this is how we used to do the buttocks therapy. And we are giving the best result along with the serial dilator, and we are combined this with the Kegel chair. And we are also happy that first time we have started the Kegel chair therapy in our center, and we are getting best result in dyspareunia cases, in male patient also in erectile dysfunction, and also premature ejaculation, we are getting the best result. So thank you all my respected teachers, the audience, and we are using this human placental extract in lots of indications. These are some of the indications you are using, and for lichen sclerosis, atropicus, and also in atrophic vaginitis also you are using this molecule, you are getting the best result. And also you are using particularly, my wife, Dr. Ipsita, also using particularly in non-gynecological cases like a acne scar. This is also best result we are getting. So lastly, let's transform women's life with advanced aesthetics, empowering women and redefining the feminine with the confidence, with the wellness. And lastly, few words from my teachers, my mentor. To this, I will conclude. Volume, please increase the volume.
Link between dermatology and gynecology. And I don't know whether the link was decided after knowing this. Ipsita married Sakti or Sakti married Ipsita. But ultimately I knew that there is a birth of a new division called gynoderma. Gynoderma is a subspecialty which has given birth today in the month of January 2025. There are various terms like aesthetic gynecology, reconstructive surgery, rejuvenation, and regenerative
medicine. This is some of the word of blessing by our mentor when this unit was inaugurated. And this is where conducted lots of such activity. Lastly, also we conducted this Gynec Aesthetic Congress for this dimension, and with the conclusion message to everyone. This all regenerative medicine practice, starting from human placental extract, PRP, stem cell, exosome. This is a powerful regenerative biologics, safe, affordable, effective, enhance the natural healing, and synergizes the other genetic therapy. Thank you all.
Thank you, Sakti, for your nice deliberation. A placental extract was used last, I think, into 92, 2000.
Yes, sir.
Then it was vanished.
Yes, sir.
Because
David,
then
yeah,
you have started, I think this has been gaining popularity due to scarring of the skin, especially
Yes, sir.
after having multiple cesarean section. Usually why this has gained the popularity? Because it prevents adhesion.
Yes,
it
sir.
leads to less collagen formation. That's why that prevents scarring initially. Nowadays, I think that concept has, because most of the cases, because of transmission of HIV and hepatitis, placental extract was not purified at all. Nowadays, they are again purifying it and reintroducing it in a newer way.
Yes, sir.
So that's why I think PRP, exosome, placental extract, that is some role.
Yes, sir. The combined therapy
But
always.
research is lacking, and multiple, I think you have to publish so that,
Yes, sir.
Otherwise it is an investigational stage.
Thank you, sir.
Thank you.
Thank you, ma'am.
Dr. Deepa, is there a fourth speaker is there? No. So I think we will conclude. So this was the last session. Last speaker.
Now I request our experts to felicitate our speakers for this session. I request Dr. Hepzibah and Dr. Gitanjali Retha Madam to felicitate our experts for this session. Again. For today, the academic session is over and it was very fruitful and successful for all. So now it's over to Dr. Jitendra Behra sir and Dr. Shakti Kumar Tripathi sir for the cultural program. I request all the delegates and distinguished faculties to please positively join for meditation session at tomorrow 7 a.m. I again request all the distinguished faculties and delegates to please join us tomorrow at 7 a.m. Kali to Kali 7 a.m. to tomorrow kaili sir. For the meditation session, I request all delegates and distinguished faculties to join tomorrow at 7 a.m. at Suraj Mahal. Now it's over to Dr. Jitendra Behra for cultural program.
चेंज कर दिया हेलो 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 Astos. Hello, 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 hello. Hello, 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 hello. Good evening, everyone. So, after a full day of hectic academic session, let us do some entertainment and relax ourselves. So, without wasting much time, we will begin with our one of the bhajan by our river teacher, our beloved teacher, Professor Dr. Gangadhar Sau, because always like we will say Jagatara Natha, Jagannatha. So like Tumeva Mata, Tumeva Pita, Tumeva Bandhu, Tumeva Sakha. So please welcome Dr. Gangadhar Sau, sir, for his melodious voice. And I think sir will definitely create a sacred atmosphere and some holistic atmosphere over here. So welcome you, sir.
Thank you, Jitendra. So I was the opening bat in the morning. So hopefully, with my good luck, the session has ended without any problem. So similarly, on the entertainment program, thank you for giving me the chance to open the session with a devotional song on Jagannath Janan. To pray Lord Jagannath before anything. So that is rather not only an opportunity, but it is a privilege and honor for me. So ମୁଁ ଯୋଉଟା ଗାଇବାକୁ ଯାଉଛି এটা ଓଡ଼ିଆରେ ଗାଇବି ସେ ଜଗନ୍ନାଥ ଜନାଣର ଶୀର୍ଷକ ହେଲା ମିଛେ ସିନା ମଲି ଡାକି ମିଛେ ସିନା ମଲି ଡାକି ଡାକି ତାର ଅରିଜିନାଲ ସିଙ୍ଗର ହେଲେ ଭିକାରୀ ବଳ ଏବଂ ମୁଁ ତାଙ୍କରି ପଥରେ ଚାଲି এই ଗୀତଟି ଗାଉଛି ମିଛେ ସିନା ମଲି ଡାକି ଡାକି ହେ ଚକାଖି মিছে সিনা মলি ডাকি ডাকি হে চকাখি শুনিবাকু দুঃখ মোর কানত কল পথর শকতি নাহি তুমর তারিবাকু দুঃখী হে চকাখি মিছে সিনা মলি ডাকি ডাকি হে চকাখি তারপরে কোন হেলা ডরি মরি লোক কহে তুমে দুঃখ হারি তুমে দুঃখ হারি আখি ছুঁই কহ দুঃখ হরিছ কাহারি প্রভু হরিছ কাহারি অতি অভিমান করি কুহাଉଛି ঠাকুরଙ୍କ ଉପରେ সত মু কহুছি বলি দেবী কোটি সাক্ষী হে চকাখি মিছে সিনা মলি ডাকি ডাকি হে চকাখি তারপরে রাধাଙ୍କୁ কেমতি ঝুরাই মারিଥିଲେ রাধাକୁ ঝুরাই তুমে মারিছ কি নাহি মারিছ কি নাহি করে যে তুমরি আস কান্দি মোরে সেই প্রভু कांदी मोरे से ही बखाणी बसिले तुम गुण सरीब कि हे चकाखी मिछे सीना मली डाकी डाकी हे चकाखी मिछे सीना मली डाकी डाकी हे चकाखी 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 चकाखी। ନାଇଁ 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 ସମ୍ବଲପୁରୀ ଗାଇପାରିବି ସମ୍ବଲପୁରୀ ଗାଇପାରିବିନି ମୁଁ ବର୍ତ୍ତମାନ ପୁରା ଜଗନ୍ନାଥ 22 ପାହାଚରେ ଗଡ଼ିବି। ଆଉ କିଏ ନେକ୍ସଟ?
So after a beautiful song by our beloved Ganga sir, now I would like to call upon our Giri sir, who is one of our legend teachers who taught us everything, and he's a very good singer. I'm quite confident that everybody will like his song. So I will like to request Giri sir to have a song over here. Thank you. अशोक भाई, दिलीप सर ना, हाँ, संबलपुरी सॉन्ग। So please give a big round of applause for Giri sir. He is going to sing एक प्यार का नगमा है। संध्या मैडम कुआडे गले सायरी टिके कुहंतु आसिकी मझिरे मझिरे।
कुछ भी नहीं, तेरी मेरी कहानी है, क्योंकि प्यार कुछ भी नहीं, तेरी मेरी कहानी है, एक प्यार का नगमा है। ला 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 ला, कुछ पाकर खोना है, कुछ खोकर पाना है, जीवन का मतलब तो आना और जाना है, दो पल के जीवन से एक उम्र चुरानी है, जिंदगी और कुछ भी नहीं, तेरी मेरी कहानी है, एक प्यार का नगमा है। तू धार है नदियाँ की, मैं तेरा किनारा हूँ, तू मेरा सहारा है, मैं तेरा सहारा हूँ, आँखों में समंदर है, आशाओं का पानी है, जिंदगी और कुछ भी नहीं, तेरी मेरी कहानी है, एक प्यार का नगमा है। ला 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 ला, तूफान तो आना है, आकर चल जाना है, बादल भी कुछ पल के छाकर ढल जाना है, परछाइयाँ रह जाती निशाना, जिंदगी और कुछ भी नहीं, तेरी मेरी कहानी है, एक प्यार का नगमा है, मौजों की रवानी है, जिंदगी और कुछ भी नहीं, तेरी मेरी कहानी है, एक प्यार का नगमा है, मौजों की। थैंक यू, थैंक यू।
Thank you, sir. I think we should give a standing applause for sir. Such a nice say means आपने तो क्या बोले आपको दीवाना बना दिया sir. So now we are going to have our most awaited dance. So ladies and gentlemen, we now present to you one of the India's most graceful and ancient classical dance form, Odissi. So Odissi, the pride of Odisha, known for its fluid movements and the iconic Tribhangis posture. So Odissi beautifully combines devotion, rhythm, and expression rooted in the centuries-old temple tradition. So these dance forms bring alive stories of spirituality, culture, and timeless elegance. So please sit back and enjoy the enchanting performance of the Odissi dance group from Odisha. Please give a big round of applause for the Odissi group team. Yeah.
कदाचित् कालिन्दी तटविपिन सङ्गीत करवो मुदा भीरि नारी वदन कमल स्वाद मधुप वदन कमल स्वाद मधुप रमा शम्भु ब्रह्मा सुरपति गणेश चितपदो जगन्नाथ स्वामी नयन पथगा भवतु कालंदी तट विपिन सुमधुर संगीत गोपी जन मोहित बदन कमल मधुपान रमा शंभु ब्रह्मा सुरपति पूजित जनार्दन वामे मुरली साजे कटि कटे पित पट नयन कटाक्ष पत सिरे सिखि पूछ विराजे कर्तक धे धिंद तत 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 धे वृंदावन लीला कारण तद्रिमि तकद्रिमि तद्रिमि तद्रिमि द्रिमि नीलाद्रि मंडन सुरेंद्र वंदन दया सिंधु बंधु सिंधु सुतमन मोहन भद्र सुभद्र सुदर्शन संग रथारूढ़ गच्छन गिड़गिड़ी तथा गिड़गिड़ी धैया ता गिड़गिड़ी तथा गिड़गिड़ी धैया ता गिड़गिड़ी तथा गिड़गिड़ी धैया शिरसी शिखी पुछौँ घटी तटे बुझे सके बेणु शिरसी शिखी पुछौँ घटी तटे दुकुलौँ नेत्रान्ते सहचर कटाख्यौ विदधते सदा श्रीमद् वृन्दावन वसति लीला परिचय सदा श्रीमद् वृन्दावन वसति लीला परिचय जगन्नाथ स्वामी नयन पथगामी भवतु मे पारावार सजल जलद श्रेणी रुचिरो रमावाणी राम स्फुरदमल पद्मो भवमुखी सुरेन्द्रैराराध्य श्रुतिगणशिखा गीतचरितो जगन्नाथ स्वामी नयन पथगामी भवतु मे भवतु मे भवतु मे रथारूढो गच्छन् पथि मिलित भूदेव पटणे रथारूढो गच्छन् पथि मिलित भूदेव पटणे स्तुति पदुर्भावौ प्रतिपदमुपकन सदया स्तुति पदुर्भावौ प्रतिपदमुपकन सदया दया सिन्धु बन्धु सकल जगता दिगिन धा धे गृधिनक धा धा धिनि तक धे गृधिनक धा धा धिनि तक धे गृधिनक धा धा धिनि तक धे तिंग राग दिगिन धा धा 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 तिंग धे गृधिनक धा धा धिनि तक धे गृधिनक धा धा धिनि धे गृधिनक धा धा धिनि तक धे तिंग धाग दिगिन धा धा 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 तिंग धाग दिगिन धा धाग दिगिन धे 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 तिंग
ना वैपार्थं राज्यं न च कनकमाणिक्यविभवम् राजेऽहं रम्या सकलजनकाम्या वरवधू न राजेऽहं रम्या सकलजनकाम्या सदा काले काले प्रमथपतिना गीतचरितो सदा काले काले प्रमथपतिना गीतचरितो जगन्नाथ स्वामी नयन पथगामी भवतु मे हरत्वं संसारं दूततरमसारं सुरपते हरत्वं अहो दीननाथ निहितमचलं निश्चितपदं जगन्नाथ स्वामी नयनपथगामी भवतु जगन्नाथ स्वामी नयन पथगामी भवतु मे जगन्नाथ स्वामी नयन पथगामी भवतु मे जगन्नाथ स्वामी नयन पथगामी भवतु मे भवतु मे भवतु मे भवतु मे
धैग तिंग तकता तगड़ तिंग तकता धैग तिंग तकता तगड़ तिंग तकता धैग तिंग तक तगड़ तिंग तक तगड़ तिंग तक तगड़ तिंग तक धैग तिंग तक तगड़ तिंग तक तगड़ तिंग तक तगड़ तिंग तक धैग 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 तक तगड़ तिंग तक धैग 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 धा 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 गति थे धा गति थे
जगन्नाथाष्टकं पुण्यं जः पठेत् प्रयतश्रुतिः सर्वपाप विशुद्धात्मा विष्णुलोकं स गच्छति इति श्री शंकराचार्य प्रणीतं श्री जगन्नाथाष्टकं संपूर्णम्।
Wow, mind blowing, mind blowing. What a fabulous performance. So now, after this, our traditional Odissi dance, now we are going to, it's a time to invite our guest faculties. And I think this menopause is just a stage. And like us, they are going to present through a skit that menopause movements, hormones take a holiday. And to present, we have 4 gorgeous, dashing, dynamic ladies. So please big a round of applause for them. And they are Dr. Jamuna Devi, Dr. Meeta, Dr. Ambuja, and Dr. Sandhya. So madam, please welcome to stage. So stage yours.
So welcome all for this skit, Menopause Moments, Hormones Take a Holiday. Now the stage is yours, madam.
Thank you so much. Actually, this skit is just representing what happens in day-to-day life. So we have husband and wife, and a junior doctor and a senior doctor. So the first scene is at home. So let's see what happens. Munni, where are you? कहाँ हो?
इधर ही हूँ। क्यों ऐसा जोर जोर से पुकार रही हो? मुझे इतना गर्मी हो रहा है और मुझे ऐसा हो रहा है, कुछ फैन नहीं, कुछ एसी नहीं, ऐसा लग रहा है एसी तो 18 में है, लेकिन बहुत गर्मी है, कुछ दिल में ऐसा धड़धड़ हो रहा है, कुछ समझ में नहीं।
बाप रे, क्या करें? कितने दिन से बोल रहे कि एसी अच्छा है, इलेक्ट्रिशियन को बुलाया, ठीक करवाया, फिर भी इनका कंप्लेंट कभी बंद नहीं होता कि एसी ठीक नहीं है। अब ये क्या करें, पता नहीं क्या हो रहा। ऐसे क्यों सोच रहे मुन्नी? चलो अपन डॉक्टर के पास जाएं, नहीं साइकियाट्रिस्ट के पास चलें? ठीक है, ठीक है, ठीक है। सो चलो फिर अब डॉक्टर के पास चलेंगे, ठीक है? चलो, कम। नमस्ते डॉक्टर साहब।
नमस्ते नमस्ते नमस्ते।
ये मेरी मिसेस है मुन्नी। अब इतना परेशान है पूछो मत, इसीलिए आपके पास लेके आए। चलो आप बोलिए क्या प्रॉब्लम, अब बताइए डॉक्टर को क्या प्रॉब्लम है
आपका? नमस्ते।
अच्छा नहीं दिखते कि क्या मतलब है?
Spot diagnosis, vasomotor symptoms, estrogen playing havoc, system, thermoregulatory system.
ये क्या होता है डॉक्टर साहब?
ये आपके लिए नहीं है, ये मेरे खुद के लिए है। थैंक गॉड मैंने वो CIMP एग्ज़ाम लिखा है। कुछ सीनियर डॉक्टर आए जब तक मैं कुछ तो हेल्प कर सकती हूँ, कुछ मदद कर सकती हूँ। बताइए आपको नींद वगैरह बराबर आती है? नींद बराबर नहीं आती है।
अब क्या कंप्लेन करें डॉक्टर साहब, बोलते हैं कि तुम सोते रहते, खर्राटे मारते रहते और मेरा कुछ भी नहीं देखते।
तो आप इनकी क्या मदद कर रहे हो?
सुबह उठ के चलो, वॉकिंग चलो,
हेलो
बोलते नहीं
डॉक्टर
चलते।
मीता।
हेलो नमस्ते मैडम, नमस्ते।
ये क्या चल रहा है? ये बच्ची क्यों रो रहे हैं? अच्छा, क्या समझा रहे बच्ची को?
मैम, ये तो स्पॉट डायग्नोसिस है, मेनोपॉजल सिम्टम्स। थैंक गॉड आप आ
Wow,
गए।
I'm so glad that you could diagnose menopausal symptoms. I know you recently passed SIMP exam. ताली ताली ताली, SIMP exam सब लोग करके आना। मेरी जूनियर असिस्टेंट इतना अच्छी है, she could diagnose menopause. तुम చెప్పండి क्या डायग्नोस कर?
क्या डायग्नोसिस मैडम, पहले हमारा ट्रीटमेंट करो, वो एग्जाम बाद में रखो।
Don't worry, we are going to solve because she has taken all the history from you. Now I know it is the menopause problems. हाँ, मैं समझाती हूँ तुमको। ऐसे चिड़चिड़ापन छोड़ दो, पहले वो छोड़ो।
दवाई दे रहे आप? कुछ दवाई दे रहे चिड़चिड़ापन का?
हाँ, दवाई यही है, तुम भी उनको मदद करना। अभी तक तुम्हारे साथ बैठ के तुम बैठे तो कॉफी लेके आए, टी लेके आए, सब करी ना। अभी उनको तुम करो।
मैडम, सुबह उठ के हम हेल्प करने की कोशिश करते, मगर हमारे उठने से पहले ही ना उठ के जाते और सब काम कर लेते। अब क्या करना बोलो आप?
संध्या, मैं क्या समझाऊँ? मैं जाने के बाद मेरे असिस्टेंट समझाती तुमको, उनको मेरे से भी ज़्यादा मालूम है। उन्होंने रिसेंटली पास वो सिम्प एग्ज़ाम है। ये क्या समझा रहा मैं? यू वांट लाइफस्टाइल चेंजेस, वो पहले का है। हाँ, वही बोलती हूँ मैं, तुम अच्छा बैलेंस डाइट खा लो। बीच बीच में वो क्या बोलते हैं, वो मुर्कू खाए,
कुरकुरे खाए,
वो सब छोड़ दो पहले, नहीं तो ये ऐसा मोटी बन जाते।
मैं वॉकिंग को चलो बोले तो नहीं चलते मैडम सुबह में।
सुनो, नहीं उन्हें भी काम करने को। मोहनलाल, तुम बाहर का काम जरा कम करो और बाहर का काम अंदर नको लेके आओ। उनके साथ हर रोज़ वॉकिंग लेके जाओ और उनके साथ क्या है, खेलना। आप चेस खेलो, नहीं तो और कुछ कैरम्स खेलो, कुछ ना कुछ करो।
मैडम, आप समझ में आया?
मुझे मालूम है, पूरा डिलीवरीज मेरे पास हुई है, उन्होंने कब से मेरे पास आ रहे हैं। उनका शौक है डांस करने का,
तो डांस क्लास जाओ बोलो मैडम।
हाँ, वो डांस
मैं मना नहीं कर रहे।
इतना कमा रहे डांस को, जाने को क्या है तुमको?
तो अब मेरे को समझ में आया मैडम।
संध्या, मैं मोहन को कितने सालों से वो बच्चा बहुत अच्छा है, वैसे चिड़चिड़ाने की ज़रूरत नहीं है, उन्होंने नहीं करता। ये पूरा तुमको ये मेनोपॉज की वजह से है। तुम फिक्र नको करो, ये फॉलो ऑल दिस थिंग्स। वो ईस्ट्रोजन हार्मोन्स देने का है, ईस्ट्रोजन हार्मोन्स देने का है। वो मीता समझाती, मीता समझाओ उनको।
हाँ, पहले जैसा मैम बताए, आप ये बताइए मुझे कि आप खाने में दिन में क्या क्या खाते हो, इसके बाद उसमें अगर से जो जो चेंजेस लाना है, और आप उनके साथ वॉकिंग अगर से सुबह गए तो कितनी अच्छी बात है। आज का आप लेक्चर, आप नहीं थे सुबह के लेक्चर, बड़े अच्छे डॉक्टर त्रिपाठी ने बताया कि वॉकिंग से सब कुछ दूर होता है, मेडिसिन की ज़रूरत। चलो, तो हाँ,
अब तो कभी कभी चलो कहीं चले जाएंगे, ट्रिप को जाएंगे, वैसा बोले तो भी नहीं आते।
संध्या, आप लोग ये गलत सोच रहे नहीं। कभी भी वो उम्र हो गया बोल के हस्बैंड से दूर रहने की ज़रूरत नहीं है। सेक्स में पार्टिसिपेट करना और वैसा नहीं, नॉट ओनली फॉर योर फिजिकल हेल्थ, वो मेंटल हेल्थ अच्छा रहता, सुकून रहता, सब रहता। सो यू गो फॉर हनीमून, सेकेंड हनीमून जाओ,
थैंक यू मैडम, थैंक यू।
उनके साथ अच्छा मजा करो, देन यू विल मोर देन दैट डोंट फॉरगेट टू टेक द मेडिसिन। पांचस्टान बोल के, फेमोस्टान बोल के नया मेडिसिन आया है, इतना अच्छा है, तुम खाए तो कल से तुम ऐसा कूद कर भागते।
थैंक यू मैडम, थैंक यू मैडम। मेरे को अब समझ में आया कि इलेक्ट्रीशियन को नहीं बुलाना, हॉस्पिटल को आना, मेनोपॉज क्लिनिक अटेंड करना,
सुनो,
and
ये
specialist को
पूरा
दिखाना।
सुनने के बाद मेरा फीस नहीं भूलना।
ओ दे देते मैडम, फीस क्या आपको गिफ्ट भी लाके दे देते।
नमस्ते।
सो
आज तो जीने का
मुझसे
तमन्ना
तो प्यार
है।
बढ़ा कि मैं एक बादल आवारा, कैसे किसी का सहारा बनूं कि मैं खुद बेघर बेचारा।
इसलिए तुझसे मैं प्यार करूं कि तू एक बादल आवारा, जन्म जन्म से हूँ साथ तेरे, है नाम मेरा जल की धारा।
इतना न मुझसे तू प्यार बढ़ा कि मैं एक बादल आवारा,
जन्म जन्म से हूँ साथ तेरे, है नाम मेरा जल की धारा।
we are all cool and redefining the life.
Thank you for making a part of it. This was spontaneous, no, not a single pre-run. So this was a spontaneous one over here. Thank you.
Excellent presentation by Team Hyderabad. Give them a big round of applause. Team Hyderabad is rocking.
The script was written by Dr. Jamuna.
So next performance is our culture, our tradition. That is a Durga Stuti. Where previously we have seen the Jagannath Stuti. Then we see the Durga Stuti in Odissi.
Two, one, 1, 2, 1, 2, 3, 1, 2, 1, 2.
शिखमपि करे रुद्र वहन्ति त्रिनेत्र सिंहस्कन्धा धीरूढा त्रिभुवनमखिलम् तेजसा पुरयन्ति ध्याये दुर्गम् ध्याये दुर्गम् जयाख्यं त्रिदेश परिवृता सेवितां सिद्धिकामे सेवितां सिद्धिकामे सेवितां सिद्धिकामे सिन्दूरधारिणी कुन्तलम्बिनी दुर्गति तारिणी हारी मते सिन्दूर सेविनी कुन्तला बन्दिनी कर्पूर गन्धिनी गन्धयुक्ते कर्पूर गन्धिनी गन्धयुक्ते गदभासिनी थन थन गामिनी रण रण सोहिनी रण रण के रण रण सोहिनी रण रण के रण रण सोदिनी रण रण के जय जय दुर्गति तारिणी जय जय भवानी मानिनी जय जय पालिनी दानिनी जय जय दुर्गति तारिणी जय जय भवानी मानिनी जय जय पालिनी दानिनी जय जय पालिनी दानिनी जय जय पालिनी दानिनी जय जय पालिनी दानिनी
मैं थोड़ी देर जी तो लूं, नशे के घूंट पी तो लूं, नशे के घूंट पी तो लूं। अभी तो कुछ कहा नहीं, अभी तो कुछ सुना नहीं, अभी ना जाओ छोड़ कर कि दिल अभी भरा नहीं। फिर और एक रिक्वेस्ट और है, हो चांदनी जब तक रात देता है हर कोई साथ, तुम मगर अंधेरों में ना छोड़ना मेरा हाथ। जब कोई बात बिगड़ जाए, जब कोई मुश्किल पड़ जाए,